Hello everyone, very warm welcome to all of you guys. Very good evening. All right, myself Dr. Vaibhav Jain, and today we are going to do a physiology session, and we are going to incorporate. I've incorporated all the important topics that has been asked previously in your NEET PG and FMG examination. So it is going to be fruitful for all the people who are looking for NEET PG as well as FMG, right? Class will be 3 to 4 hours. I've already shared the PDF in our Telegram group. Let me share it again. In my Telegram group, you can join and you can get the PDFs. Just give me a moment. Yes, it is shared now. So you can get the PDF. This is our FMG booster dose program, and I'm very excited to teach you guys the subject of physiology. This is the physiology. Today we are going to do physiology, right? This is updated schedule that you can take a screenshot or you can download, right? Here we have certain changes, right? So this is the updated schedule that you need to follow, right? All right, so before beginning, the quote for the day is going to be: behind every high achiever there is a story of a hard work and countless study sessions, right? I know you have already put in your hard work and countless study sessions you have done, right? So this is going to be a fruitful session. Whatever you have read from whatever source you have read doesn't matter. I'm going to give you all the important information. What I've done, let me just introduce this thing, right? I've taken all the systems accordingly, right? According to our workbooks, right? Oh, these are going to be the system. We will learn about the general physiology, body fluids, excretory system, endocrine, muscular, CVS, respiratory, reproductive system, GIT, and we will end up with the CNS and certain miscellaneous topics. So all the important questions that has been asked previously in your different examinations, be it NEET PG, be it FMG, जो भी questions आए हैं, I have taken all those questions and I have kept some topics. तो वो सारे topics हम लोग discuss करेंगे, and I'll also make you understand how to apply those things, right? So this is how we are going to do all the things. And in last we are going to do certain one liners. These are the one liner questions that has been asked previously, है ना? जो भी FMG में आया, NEET PG में आया, सब कुछ करेंगे. So let's begin with the first thing that we are having. Class is based on mixed things. It will be having MCQs, it will be having TND basis also, and also certain one liners which are definitely going to be your PYQs, है ना? And I am also going to teach you certain topics which are important for your examination, है ना? तो सारी चीज़ें हम लोग करेंगे. The link for Telegram, you can download the PDF from here, right? This is my Instagram and YouTube channel in case if you want to connect further, right? All right, are you guys excited? Do let me know. Physio is going to be good after this particular session. You will love physiology. I'll try to make you understand. कुछ भी नहीं पढ़ा तो भी अच्छा, ठीक है? तो भी कर लेंगे. All right, guys. So let's begin. The first thing we are having, we're starting it off with the general physiology. तो क्या क्वेश्चन है? First, try to solve this question. I just want you guys to be interactive. तो आंसर करते रहेंगे, right? Try to solve this particular question we are having in front of us. So there is a patient who is coming to your OPD. A 7-year-old boy presented to the OPD, and mother stated that he is having difficulty in rising from the floor, right? On examination, his calves are hypertrophied. Hypertrophy of the calf is given. Which of the following substance defect or deficiency is the cause for patient's condition? Yes, definitely. Up ki baar definitely we will get 200 par. Right? So यहाँ पर क्या पता चल रहा है? What is going to be your answer? How many of you think the answer is going to be A, B, or C, or D? Try to answer. Right? So whenever you will see the word hypertrophy of the calf muscle, hypertrophy of the calf muscle is very characteristic of one thing. What is that one thing? Muscular dystrophies, beta. Whenever you will find the keyword in the question, be it medicine question, be it your physiology question, जब भी आप देखोगे pseudo hypertrophy of the calf muscle, this is going to be telling us about some kind of muscular dystrophy, right? What is the muscular dystrophy we are having here? And this particular thing, difficulty in rising from the floor. What is that? Difficulty in rising from the floor is very characteristic sign. This sign is known as what? This sign is known as what beta? This sign is known as Gower sign, है ना? तो pediatric department में when the patient is going to come, we will ask the patient to sit down and try to get up again. But this patient is having some kind of muscular dystrophy, एक muscle की dystrophy है. This is known as Gower sign. ये बच्चा एकदम से खड़ा नहीं हो पाएगा. This boy is going to take the support of the body. This is known as Gower sign, right? And this is characteristic feature of what? Duchenne muscular dystrophy. So we can have two important things. What is your diagnosis? We can have Duchenne muscular dystrophy. We can also have what? दो चीजें हो सकती हैं. Duchenne हो सकता है और it can be Baker's muscular dystrophy. So what is the difference between Duchenne and Baker's? If there is a complete loss of dystrophin, what is the protein involved here? This is going to be the dystrophin is going to be the answer. If there is complete loss of dystrophin, अगर पूरा loss है, this is going to be complete loss will lead to Duchenne muscular dystrophy, whereas if there is a partial loss of dystrophin will lead to what? Baker's muscular dystrophy. क्या difference आएगा सर? बंदा ज़्यादा दिन तक जिंदा रहेगा. If the patient is having Baker's muscular dystrophy, he will be living a little longer, right? If he is having a Duchenne muscular dystrophy, he is going to die little sooner, right? So this is what is going to be the difference. Sir, how to rule out the options? What are the options we are having? Look here, beta, right? The first option we are having is about the dynin. What is this dynin? What is this dynin? Dynin is responsible for what? This is going to be what? Dynin is responsible for reverse axonal transport, beta. Dynin is responsible for reverse axonal transport. Sir, ये axonal transport क्या होता है? What is this axonal transport? So when you look at a neuron, suppose this is a neuron. So this neuron will be having this particular thing. This is known as cell body. This particular thing is known as axon, and here you will be having the synapse. Here you will be having the synapse. तो ये axonal जो transport है, everything is transferring from the cell body towards the synapse, right? This is known as forward axonal transport, and this forward axonal transport is due to kinesin, right? Due to kinesin. But the examiner is fond of asking this question: dynin is responsible for what? Retrograde or reverse axonal transport. Sir, इसका clinical implication क्या है? There are going to be two important diseases, beta. What are two important diseases which are following this pathway? First one is going to be tetanus. Another one is going to be रेबीज. बोथ ऑफ देम आर वैक्सीन प्रिवेंटेबल डिजीजेस, है ना? बहुत ही कॉमनली यूज, हम लोग इसकी वैक्सीन बहुत ही कॉमनली यूज में लेते हैं. दिस इज गोइंग टू बी व्हाट? tetanus vaccine and rabies vaccine. Tetanus, you need to remember one more advancement that we are having for this particular examination. पहले हम लोग tetanus के लिए क्या देते थे? Earlier we used to give tetanus, right? TT. But now we are giving what? TD. अभी हम लोग tetanus और diphtheria दोनों को cover कर रहे हैं. This is also from PSM. You can remember this, right? So this tetanus is due to Clostridium tetani. This is a bacteria, Clostridium tetani. Right? Clostridium tetani is a bacteria. Whenever this bacteria will come in contact with your body, right? क्या होगा? Just try to understand this thing. You are driving a bike, you are having road traffic accident. क्या होगा? This bacteria is going to have certain spores. When these spores will come into contact of your body, they will try to enter into your body. ये body के अंदर enter करेंगे. But how they are going to travel? With the help of dynin. So they will travel in the retrograde manner. यहाँ पर इंजरी हुआ है, यहाँ पर कट लगा, रस्टेड आयरन, सोइल, राइट? यहाँ पर कट लगा. दिस मूवमेंट इज गोइंग टू बी व्हाट? दिस बैक्टीरिया विल ट्रेवल इन द रेट्रोग्रेड फैशन विद द हेल्प ऑफ व्हाट? डाइनिन. और कहाँ जाके स्टक करेगा? ऑन योर स्पाइनल कॉर्ड, एंड इट विल कॉज व्हाट? टिटनस. टिटनस में क्या होता है? राइसिस सार्डोनिकस विल बी देयर, ग्रिम लाइक फेसेस विल बी देयर, राइट? यू विल बी हैविंग व्हाट? ट्रिस्मस medial pterygoid muscle will get involved. You will be having what? Certain specific posture like opisthotonous posture, right? These are the important things you need to remember. Rabies is due to which virus? Rabies is due to Lissa virus. Rabies will also have the same thing. You are having a bite of a dog. Now what will happen? This virus, basically Lissa virus, is going to travel into your body in backward direction. देखा होगा ना, hippocampus में you will find what? Negri bodies, right? Why? What are those Negri bodies? These viruses are going to travel in a retrograde fashion. ये उल्टा क्यों चल रहा है? With the help of what? Dynin. With the help of dynin. So dynin has got two important functions. What are these two important functions? It is responsible for reverse axonal transport. Two clinical implications that has been asked previously that you need to remember. One is tetanus, another one is rabies. ठीक है? Rabies is a 100% fatal disease, beta, right? One more thing you need to remember, if you are having mutation of this dynin is also responsible for what? Ciliary movement. It is also responsible for ciliary movement. और अगर cilia का movement नहीं होगा तो कौन सा syndrome होगा? Pure physiology question. This is going to be your Carter-Jenner syndrome. This is going to be your Carter-Jenner syndrome. And what happens in Carter-Jenner syndrome? What is the triad? Can anyone tell me what is the triad for Carter-Jenner syndrome, beta? This is going to be your triad for Carter-Jenner syndrome. So they can frame a question around this particular thing. They can write you Carter-Jenner syndrome include all of the following except, right? So what is going to be the thing? We are having not bronchitis, but it is going to be bronchiectasis. Second one is going to be what? Dextrocardia, right side heart. Because heart is formed in the right side, then it will travel with the help of cilia. ये travel करेगा cilia की मदद से and it will come on the left side, right? So this is going to be having what? Dextrocardia. And third one is going to be what? Sinusitis, right? You can also see infertility. Infertility can be there in the person, right? So this is going to be what? Ciliary movement. Cilia का function होता है चीजों को unidirectionally आगे फेंकना, right? So this is going to be responsible for unidirectional movement, ciliary movement, right? So ciliary movement is also due to dynin. So what questions they can ask you from dynin? These are the three important questions that has been asked previously, and we are done with this, right? The next important thing we are having is Dasmin. What is this Dasmin? Dasmin is an intermediate filament, beta. This is going to be an intermediate filament. It is a marker for sarcoma. It is a marker for sarcoma. So whenever you are having sarcoma, the Dasmin will be increased, right? For example, we have also learned about keratin. Keratin is a marker for carcinoma. है ना, हम लोग पढ़ते हैं cytokeratin 14, cytokeratin 20. These are the CK marker. What are CK marker? They are the marker for carcinoma. Dasmin is a marker for sarcoma. पैथो में भी पढ़ा होगा, right? Next thing we are having is laminin. What is this? Laminin is important. Laminin mutation will lead to a disease. If you are having mutation of this laminin, what is the disease you can have? This disease is known as progeria. Progeria. What is progeria? Pro means faster. Geria means geriatrics. Geriatrics मतलब क्या हो गया? Older aging, right? So this person is going to have what? Faster aging, or you can remember this is the person who is going to have laminin mutation will be having what? Premature aging, right? आपने मूवी देखी है? मूवी पा मूवी में क्या हुआ था? अमिताभ बच्चन is having what? This premature aging is going to be there, and this is due to laminin mutation, right? So in this particular case, what is going to be your answer now? We are covered with the four important topics. What is going to be your answer? This is going to be your dystrophin. Dystrophin is the largest one that is going to be present on the chromosome number 1. है ना? INI में एक बार पूछा था. This is present on the chromosome number 1, right? This Gover sign image has been given. These are the muscular dystrophy question they have asked earlier, and this Carter-Jenner syndrome is also very very important. तो हमारे 4 topic यहाँ पर cover हो गए. This is going to be the important things from this particular topic, right? Are you done with this? Did you understand? Give me a quick confirmation. कौन सी मसल? लेट मी आस्क यू वन क्वेश्चन. कौन सी मसल इन्वॉल्व होती है टिटनस में? जब ट्रिस्मस द पेशेंट विल बी हैविंग ट्रिस्मस, व्हिच मसल विल गेट इन्वॉल्व? Anatomy. This is a high time. Just try to answer me if you can. Which muscle will get involved? Which muscle of the mouth will get involved? That is going to be your medial pterygoid, beta. Remember, medial pterygoid is going to be involved in trismus, or jaw clenching will be there, right? This is going to be medial pterygoid, right? The next thing we are having is going to be your junctions. What are the junctions we are going to have? Let's try to understand these junctions. These are going to be your junctions. They have asked questions from here. We will solve the question. First we will try to understand what are the junctions we are having. तो body के अंदर एक cell है, this is another cell, and these two cells are going to combine with each other with the help of certain junctions in our body. Our body functional unit is going to be cell. तो बहुत सारे cell होंगे, multiple cells are going to be there. How they are connected? They are connected in different parts. They are connected with different junctions, right? So we have got these different kind of junctions we are having, and this is what we need to remember, the clinical implication, right? So tight junction, where do you find the tight junctions? They are going to be very tightly connected, They are going to be found in the blood brain barrier. They are found in the blood brain barrier. They are found in the blood testis barrier, right? So they will not allow the passage of certain things, है ना, कोई भी चीज इनमें से आसानी से नहीं गुजरेगी. They will not allow this, right? This is going to be something you will be finding in the tight junctions. तो examiner ने question पूछा, these tight junctions are because of what? These tight junctions are due to what? So remember, these tight junctions are due to two important protein. These are going to be your important one, claudin and occludin. Jahan bhi ho bolo, just speak along with me. What are the proteins which are responsible for tight junctions? These are going to be your claudin and occludin protein, right? Adherent junctions, ये टाइट जंक्शन ब्लड ब्रेन बैरियर बनाते हैं, इसीलिए हमारी सारी चीजें ब्रेन के अंदर नहीं जाएंगी. whatever drugs you are taking, some of them can pass, some of them will not pass. Why? Because of this blood barrier junction, right? Blood brain barrier. Another thing we are having is adherent junctions. These are going to be making your cadherins, like we are having E-cadherins that you are studying in pathology. These are going to be your adherent junction. They are also having what? Actin or cadherins are going to be there. What is desmosomes, beta? Desmosomes are going to be something which is going to bind your skin, right? And this is exam question. Last exam also they have asked this question. So we have got keratinocytes in the skin. This is another keratinocytes. ये दोनों keratinocytes को जोड़ने का काम कौन करता है? Who is going to bind two keratinocytes? Suppose this is one keratinocyte, this is another keratinocyte. They are binded together with the help of desmosomes. So this is going to be another thing we are having in the skin, in the epidermis. It is going to be your desmosomes. If you are having a disorder of this desmosome, अगर इसके against antibody बन गया, two things. One is from derma, another is from micro. But I am concluding here. There are two diseases that can happen. One has been asked previously in last exam, है ना, FMG last exam में January last exam they have asked this particular question. So what was that? If you are having antibody against this particular thing, this disease is known as what? This disease is known as pemphigus. क्या होगा बेटा? स्किन रप्चर हो जाएगी. दो सेल अगर साथ में नहीं है तो क्या होगा? स्किन रप्चर विल बी देयर. यू विल बी हैविंग पीलिंग ऑफ द एपिडर्मिस, राइट? अनदर थिंग, इफ यू आर हैविंग अ टॉक्सिन प्रोड्यूस्ड अगेंस्ट दिस पर्टिकुलर थिंग, अगर इसके अगेंस्ट टॉक्सिन बन गया, स्टैफ और इसके टॉक्सिन्स होते हैं, दीज आर गोइंग टू बी योर एपिडर्मोलाइटिक टॉक्सिन ए and epidermolytic toxin B, and this disease is going to cause what? Staphylococcal skin scalded syndrome, that is SSSS, right? This is going to be your important question. Last exam mein January, this they have given the image and the patient will be having what? Peeling of the skin. क्यों हो रहा है skin peel? Because there is toxin against what? Desmosomes. There is a toxin against what? Desmosomes. And what are the toxins we are having? कौन से टॉक्सिन्स है? ETA and ETB are the toxins. तो अगर ये desmosomes नहीं रहेंगे, what will happen? These two keratinocytes will fall apart, and this is going to give you a peeling of the epidermis. That is what you are going to see in the staphylococcal skin scalded syndrome, and pemphigus is a disorder that you will learn in the dermatology, right? These gap junctions are maximally present where? Gap junctions सबसे ज्यादा कहाँ होते हैं? सबसे fast conduction कहाँ चाहिए होता है? This is going to be present in your heart. This is going to be present in your heart maximally, and this gap junctions are made up of which protein? These are made up of connexin protein. Connexin is the protein which is going to make what? Gap junctions. And if there is a mutation of this connexin, this is going to cause a disease. Medicine में आप लोग पढ़ते हो, this disease is known as Charcot-Marie tooth disease. This disease is known as CMTD or Charcot-Marie tooth disease, right? So this is the important thing that we are having. Tight junctions, blood brain barrier made up of what? Claudin, occludin. Cadherins are going to be what? Adherent junctions. Desmosomes are going to be present in the skin. These are the two important questions they can ask, right? Gap junctions maximally present in your heart, and this is made up of what? Connexins, right? And if you are having mutation, this is going to be what? Charcot-Marie tooth disease is going to be there, right? Next one is going to be your hemidesmosomes. Beta, now these cells are going to be binded with each other with the help of desmosomes, but they need to bind to the basement membrane also. So how they are going to bind to the basement membrane? With the help of hemidesmosomal proteins. What are hemidesmosomal proteins? These are going to be your BPAG1, BPAG2, right? Integrin, plectin, multiple we are having, but these two are important one. And if you are having mutation of this particular, if you are having antibody formation against these two, this is going to cause a disease. This is known as bullous pemphigoid beta. This is known as bullous pemphigoid. Bullous pemphigoid, right? Derma mein padhoge, but these are the junctions that you need to remember. These are the various junctions which are present throughout our body, है ना? तो body में ये junctions present होंगे. These are the junctions. They are asking one question along with this particular thing, right? Next one is going to be what? About the signaling. About the signaling. What is signaling? These 5 junctions are clear to you. Now we will discuss about the signaling. What is signaling? Examiner ने क्या किया? INI set में भी same question पूछा, NEET PG में भी same question पूछा. They have given the image from here and they are asking you what kind of signaling is happening, right? तो कौन सी signaling है? Can you appreciate this is a something is coming from the same gland and working on the same cell, right? It is coming out from here and it is working here. This is known as autocrine. Autocrine type of signaling. Autocrine मतलब क्या हो गया? Self service हो गया एक तरीके से. You can call it as a self service, yes or no? So this is a autocrine kind of signaling, and the hormones or the things which are coming out from here are known as what? They are known as autocoids. They are known as autocoids. Pharma में आप एक चैप्टर पढ़ते हो, this is going to be what? Autocoids. So what are the things in the autocoid chapter? क्या क्या पढ़ते हो? नहीं बेटा, IgA antibody नहीं होगा. Here both of them you will be having what? Pemphigus and pemphigoid. Both of them will be having what? IgG and C3 deposits are going to be there. IgG and C3 deposits are going to be there. Linear IgA जो disease होता है उसमें क्या होगा? इन्हीं के against IgA antibody बन जाएगा. This is going to become linear IgA disease, है ना? तो ये याद रखना. इन दोनों में in these two particular thing you will be having what? IgG and C3 deposits are going to be there, right? So tell me, what are the autocoids you know? Autocoids are going to be what? What are the autocoids you know? Yes, you know, you have heard about what? Histamine. What is histamine? Histamine is autocoid. Histamine, serotonin, right? Your prostaglandins, all these things are coming under this particular chapter of autocoids. Histamine has got 2 important functions. It will cause vasodilatation. It will cause bronchoconstriction. है ना? Suppose we are having a mosquito bite. You know what happens after a mosquito bite? After a mosquito bite, the cell will release what? Histamine. And this histamine is going to cause what? Vasodilatation. And suppose this is a vessel which is going to dilate. Now what will happen, beta? Something will be coming out, increase in vascular permeability, and because of this increase in vascular permeability, you will be having something, edema is going to be there. पानी बाहर आएगा या accumulate होगा. This water will come and get accumulated. You will be having edema. You will be having redness. You will be having itching, right? So all these things are happening because of what? Histamine, right? And that is why you are taking what? Antihistaminics, right? So this is what is a autocoid. It is working on the same cell. It is working on the same level. It is working on the same location, right? So this is going to become a autocoid, and these glands are known as autocrine glands. We are also having endocrine and exocrine glands. We will discuss this thing further, right? The next thing we are having is about the gap junctions. These are going to be the gap junctions. Can you appreciate the things are moving through the gap junction? This is going to be the gap junctions. You just need to identify if they are going to give you the image. Same image is going to come and you are going to identify, right? Paracrine signaling क्या होता है? This is the question they have asked. What is paracrine type of signaling? Paracrine का मतलब क्या होता है? Para और juxta. The meaning of para and juxta is same. Juxta or para means nearby, right? So you heard about a gland, parathyroid gland. So nearby the thyroid gland is parathyroid gland, right? Juxtamedullary nephrons. Near the medulla is going to be what? Juxtamedullary nephron. So para means nearby. So you can appreciate this is something which is releasing from this particular cell and going to the nearby cell. The target is going to be nearby cell. This type of glands are known as what? Paracrine gland. These type of glands are known as paracrine glands, right? Lastly, we have got the endocrine type of signaling. Endocrine glands are going to release their substances directly into the blood. So if you find this type of thing, this is going to be a blood vessel is involved. This is going to be endocrine type of signaling, and whatever is coming out of endocrine glands, they are known as what? इनको हम लोग बोलते हैं हार्मोन. These are going to be your hormones, right? And lastly we are having exocrine glands also. These are the glands with the ducts. तीन तरीके की ग्लैंड्स इंपॉर्टेंट है. ऑटोक्राइन, यू ऑलरेडी नो, द थिंग्स व्हिच इज कमिंग इज नोन एज ऑटोक्विड्स. सेकंड वन इज एंडोक्राइन, दे आर गोइंग टू रिलीज देयर सब्सटेंसेस, दे आर नोन एज हार्मोन्स, they are going directly into the blood. And third one is exocrine glands, they are going to be having ducts and they are going to release their substance, and their substance is known as what? इनके substance को क्या बोलते हैं? This is known as juices, right? So we are having pancreatic juice, we are having bile juice. So anything which is coming through a duct is going to be what? Juices, right? Now try to solve this particular question. Which of the following junction is helping the cell to bind with the basement membrane? Which of the following junction is going to help the cell to bind the basement membrane? Yes, my dear students, try to answer. So we have already seen this. Now I hope you can answer this, right? Desmosomes, we have seen they are going to be present in the epidermis. They are responsible for binding the keratinocytes. Tight junctions are something you will be finding in the blood-brain barrier, blood-testis barrier. Gap junctions are maximally present in your heart. So answer here is going to be what? Hemidesmosomes. This type of question we are not going to make wrong. These are going to be your hemidesmosomes. What is the disorder? Now you try to tell me what is the disorder that can happen if there is a mutation, if there is antibody IgG and C3 deposit against this hemidesmosomes. What disease will happen? Try to answer. कौन सी बीमारी होगी against hemidesmosomes? Which disease will occur? Let me see how attentive you are. Which disease will happen? The next important topic they are asking from here is going to be your glut. Glut are very important. Very good. So, Sai Krishna, Dolly, Moni, Shagun, very good. It is going to be bullous pemphigoid. Bullous pemphigoid, right? So next thing we are having is about the glut transporters. So what are these glut transporters? They are asking this question, right? So glut are going to be what? Glucose transporters are going to be there, right? So what are these gluts? These are the examples of facilitated diffusion. आगे बताऊंगा क्या होता है facilitated diffusion. But for now, just believe me, glut and aquaporins. These are going to be the two things which are example of what? Which are the example of facilitated diffusion. ये examiner ने question पूछा, aquaporins are type of which type of transport? So answer will be what? Facilitated diffusion. Glut अगर पूछता है, they are going to ask you about the glut 2 is which type of transport, glut 3 is which type of transport. क्या answer करना है? This is going to be a type of facilitated diffusion, right? So we have got glut 1, glut 2, 3, 4, 5 like that. The important one that you need to remember, this glut 1 is going to be present in your RBCs and blood-brain barrier. They are having high affinity, means they will take up glucose very easily, है ना. दिमाग को glucose चाहिए, blood brain barrier में glucose चाहिए, RBCs they require lots of glucose, so they are having high affinity for the glucose. These are going to be the glucose transporters, right? Glut 2 is going to be present where? Glut 2 is present in your liver, kidney and pancreas. Important thing, and this is going to be what? This is going to be present in the liver, kidney and pancreas, right? Glut 3 is present in your neurons. They are also having high affinity, right? Glut 4 is going to be where? In the skeletal muscle, cardiac muscles and fat. You can also remember skeletal muscles, cardiac muscles and fat. These fat cells or adipocytes, these are the three locations where you will be finding what? Glut 4, very important, and they are going to be insulin dependent. That means when you will have the insulin, then only this glucose is going to be entering into the cells, right? So whatever you are eating will able to enter into your cardiac muscles, fat or skeletal muscle with the help of what? Glut 4, right? Glut 5, F for 5, you can remember F for 5, it is going to be responsible for what? Fructose transport. Glucose transport is due to these 4. Fructose transport is due to what? Glut 5. It is present in your intestine, right? These are your glut receptors, basic glut receptor that you need to remember, right? इसके बाद में आते हैं SGLT. What is SGLT? These are going to be your सोडियम ग्लूकोज लिंक ट्रांसपोर्टर्स. सोडियम ग्लूकोज लिंक ट्रांसपोर्टर मतलब सोडियम भी साथ में एंट्री करेगा एंड ग्लूकोज विल आल्सो एंटर along with that, right? What are these type of transport? These are going to be your secondary active transport. Okay, in the next slide I'll teach you what are these transports. और यहाँ से क्वेश्चन पूछते हैं, they will give you one pump, they will give you one receptor and they will ask you this is which type of transport, this is which type of transport. So how you will identify? So this SGLT is going to be what? Secondary active transport. SGLT क्या है? Secondary active transport है. What are the examples we are having? We are having SGLT1. One is looking like eye, so you can remember it is present in the small intestine. Majorly it is present in the small intestine, some part in the kidney, right? So this is going to be what? GLUT1. Sorry, SGLT1. This is going to be what? SGLT1. And examiner has given you one question. What is the role of giving ORS, right? Why we are giving 75, why we are giving the sodium and glucose together? अगर किसी को डायरिया है या कुछ भी है, right? Dehydration है. Why we are giving glucose and sodium together? Why we are giving? Because this is going to be the transporter which is going to absorb both the things together, right? So this is going to be, suppose this is your intestine, you are drinking this particular thing. So what will happen? The same amount of sodium will go inside, the same amount of glucose will go inside, and that is the reason behind giving ORS. You will find that same amount of sodium and same amount of glucose is going to be there, and this is going to increase the absorption of sodium. And we very well know this particular thing, wherever the sodium will go, what will happen? This water is going to follow, right? So water will also go inside the body, right? And this is the basis of giving the ORS. This is the question they have asked you previously from the pediatrics, from the medicine and physiology also, you can remember. This is the basis of giving ORS. So ORS में SGLT1 pump काम में आएगा. Even your grandmother know this particular thing, right? They are mixing what? Whenever there is diarrhea or something, what they will do, they will mix the salt as well as glucose together. Why? Because we are having SGLT pump for the absorption of the same thing, है ना? तो इनका absorption किससे होगा? SGLT pump से होगा, and sodium and glucose, both the things will come together, right? What about this SGLT2? They are asking SGLT2 inhibitors, right? So this SGLT2 is going to be present in the kidney. ये किडनी के अंदर होगा और इसका फंक्शन क्या होता है? ये आपके ग्लूकोज को वापस से एब्जॉर्ब करेगा. दिस इज गोइंग टू एब्जॉर्ब द ग्लूकोज व्हिच इज गोइंग आउट इनटू द यूरिन. Like in you and me, in normal individual, do you think there is glucose coming into the urine? No, we do not pass the urine. Why? Because we are having what? This SGLT2 pump is going to be there. And what is the role of this SGLT2 pump? It will absorb all the glucose, it will absorb all the sodium along with this particular thing, right? So this is going to be what? SGLT2 pump. Where do we need to block this pump? If someone is having what? Hyperglycemia. अगर किसी की बॉडी में बहुत ज़्यादा ग्लूकोज है, this is going to become what? Diabetes, right? So in diabetic patient, we are giving a group of drug. What is the drug that we are giving? SGLT2 inhibitor. Anyone? Let me know. Chat box. What is the SGLT2 inhibitors that we are giving? Remember, in PCT, it is going to be present. In PCT, it will absorb 100% of the glucose, right? Normally, it will absorb the 100% of the glucose. In NEET PG people, you can also remember about the renal threshold. This is going to be what? 375 milligram per minute. And what is the plasma concentration? What is the plasma concentration? It will correspond, that is going to be 180 milligram per deciliter of blood, right? So that means, in simple words, if I want to convey the same information, kidney इतना अच्छा organ है, it is going to absorb 100% of the glucose, right? But कब तक absorb करेगा? जब तक इतना ग्लूकोज, this amount of glucose is reaching to the kidney, it will absorb 100%. But इससे ज़्यादा अगर ग्लूकोज जाएगा, this is the renal threshold. If you are having 400 milligram of glucose coming in per minute, what will happen? 25 milligram will be going out of the urine, है ना? और पेशेंट को क्या हो जाएगा? ग्लाइकोज So this is known as renal threshold. They have asked this question, right? What is the plasma concentration it will correspond? That is going to be, अगर आपका blood glucose 180 milligram per deciliter, this is going to be what? Renal threshold will be this particular one, right? इससे ज़्यादा होगा, 300-400 ग्लूकोज है आपके ब्लड में, तो क्या होगा? Obviously you will start to have what? Glycosuria. यूरिन में क्या आने लग जाएगा बेटा? ग्लूकोज आने लग जाएगा. Very good. Sai Krishna, Shivani, RK. Yes, these drugs are going to be what? The drugs which are SGLT2 inhibitors, these are going to be what? Gliflozin. right? Glucose flows in urine, you can remember like that. So these are your dapagliflozin, empagliflozin. These are the anti-diabetic drug, very important topic for FMG examination. So this is going to be SGLT2 inhibitor, right? So these drugs are going to be what? SGLT2 inhibitors. तो basically what we are doing, we are blocking this pump. अगर इस पंप को बंद कर दिया तो क्या ग्लूकोज बॉडी में आएगा? नहीं, सारा ग्लूकोज कहाँ चला जाएगा? यूरिन में चला जाएगा. दैट इज व्हाट वी वांट इन आवर पेशेंट ऑफ डायबिटीज. सो दिस इज गोइंग टू बी व्हाट? SGLT2 inhibitors, right? So these are the GLUT and these are the SGLT transporters. Very, very important high yield information that you need to remember. Now we will talk about the ionic composition. What is the ionic composition that we are having? So suppose this is going to be a cell, something is going to be inside the cell, this is known as intracellular fluid. Something is going to be outside the cell, this is known as extracellular fluid, right? So inside the cell, what is the ions? Outside the cell, what is the ion? That is what they are asking. So they will be asking you what is the most abundant, try to answer what is the most abundant intracellular cation. What is going to be your answer? Yes, Sai Krishna, the side effect of gliflozins will be UTI. सिंपल समझो, अगर बहुत सारा ग्लूकोज बाहर जाएगा, ग्लूकोज इज द फूड फॉर द बैक्टीरियाज, right? So what is going to be there? ICF is going to be there, ECF is going to be there. My question is, what is the most abundant intracellular cation? So two things you have to remember, beta. First thing is going to be cation. Cation क्या होता है? Cation will be having T. You can remember this is going to be what? Positive charge. This is going to be positive, and ions are going to be what? Negative charge. First thing is sorted. Second thing, we are having two compartment. One is extracellular, one is intracellular. एक बाहर का कंपार्टमेंट है, दिस इज गोइंग टू बी वन कंपार्टमेंट, दिस इज गोइंग टू बी अनदर कंपार्टमेंट. तो सिंपल क्वेश्चन दे वांट टू आस्क इज व्हाट? दे विल राइट यू मोस्ट अबंडेंट एक्स्ट्रा सेलुलर केटाइन. सो व्हाट इज द अंडरस्टैंडिंग, बेसिक अंडरस्टैंडिंग दैट यू शुड हैव. इससे घबराना नहीं है. बाहर ज्यादा क्या होगा बेटा? सोडियम ज्यादा होगा. यू कैन अप्रिशिएट व्हाट इज द एक्स्ट्रा सेलुलर कंपार्टमेंट. दिस इज गोइंग टू बी योर एक्स्ट्रा सेलुलर कंपार्टमेंट. व्हाट इज मोर हियर? You can appreciate what is more here. This is going to be sodium. 140 के आसपास क्या है बेटा? सोडियम है. So most abundant extracellular cation if they ask you, बाहर ज्यादा क्या होगा? सोडियम होगा. This is going to be sodium. Along with that, another thing they can ask you, this is intracellular compartment. इसमें ज्यादा क्या है बेटा? 140 के आसपास ही क्या है? Potassium. So what is the most abundant intracellular cation? Potassium. Most abundant extracellular cation? सोडियम. सोडियम बाहर ज्यादा, पोटेशियम अंदर ज्यादा. लाइकवाइज वी नीड टू रिमेंबर, अगर सोडियम बाहर ज्यादा है तो एनाइन कौन सा ज्यादा होगा? अलोंग विद द सोडियम हु इज गोइंग टू बी देयर? Chloride, right? So this is going to be the chloride which is going to be more. So these are going to be your anions, these are going to be your cations. This is your extracellular compartment, this is your intracellular compartment, right? Magnesium will be more in which compartment? Magnesium will be more in which compartment? Magnesium is the most abundant extracellularly or intracellularly? Magnesium is more abundant intracellularly. Calcium ज़्यादा कहाँ होता है? Calcium is going to be more where? In the extracellular compartment, right? And these are going to be your phosphate and inorganic anions are going to be there. Proteins are going to be more inside the cell. So these are the basic information. If you remember this, you can solve your question, right? अब देखो examiner, how this examiner is going to trick you. They are going to give you a value, like they can also write you that there is a person, we are doing some analysis of the body fluid and sodium is going to be 140 milliequivalent per liter, right? Potassium is going to be 12 milliequivalent per liter, right? They can also write you about the magnesium is going to be what? 7 milliequivalent per liter. They can write you like this and they will give you identify the compartment. Now try to apply the knowledge that I have given you. Now try to apply the knowledge. Identify the compartment. ऐसा ही क्वेश्चन पूछता है एग्जामिनर. Some of the people, they are afraid of math. They will think like that कुछ calculation होगा 140 12 7 बहुत सारा कुछ दिया हुआ है. So they are afraid of math and they will leave this question. But is it the question to leave? No, this is not a question to leave. हम यहाँ पर थोड़ा सा दिमाग लगाएंगे. क्या ज़्यादा दे रखा है बेटा? सोडियम ज़्यादा दे रखा है. That means which compartment they are asking about? Which compartment they are asking about बेटा? If sodium is given more, that means they are asking about the extracellular compartment. So which is the compartment they are asking? This is going to be extracellular. Potassium कम है, sodium ज़्यादा है. Instead of this, if they will write you potassium is going to be 130, what is going to become this compartment? It is a extra. Let me give you the question. If they will write you potassium is 130, sodium is 10, identify the compartment and they can write you the options ECF, ICF, intracellular compartment or interstitial fluid. You need to identify the compartment. What is this compartment for potassium? कर लोगे ऐसा क्वेश्चन? दिस इज गोइंग टू बी व्हाट? इंट्रा सेलुलर कंपार्टमेंट, है ना, इससे घबराना नहीं है, बड़ा आसान है, सिंपल है, हो जाएगा। और यही पूछते हैं, दिस इज द सेम थिंग दे हैव आस्क्ड इन द प्रीवियस एग्जामिनेशन। मैं वही पढ़ा रहा हूँ जो पूछा गया है, जैसा पूछते हैं, राइट। सो दिस इज गोइंग टू बी व्हाट? ECF. This is going to be what? ICF, most abundant extracellular cation. This is going to be what? Sodium, most abundant extracellular is sodium, intracellular is potassium, anions are going to be these proteins and phosphate, and chloride and bicarbonate. This is going to be the basic understanding that we need to have about this ionic composition. I hope you are done with this, right? Last important topic that we are having from here is going to be what? This type of transport across the membrane, है ना, थोड़ा बोरिंग होता है ये चैप्टर, but at least we have to do some certain questions they are asking from here, right? So what is this question? This question is about the how the things are going to be moving through and through a cell. कैसे चीजें अंदर और बाहर जाएगी? This is known as what? This is known as transport. So we can have two important types of transport. We can have passive transport, we can have active transport. Passive transport होगा, active transport होगा. Passive means, is it going to use some energy? So there will be no utilization of energy. Energy is not going to be used. What are the examples of passive transport? बोलो मेरे साथ. The first one is simple diffusion. Another one is facilitated diffusion. What happens in simple diffusion? We are having concentration gradient. You know, everything will move from its higher concentration to lower concentration, right? This is going to be simple osmosis that you need to remember. But the examiner is going to ask you question from where? From the facilitated diffusion, right? And what are the two examples for facilitated diffusion that we have already seen? Yes, my dear students, tell me, what are the two examples that we have seen for the facilitated diffusion? Yes, the first one is going to be blood transporters. This is going to be example of facilitated diffusion. And one, the question that they have asked already, this is going to be your aquaporins. This is going to be your aquaporins. Very good, Shagun, right? Dolly Moni, right? Very good guys, right? So this is going to be what? Glut and aquaporins are going to be the example of facilitated diffusion. These are the two important things you need to remember from here, right? What about this active transport, beta? Active transport means they are going to be using what? Energy in the form of ATP. In the form of ATP, they are going to use energy, and we are having two important types of transport here. One is due to vesicle, one is due to pump, right? Vesicle is going to be what? Anything can come inside. This is known as, if something is coming inside, this is known as endocytosis. If something is going out of the cell, this is known as exocytosis. So we are having endocytosis, we are having exocytosis. But remember, in endocytosis, if the material is going to be solid, अगर solid material को कोई चीज खा रही है, we are going to call it what? Phagocytosis. क्या बोलेंगे इसको? Phagocytosis. If the material that we are engulfing is solid, this is phagocytosis. If the material that we are engulfing is liquid, अगर liquid है तो इसको क्या बोलना है? This is known as pinocytosis. और नीट पीजी में इन्होंने pinocytosis को लिखा था बेटा cell drinking. What they have written? Cell drinking. So this is going to be what? Cell drinking or pinocytosis is going to be what? The same thing, engulfing something which is going to be liquid, pinocytosis. If it is a solid, this is going to be phagocytosis, right? Now, what are the proteins which are important here? NEET PG examination question. There are two important proteins. One is going to be what? Clathrin. Another one is myelin. Last to last exam mein these two protein has been asked. What are the two important proteins for endocytosis? The answer will be clathrin and myelin. Whatever is there, you can mark, right? For exocytosis, what is the thing you need to remember? For exocytosis, which proteins are important? These are going to be your snare protein. कोई चीज बाहर निकालने के लिए क्या जरूरी है? Which protein is important? This is going to be snare protein is important. And one more clinical implication, if I want to connect this particular thing, you know about the Botox, botulinum toxin, right? You know what this Botox is going to do? It is going to destroy the snare proteins, and these snare proteins are not working. तो क्या बाहर नहीं आएगा? Suppose this is a vesicle, it will be having acetylcholine. What is the role of snare protein? To release this acetylcholine into this particular place, right? Here you will be having the receptors for acetylcholine. But if you are having what? If you are having if you are using this botulinum toxin, what will happen? This near protein is going to get blocked, and this acetylcholine is not able to come forward, right? And if it is not able to come, you are going to have what? Paralysis is going to be there, flaccid paralysis, right? So this is going to be what? Snare proteins are important, right? So exocytosis के लिए कौन सा प्रोटीन इंपॉर्टेंट है? बोटुलिनम पे तो क्वेश्चन पूछा है, मैकेनिज्म मैंने तुम्हें बता दिया, right? So this is going to be snare protein, and these two question has been asked previously, right? So this is done. The next thing we are having is about the pumps. What are the pumps we are having? Two important types of pumps. What are the two important type of pump? First one is primary active transport. Another one is secondary active transport. So they can give you a question, they can give you some receptor, and they can ask you. यही क्वेश्चन बार बार पूछते हैं क्योंकि बच्चे गलत करते हैं, राइट? सो व्हाट दे आर गोइंग टू आस्क यू, sodium potassium pump is a type of. Options are facilitated diffusion, osmosis, primary active transport, secondary active transport. So sodium potassium ATPase pump is an example of what? Primary active transport. Proton pump is an example of what? प्राइमरी एक्टिव ट्रांसपोर्ट. ये याद करना है, बहुत इंपॉर्टेंट है, हर साल क्वेश्चन आता है, राइट? सेकेंडरी एक्टिव ट्रांसपोर्ट में व्हाट यू नीड टू रिमेंबर व्हेनेवर यू विल फाइंड द वर्ड सिम्पोर्ट, ये टेक्निक है, व्हेनेवर यू विल फाइंड द वर्ड एंटीपोर्ट, को ट्रांसपोर्टर, एक्सचेंजर, राइट? जब भी ऐसा कोई भी वर्ड दिखेगा अपन को, वी आर गोइंग टू मार्क आवर आंसर एज सेकेंडरी एक्टिव ट्रांसपोर्ट. लाइक if let me ask you, sodium iodide symport, ये PYQ है. Sodium iodide symport is a type of primary active transport, secondary active transport, facilitated diffusion, or osmosis. What is going to be your answer? Yes, it is going to be secondary active transport. Let me ask you one more question. Sodium potassium 2 chloride co-transporter. If anyone can tell me the location, also try to tell me the location of this pump. Sodium potassium 2 chloride pump कहाँ होता है? The drugs you are using for this pump is going to be what? Furosemide. अब बता दो कहाँ होता है? So this is also going to be secondary active transport, right? No need to go into detail, है ना? Detail आप लोग पढ़ चुके हो. Just how to solve the question, this is what is important, right? So this is an example of what? Secondary active transport, right? So what are the four transport mechanism across a cell? First one is going to be what? Two are going to be passive transport, two important are going to be active transport. Passive transport, if something is traveling with the help of osmosis, this is simple diffusion. Facilitated diffusion, no need to forget these two options. These two options are important. One is glut, one is aquaporins. SGLT2 is going to be what? SGLT is also going to be what? Secondary active transport. Sodium glucose like transporter is going to be what? Secondary active transport, right? Glut याद रखना है, facilitated diffusion का example है, right? Vesicular, you need to remember. For endocytosis, which two proteins are important? जहां भी हो बोलो, which two proteins are important? Just use the time very well, right? So first one is going to be what? Clathrin. Another one is going to be what? Megalin, right? For exocytosis, we are having which protein? Snare proteins. What is the implication? Your botulinum toxin, right? Botox. Pump, we have seen primary and secondary active pumps that we are having. This is going to be the important thing, right? The last thing we are having from the body fluids is going to be about this pathways. They have asked a question. What is my question? Let me ask you. The conversion of prothrombin to thrombin. The conversion of prothrombin to thrombin is done with the help of what? With the help of what? So this is your clotting cascade that we are having, right? So we have already learned the story, how a cut is going to happen, and what is the primary active primary hemostasis and secondary hemostasis. We have learned about all those things, right, in the full classes, right? So we are having hemostasis, मतलब अगर किसी को कट लग गया तो ये bleeding कैसे रुकेगा? This is going to have two component. One is going to be primary hemostasis. One is going to be primary hemostasis. Another one is going to be what? Secondary hemostasis. सर ये प्राइमरी हीमोस्टेसिस क्या होता है? एक बार अगर कट लग गया, यू विल बी हैविंग ब्लीडिंग, बट विद इन सम टाइम्स. व्हाट इज द नॉर्मल ब्लीडिंग टाइम? 2 to 9 minutes. तो within 2 to 9 minutes what is going to happen, ये cut अपने आप बंद हो जाएगा, bleeding रुक जाएगी, right? But if you press this thing, you know what happens, again it will start to bleed, right? Why? Because it is a primary hemostasis, and this primary hemostasis is due to what? It is due to platelet, right? Now you see the same lesion that you are having, if you try to press it the next day, अगर आप उसको कल दबाओगे, अगले दिन दबाओगे, is it going to bleed? No. Why? Because now the secondary hemostasis comes into action, and the function of secondary hemostasis is to make what? Fibrin, right? And this fibrin is the one which is going to make the plug, which is going to be a strong plug, right? So primary plug is due to what? Platelets, which is a weak plug. If you put the pressure, it will bleed again. Secondary plug is due to fibrin. If you put the pressure, फिर भी bleeding नहीं होगा, right? So this is going to be primary and secondary hemostasis, right? This particular pathways that you are having, they are only for the secondary hemostasis, they're not for the primary hemostasis, है ना? Primary hemostasis में सिर्फ platelet आएंगी और अपना खून का थक्का बनाएंगे, and this is how they are going to stop the bleeding. But what happens in secondary hemostasis? This is going to have this cascade. What is this cascade? This is known as coagulation cascade. Simple में याद करते हैं इसको. What is the coagulation cascade? We are having two pathways: extrinsic pathway, intrinsic pathway, and common pathway, right? What is the factor that is going to be there in the extrinsic pathway? Just remember the table. 7 is going to be there. You can write 1, 1 2 ja 2, 2 5 ja 10. So 1, 2, 5, 10 are going to come in the common pathways. Remaining, what is remaining? 8, factor 9, 10 we have already written, factor number 11, factor number 12, they are coming under the intrinsic pathway. So these are the intrinsic pathway, these are the factors for the extrinsic pathway, and these are the factors for the common pathway. Sir, factor number 2 क्या होता है? ये thrombin होता है. This is going to, this is going to be prothrombin, which is going to convert into thrombin. Now this is going to catalyze the reaction. What is the reaction? This factor number 1, fibrinogen, will convert into fibrin, and ultimate purpose of this particular thing, ultimate purpose of this complete pathway that you always study, intrinsic, extrinsic, इसका एक ही मकसद होता है. What is the मकसद? What is the ultimate purpose? To make what? Fibrin. To make what? Fibrin. और ये fibrin जाके जहां भी deposit होगा, which is going to make a strong plug, right? So this is going to be the basic thing you need to remember. Factor number 7, I've written the same thing. 7, 1, factor number 2, factor number 5, factor number 10, they are going to come under the common pathway. What is left? 8, 9, 11, and 12. These are going to be your intrinsic pathway factors. So this is how you need to remember. They are ultimately going to catalyze another reaction, ultimately going to make what? Fibrin bands. This is going to be the ultimate thing. But examiner has asked the question. What is the question? The conversion of prothrombin to thrombin is done with the help of what? With the help of calcium. The conversion of prothrombin to thrombin is done with the help of what? Calcium. This is the question they have asked, right? What are vitamin K dependent factors? Can anyone tell me what are vitamin K dependent factors? These are going to be your factor number 2, 7, 9, and 10. These are vitamin K dependent factors, right? Gamma carboxylation will happen. This is going to be factor number 2, 7, 9, and 10, right? Now comes the some one-liners. What are the one-liners we are having? What is the most abundant extracellular cation? Now try to answer. These are the question that has been asked previously. Chalo batao, what is the most abundant extracellular cation? What is going to be your answer? This is going to be, yes, sodium. Very good. This is going to be what? Sodium. Which glut is present in adipocytes for uptake of glucose? Which glut is going to be there for glucose uptake? Which glut is going to be there? This is going to be glut 4. Remember I told you glut 4 is present in 3 locations, important ones: skeletal muscle, cardiac muscle, and adipocytes. They are insulin dependent, right? What is calcium binding protein in smooth muscles? What is calcium binding proteins? From this particular chapter, these questions has been asked previously. What is a calcium binding protein in smooth muscle? This is going to be your calmodulin. What is going to be your answer? This is going to be calmodulin. Calmodulin is going to be the calcium binding protein. What is the normal anion gap? This is going to be 8 to 12 milliequivalent per liter. This is going to be normal anion gap. You can also calculate this particular thing. You can calculate the amount of sodium That means whatever is going to be outside is going to be what? Sodium. You can subtract this particular thing with chloride plus bicarbonate, right? And this is how you will get the anion gap. This is the formula for anion gap. Suppose the sodium is given like 140 for NEET PG students, and this is given like 110 plus like 20, right? 20 is bicarbonate. What is going to be the anion gap we are having? 110 plus 20 is 130. The anion gap is going to be what? 10. And this 10 is going to be coming under the normal anion gap. It can have high anion gap, you can have low anion gap also, right? So this is what can happen, right? Rabies virus uses what for the movement? This is another question they have asked. Rabies virus is going to use what for the movement? They are going to use what for the movement? Which protein they are going to use for the movement? They are going to move upward, right? From a site of the bite, they are going to travel in your body to the hippocampus, to the brain. How they are going to travel? What is the speed also, you can tell me? What is the speed for rabies? Anyone? Rabies is going to use what? Dynein beta. It is going to use what? Dynein, and this is going to be what? Causing reverse axonal transport. Reverse axonal transport. ORS basis for transport. What is the transporter we are going to use in the ORS? This is going to be which transporter? GLUT or SGLT? What is going to be your answer? This is the exact question they have asked you. The answer will be SGLT 1. Remember, 1 is going to be present in the intestine, right? Decrease free radical injury and increase lifespan by. This is going to be done by decrease free radical injury and lifespan will be increased by. Free radical injury are basically, free radicals are reactive oxygen species. These are going to be your oxygen compounds that are going to be there. These are going to be nascent oxygen compounds, right? तो ये इनकी वजह से इंजरी होता है. इसको कौन कम करता है? These are going to be your sirtuins, your antioxidants, right? These are going to be your sirtuins, your antioxidant, or maybe decrease in the calorie intake. Whatever is going to be there, you can mark this answer, right? So sirtuins has been asked previously. They are rich in antioxidants. So whatever food you are eating, or you can tell me what are the three vitamins which are rich in antioxidant properties. 3 vitamins you should be having: vitamin A, C and E. These are the 3 vitamins which are rich source of what? Antioxidants. These antioxidants are vitamins are going to be vitamin A, C and E vitamins, right? So this is the important questions from the chapter number 1 that we have seen. These are the important topics that you cannot skip, right? These are the important topics. Now we will discuss about the excretory system. Now we will discuss about the second system. Try to answer this question. In the given cystometrogram 1B indicate what? So what is this cystometrogram? Cysto matlab hota hai bladder, right? Metrogram is going to be the graphical representation. So what is going to be your answer? In cystometrogram, what you will find? 1B is going to indicate what? This is a current favorite of examiner. In the last exam also, in the previous INA set also, they have asked questions from here. So what is this particular thing? Let me make you understand what is this excretory system is going to be there and how it is working, right? So what is the parts of excretory system? That is going to be what? Just try to understand the normal physiology behind this excretory system. The function of excretory system is to remove the urine out of the blood. So out of your heart, how much amount of blood is going to come out? This is known as cardiac output. What is cardiac output? This is going to be heart rate times stroke volume, right? So how much is cardiac output? 1 minute में कितना blood बाहर आता है? 1 minute में from your heart 5 liter of blood is going to come out. Out of that 5 liter, how much is going to the kidney? This is known as renal blood flow. This is known as renal blood flow. So 20% will go to the kidney. That means your kidney will receive 1 liter per minute. How much blood is going to the kidney? 1 liter per minute. अब इस 1 liter में क्या होगा? There are going to be 2 components. One is going to be 40% will be cells and 60% will be plasma. है ना? ये we are understanding how the urine is getting formed, right? So 60% will be plasma, and this plasma which is coming to the kidney, this is known as renal plasma flow. This is going to be 600 ml. How much is going to be renal plasma flow? 600 ml is going to be renal plasma flow, right? And out of that renal plasma flow, how much is getting filtered? 20% again is getting filtered, and this is filtered through the glomerulus, so it is known as glomerular filtration rate, and 20% of that is going to be what? Approximately 120 ml per minute or 125 ml per minute. This is going to be your GFR. This is known as glomerular filtration rate, है ना? तो हार्ट में से कितना ब्लड निकला था बेटा? 5 लीटर. उसमें से कितना फिल्टर हुआ किडनी में? 120 ml. And what is the urine output that you are having in a day? What is the normal urine output? Normal urine output कितना होता है एक दिन में? How much urine you are passing? This is going to be 1 to 2 liter. You can call it as 1500 ml. Right? And out of that 1500 ml, how many minutes in a day? If you count, this is going to be 1440 minutes. Right? So can I say your kidney is making approximately 1 ml of urine per minute? Right? So हर minute में 1 ml urine बन रहा है. Right? So out of that particular thing, you can say renal output is going to be how much? This is going to be 1 ml urine per minute. 1 minute में कितना यूरिन बन रहा है? 1 ml. 1 मिनट में हार्ट में से कितना निकल रहा है? 5 लीटर. उसमें से कितना यूरिन बन रहा है? 1 ml per minute, right? तो पूरे दिन में कितना बनेगा? 1500 ml. Simple, right? So this is what we need to understand what happens with the 119 ml, right? इस बाकी बचा हुआ यूरिन कहाँ गया? ये सारा absorb हो गया बॉडी में, right? So this is what is important. This is a function of kidney. Our kidney is a very efficient organ. It is going to supply out of 5 liter. It is going to make 1 ml of urine per minute. Sometimes you could use certain terms like polyuria. What is polyuria? What is oliguria? When you will pass the urine more than 3 liters per day, this is known as polyuria. When you will pass the urine 400 ml per day, this is going to be what? Oliguria, right? So now let's try to understand ये सारा बचा हुआ urine कहाँ absorb हो रहा है? What is the location for this absorption? So this is going to be the thing we are having. This is a diagram of the kidney. This is a schematic diagram of a nephron, right? So let's try to understand. Out of heart, how much blood is coming? 5 liter. How much is coming to the kidney? 1 liter. What is the plasma? 600 ml will be plasma, and how much plasma is coming to the kidney is known as renal plasma flow. Examiner has asked a question. What is the question? The question is how you will identify the renal plasma flow. So what is the indicator for renal plasma flow? This is going to be PAH. This is going to be para-amino hippuric acid is the indicator for renal plasma flow. This is a neat PG question, right? Renal plasma flow कैसे identify करेंगे? With the help of para-amino hippuric acid, right? This is going to be PAH, right? So out of that 600 ml which is coming into the kidney, right? कितना filter होगा यहाँ पर? This is known as glomerulus. How much is getting filtered here? This is going to be glomerulus. Whatever is filtered is known as glomerular filtration rate. So this is going to become what? 120 to 125 ml per minute, right? So this is going to be what? GFR. GFR is going to be what? You understand what is GFR, right? Now the first part of the kidney, can you see it is convoluted? It is proximal. It is convoluted. So this is known as what? Proximal convoluted tubule. This is known as PCT. The second part of the kidney is going to be what? This is U-shaped structure that we are having, or loop-like structure. This is known as loop of Henle. This is going to be loop of Henle. This part is again distal part. Again, can you see it is convoluted, right? So we can call it distal convoluted tubule. This is your DCT, right? And lastly, all these things are going to drain into what? Different collecting ducts are going to be there, and all these collecting ducts are going to drain into what? We are having 2 ureters coming. These ureters are going to drain this urine into the urinary bladder. In the urinary bladder, how much is the urine which is coming here? 1 ml per minute, right? And this is coming into the urinary bladder. Through urinary bladder, what will happen? The urethra will be coming out, and this urethra is going to pass this particular urine into the urinal wherever is going to be there, right? So this is going to be the story of the kidney that you need to remember. अब यहाँ पर क्या होता है? All the important parts are important, right? All the drugs that you are using are important. They are not asking direct physiology question, rather they are asking you question किस पंप में क्या होगा, कहाँ कौन सा पंप होता है, but the location you need to remember. अगर लोकेशन पता रहेगी, कैसे काम कर रहा है पता रहेगा, तो हम आसानी से आंसर कर सकते हैं, right? For example, like you are learning about what chronic renal failure or sometimes acute kidney injury, how to differentiate. They are differentiated on the basis of what? GFR. GFR के बेसिस पे you are going to differentiate. अगर किसी का GFR 120 ml per minute है, it is going to make how much urine? 1 ml. Right, now think about it. If someone is having 30 GFR, if the GFR is going to be 30, what will happen to the urine output? Automatically sir iska kidney kharab ho gaya, right? We call it the same thing, right? What is the meaning here? The GFR is disturbed, right? If the GFR is disturbed in a short period of time, we call it acute kidney injury, right, due to some disease. Right, if it is a long term process, this is known as chronic renal failure. It is dependent on the GFR that you can connect in your medicine, right? But we need to remember about our parts. The first part is going to be what? First and foremost is going to be what? PCT. Which pump is going to be there in the PCT beta? This is going to be your carbonic anhydrase inhibitors, and the name of the drug that would be working over here is going to be what? Dimox. Basically it is going to be your acetazolamide, right? So the first group is going to be what? Proximal convoluted tubule. 100% of sugar is getting absorbed here, 100% of amino acid, with the help of which pump? Now you try to tell me the answer. The pump which is going to be here is going to be what? SGLT2 pump is going to be there, which is going to absorb all the sugar and amino acid along with the sodium, right? So this is the function of this particular PCT, right? Then you will be having this descending limb of loop of Henle. It is permeable to water. So what will happen? This water will come into this particular same vessel. This vessel is known as what? Vasa recta. Suppose this blood is coming from here and this blood is going from here. So the same vessel will run along with this particular thing and it is going to make your counter current system. Basically what will happen? यहाँ से चीजें वापस absorb होके यहाँ आ जाएंगे. इसी को counter current system बोलते हैं. This is going to be what? Exchanger, counter current, multiplier exchanger that you are having. But the basic understanding is what? यहाँ से चीजें यहाँ absorb हो जाएंगी, right? So this is going to be the thing. The next important pump that we are having is going to be this particular area. Here you will be having what? Sodium potassium 2 chloride pump, right? And the drug which is going to be blocking this particular pump is known as what? Loop diuretics. Loop diuretics, right? So basically it is going to absorb what? Sodium, potassium, chloride, everything is going to get absorbed here. And एक simple rule याद रखना है, जहां पर भी सोडियम जाएगा वहां पर क्या जाएगा बेटा? Water will also go along with the sodium. This is a simple rule that you need to remember, right? So this is going to absorb the sodium and water. Sir, कितना कहाँ absorb होता है? In PCT 65% of the water absorption is going to be there, salt along with the water. 25% of the absorption is going to be happening at this particular level. This is going to be your loop of Henle. 6 to 8% of the absorption is going to happen at DCT, distal convoluted tubule. It is going to have what? Sodium chloride pump, which is also going to absorb the sodium into the body. What will happen? पानी भी साथ में absorb हो जाएगा. And lastly, 2 to 3% of the salt absorption is going to take place in the last part, which is going to have what? Aldosterone working, and this aldosterone is going to do what? It is going to absorb the sodium and it is going to remove the potassium and H plus out of the body, right? This is going to be the thing we are having. In lower part of the collecting duct, you will be finding this antidiuretic hormone, right? जहां पर भी video stopped. Wherever you will feel like I need to explain more, you can let me know. अगर कुछ भी नहीं समझ में आ रहा तो बता देना, थोड़ा extra time लग जाएगा, but we will cover up this particular thing, right? So wherever you are having doubts, do ask me, right? So these are the 5 pumps that you need to remember. और अगर आपको ये 5 pump समझ में आ गया, आपको आपका BP control भी समझ में आ जाएगा. You will understand how to use this particular thing, right? We can also have diseases around this particular area. What are the diseases we can have? Video is working or not? Can you see me? Can you see me and hear me? Audio video is fine, beta. Okay. So this is going to be what? This is going to be your distal convoluted tubule. Here you will be having what? Sodium chloride pump is going to be there. It is going to absorb what? 6 to 8% of the sodium in the blood vessel. And what will happen? 6 to 8% of the water will also come into the blood vessel. This is the function of this sodium chloride pump, which is going to be present in the DCT. After that, we are having collecting duct. This collecting duct will be having 2 parts. The upper part is known as this is going to have what? Upper part of the collecting duct and lower part of the collecting duct. Upper part will be having functioning of a hormone. This hormone is known as what? Aldosterone. This hormone is known as what? Aldosterone. Basically what it will do, suppose this is your blood vessel. So this aldosterone is going to come from the blood vessel. Suppose these are your blood vessels. This aldosterone is going to come and it has got a function. This is going to be, suppose, your cell of kidney, and this is going to be the urine which is going below. Just try to orient yourself. Here you will be having blood, here you will be having cell, and this is going to be the urine which is going into the lower collecting duct. So what is the role of aldosterone? It will come here and it will make certain pumps. What is the role of aldosterone? It will make certain pumps, and these pumps are known as epithelial sodium channel. These are known as ENaC pumps or epithelial sodium channels, and they are going to make pumps like this. What is the function of the sodium channel? It will absorb the sodium. It will absorb the sodium from the urine, and it will absorb the sodium. Along with the sodium, who is going to come? Water is going to come, and this sodium is going to come into the blood again, and water will also come into the blood again. This is how this aldosterone is working. Aldosterone is a hormone, so it is coming from the adrenal medulla. It will come here, and the function is to make what? ENaC channel. अब जितने ज़्यादा ENaC channel होंगे, more the ENaC channels are going to be there, more the salt absorption will be there. Yes or no? Right? So the more sodium is going to come inside, what will happen? Another thing, अब ये sodium अंदर लेगा. If it is going to take the sodium inside, it needs to remove something. What is something that it is going to remove? K plus and H plus. So whatever sodium is coming inside, what will happen? It will remove the H plus and K plus in place of the same thing, right? And if you are having a disease, if you are having increase in aldosterone, ये मेडिसिन में कोरिलेट करोगे, अभी देखो समझ में आएगा. अगर एल्डोस्टेरोन बढ़ गया तो इसको बोलते हैं Cohn syndrome, right? This is known as Cohn syndrome, and we can have decrease in the aldosterone. You will be having Addison's, right? Now tell me the symptoms of Cohn syndrome. What will be the symptoms of Cohn syndrome? What will happen? Cohn syndrome means increase in the aldosterone. More aldosterone means more ENaC channel. More ENaC channel means more sodium coming inside, more water coming inside. If more sodium is going to be there, more water is going to be there, what will happen to the BP of the person? BP भी बढ़ जाएगा इस person का, right? What will happen to the potassium? More potassium will be going out, more H plus will be going out. So this person will be having what? Hypokalemia. This person will be having what? Hypernatremia, increase in BP, hypertension, right? All these symptoms are going to be there. This is going to become what? Cohn syndrome, right? Addison में क्या होगा? उल्टा हो जाएगा, aldosterone कम है. So what will happen? This urine will be having sodium going out into the body, right? Yes, definitely it will be enough for your NEET FMG. Yes, right? We are covering most of the topics I am trying to cover here. Don't worry about anything. Just remember, even if you remember these topics like this Cohn syndrome, Addison, this is something will give you the understanding. You can apply it in your medicine also, right? So this is, but we are short on the time, but we'll try to cover maximum. Whenever you are not able to understand, do let me know, right? तो उल्टा यहाँ पर हो जाएगा बेटा. This is going to be what? Functioning of aldosterone. It will absorb 2 to 3% of the salt, and it will remove what? Potassium and H plus out into the urine, right? The next part is going to be what? This is going to be your antidiuretic hormone, and this antidiuretic hormone will be having two functionings here. The same cell we can make for ADH also. So ADH is also a hormone. Let me make it here. So ADH is also a hormone. It is coming from the blood vessel, and it is going to make something around this cell. This is going to be cell. Here is going to be what? Urine. The urine is going here. This is going to be the cells, and this is going to be the blood vessel, vasa recta, which is going to be there. I told you the same blood vessel will be moving like that. So it will be coming here. Here you will be having certain cells, and this is how the things are coming here, right? So now let's talk about the antidiuretic hormone or ADH. This ADH is also known as vasopressin, right? So this ADH is also coming from the brain, from the hypothalamus it would be coming, and it is going to do what? It is going to make some pumps, and these pumps are known as what? These pumps are known as aquaporins. These pumps are known as aquaporins. से क्या बनाता है बेटा? Aquaporins बनाएगा, and these aquaporins are going to absorb what? Water. These aquaporins are going to absorb. Aqua means, remember, only water. These are the pore only for the water. So water is going to come from here, and this water is going to come from here. It will come into the vessel. What will happen? सिर्फ पानी का absorption होगा. So this is going to be the role of aquaporin. सोचो अगर यहाँ पर ADH बढ़ गया, तो कौन सा डिसीज हो जाएगा? इफ देर इज गोइंग टू बी डिक्रीज इन एडीएच, व्हिच डिजीज विल बी देयर? टेल मी. If there is increase in ADH, syndrome of inappropriate or increased ADH, ऐसा ही ADH हो जाएगा, right? अगर ADH का level कम हो गया, if the level of ADH will be low, what will happen? If ADH will be low, what will happen? This aquaporins will be low. पानी अंदर नहीं आएगा, ये पानी सारा कहाँ जाएगा? बाहर जाएगा. एंड पानी बाहर जाने को क्या बोलते हो? इफ देर इज मोर देन 3 लीटर ऑफ वाटर इज कमिंग आउट इन द यूरिन, दिस इज नॉन एज polyuria, and polyuria is a symptom of what? Diabetes insipidus. This is known as diabetes insipidus. We are having central and nephrogenic diabetes insipidus. We are having SIADH. इनके drug of choice भी याद कर लो. What is the drug of choice for SIADH? This is going to be Vaptans. And here you can use what? Desmopressin or thiazides, right? So this is important. You understand this thing? We can have certain syndromes that you need to remember. What are the syndromes that can happen? If you are having mutation, in the PCT, just remember the name of the syndrome. This is going to cause what? Fanconi syndrome, right? If you are having problem with the sodium potassium 2 chloride pump, this is going to give you a syndrome. This is known as Bartter syndrome, right? If you are having problem with the sodium chloride pump, which is where the thiazides will be working, this is going to cause what? Gitelman syndrome, right? And if you are having ENaC mutation, epithelial sodium channel mutation, this is going to cause what? Liddle syndrome. अब देखो एग्जामिनर ने नीट पीजी में क्वेश्चन पूछा, if there is a Liddle syndrome, patient is having hyperactivation of ENaC channel, what is going to be the symptoms? तो patient examiner ने क्या किया? Only symptoms दे दिए. नीट पीजी में they have given a case of Liddle syndrome and they have written what? This patient is having what? These channels are going to be more. If these channels are going to be more, what are going to be the symptoms? इस patient को hypertension होगा कि hypotension होगा? Try to answer. Liddle syndrome में patient का BP बढ़ेगा कि कम होगा? ENaC चैनल बढ़ गए मतलब सोडियम ज्यादा अंदर आएगा, सोडियम ज्यादा अंदर आएगा तो पानी ज्यादा रहेगा. If there will be more sodium inside the body, more water inside the body, more BP will be there. What happens with potassium? Potassium will be low. What happens with H plus? H plus will be low. Simple understanding. What happens with the levels of aldosterone? They are also going to be low. So this is how you can apply the information, है ना. Basics अगर हमारा clear है, you can apply and you can derive the medicine. This is इसीलिए बोलते हैं ना, फिजियोपैथोफार्मा अगर ठीक है तो ऑटोमेटिकली मेडिसिन अपने आप आ जाता है. ठीक है. So these are going to be the thing we are having. So we are having PCT, we are having this loop of Henle, we are having DCT, we are having what? Collecting duct, upper part and lower part. ये 5 चीजें आपने पढ़नी है. These 5 things are important, right? Okay, these are going to be the syndromes that we can have, right? What about the cystometrogram that we are having? This cystometrogram is going to be something which is going to tell us about the situation of the bladder. ये आपका bladder है, ये भरेगा. This is going to get filled and we are going to go out for urination, and the condition of this bladder is known as what? Cystometrogram, right? So let's try to understand what is the graphical representation of the bladder. ये आपका bladder है. So what is going to happen inside your bladder? This is what we are going to learn in this particular thing. When the urine is going to come through both the ureters, these are the ureters which are going to bring the urine, है ना? This is going to come into your bladder. So we are going to have 3 phases, 1A, 1B and 2. These are the 3 phases we are going to have. What happens in 1A? Just try to understand. Very very important topic for FMG as well as NEET PG. अभी INI set में भी इससे क्वेश्चन पूछा और at least 4 question they have asked from here, right? In the previous examination 4 बार ये क्वेश्चन पूछ चुके हैं यहाँ से, अलग अलग तरीके से पूछेंगे, but you have to answer this thing, right? So what is going to be the thing? बहुत simple है, बहुत simple. In a format of a story we are going to learn this thing. देखो, when you are going to pass the urine, what will happen? This is a pressure volume graph again. This is going to be the volume on the x-axis. On the y-axis you are going to have the pressure. अभी देखो इसको समझो क्या होगा. यूरिन भरेगा, कितना यूरिन आता है 1 मिनट में? What is the amount of urine which is coming per minute? This is 1 ml of urine coming per minute. ये हमने देख लिया कैसे आता है, right? So this is 1 ml of urine coming per minute, right? When you will pass the urine, what will happen? Your pressure will be 0, your volume will be 0. खाली कर दिया. अभी स्टार्टिंग से देखते हैं. First phase is going to be what? 1A. 1A will be having what? Can you appreciate? The pressure is also increasing, the volume is also increasing. So 1A is going to have what? Increase in the pressure and increase in the volume. Both the things are increasing. This is going to be 1A. उसके बाद में क्या हुआ, आप यूरिनेट करके आए, यू आर गोइंग टू पास द यूरिन. आफ्टर सम टाइम्स यू नो व्हाट हैपेंस, स्टार्टिंग में दोनों चीजें बढ़ेंगी, बट आफ्टर सम टाइम्स, फॉर एग्जांपल यू एंड मी एंड लॉट्स ऑफ पीपल आर सिटिंग, राइट, वी आर सिटिंग इन विच फेज, we are sitting in this particular phase. This phase is known as 1b. This phase is known as 1b. And 1b में क्या होगा बेटा, वॉल्यूम तो बढ़ रहा है, your bladder will be having urine coming from the, constantly urine is coming from the kidneys and it is getting accumulated here, but are you feeling the pressure to pass the urine? No, we are not feeling the pressure. Why? Because we are having a special law working here, and this law is known as Laplace law. So basically when you will be having increase in the volume but the pressure will be what, constant, or very less pressure will be increased, this is known as what, Laplace law. This is based on a law and this law is known as Laplace law. So they can write you in the question, 1b is due to Laplace law. What is happening in the 1b, the pressure remains constant and the volume is continuously increasing. You can see here the volume बढ़ रहा है but pressure constant है. Yes or no? Right? So this is going to be what? This is going to be known as 1b or Laplace law. But what will happen, and why this thing is happening? Why this thing is happening? Because of a property of a bladder. What is the property of bladder? Bladder is a plastic organ, and this property is known as plasticity. It is elastic. क्या होता है बेटा, आपने खींचा, it will come back to original position. You will stretch it, it will come back to its original position. This is elastic thing, right? But what is plasticity? Plasticity, like your stomach, like your bladder, ये क्या होगा, यूरिन आता जा रहा है, बड़ा होता जा रहा है, बड़ा होता जा रहा है, बड़ा होता जाएगा, right? And then it will start to contract, right? It will get bigger, it will get full, and then it will start to contract. आप खाना खा रहे हो, खाते जा रहे हो, खाते जा रहे हो, there is going to be it will your stomach will accommodate everything, but there is going to be a point when it will contract और आपको vomiting हो जाएगा. So these organs are known as what, plastic organ. Lungs कैसे हैं? Lungs are elastic, they are going to stretch, they are going to come back to original position, like that. These are going to be your lungs, right? So these are the plasticity. समझ में आया क्या होता है, right? So this is going to be the property, this is plasticity, and this is based on a law, Laplace law, and where the volume will be increasing but the pressure remains constant, and there is going to be a point when you will feel the sensation to pass the urine. You will be having this marked sensation, और यहाँ पर क्या होगा बेटा, यहाँ पर pressure बढ़ने लगेगा, and now the pressure will start constantly increasing. ये pressure बढ़ता जाएगा till the time you are not going to pass the urine. This is what is happening in our daily life, and this is known as what? This is going to be phase number 2, where the pressure will be increasing, and now you will go for what? Micturition. Now you will go for what? Micturition. Now you will pass the urine, right? This is the same question they have asked multiple times. There is nothing to worry. A very simple concept. You just need to remember what is happening and you can answer this question. Now try to see this question and try to answer what is this particular thing. 1b is indicating what? What is going to be your answer now? वन बी क्या बता रहे हैं? दिस इज गोइंग टू बी इलास्टिसिटी और प्लास्टिसिटी. यस, दिस इज गोइंग टू टेल अस अबाउट द प्लास्टिसिटी है ना. Automaticity you will be finding in the automatically who will be working as a note, and contractility is a feature of what? Muscles, right? This is going to be a feature of muscles, right? So this is going to be what? Plasticity. You understand this thing? Now try to solve these questions. Renin is coming from which cells of the kidney? रेनिन कौन से सेल से आता है किडनी के? रेनिन is coming from the which cells of the kidney? This is going to be, yes, JG cells of kidney. Juxtaglomerular. Juxta मतलब पढ़ाया था, आज ही पढ़ाया था. Juxta मतलब near by the glomerulus there are going to be certain cells, and these are known as JG cells, right? Erythropoietin is coming from where? Erythropoietin is coming from the peritubular capillaries. अगर कुछ भी नहीं पढ़ा फिजियो में तो ये तो देख के जाना, इतना तो याद करके जाना, राइट? सो दिस इज कमिंग फ्रॉम द पेरिट्यूबुलर कैपिलरीज. Glucose and amino acid absorption in the kidney is going to happen with the help of what? In the PCT. How much percentage? 100% of glucose, 100% of amino acid is going to get absorbed with the help of which pump? SGLT 2 pumps. And what kind of transport is this? Primary active, secondary active? This is going to be your secondary active transport. ANP functions in the kidney. What is the function of atrial natriuretic peptide? This is going to cause what? Natriuresis. Natriuresis का मतलब क्या हो गया? What is the meaning of natriuresis? Natri means salt. Uresis means it's going to go out. So whenever there is going to be more pressure on the heart, what heart will do? It will release ANP, and this ANP is going to go to kidney, and it will cause what? It will cause natriuresis. That means the salt is going away from the body, and you very well know this. If the salt will go away from the body, what will happen? Water will also go away from the body, will lead to decrease in the pressure, right? So it is going to release the sodium, right? It will cause natriuresis. 1B in cystogram is based on which law? 1B in cystogram is based on which law? कौन सा law पे based है ये? This is based on a Laplace law. Laplace law, right? Laplace law is going to be there. Bartter syndrome is due to mutation in which thing? मैंने पढ़ाया था. If there is problem in the PCT, Fanconi syndrome. If there is problem in sodium potassium 2 chloride pump, this is going to be what? This is going to be sodium potassium 2 chloride pump problem. This is going to be what? The Bartter syndrome, right? Impaired function of aquaporin. Aquaporin काम नहीं कर रही. Aquaporins are due to what? They are working due to ADH, anti-diuretic hormone. अभी पढ़ाता हूँ आगे anti-diuretic कहाँ से आएगा. We will connect the whole story, right? This ADH is going to be there. And what is going to be the disease? This disease is going to be diabetes insipidus. Disease is known as diabetes insipidus. क्या हुआ यहाँ पर? Decrease in the ADH. Decrease in the ADH. अगर ADH काम नहीं करेगा, right? अगर ADH काम नहीं करेगा तो कौन सा disease होगा? This is going to be your diabetes insipidus. Diabetes insipidus, right? Simple समझो इसको. Why you are having doubts? Look here. So this is going to be ADH. Its function is to make what? V2 receptor. अगर ये अगर ये aquaporins नहीं बनाएगा, it is not going to make aquaporins. If there is decrease in ADH, there will be decrease in the aquaporins. If there is decrease in the aquaporins, there is decrease in the water absorption. If water absorption is not there, what will happen? This water will go out into the urine, and if there will be more water going out into the urine, this is known as polyuria, and polyuria is a symptom of what? Diabetes. Polydipsia will be there, and this is going to be telling us about the decreased ADH will lead to what? Diabetes insipidus, है ना. इनका दोनों अलग अलग है. उस डायबिटीज में भी क्या होता है? पोलियूरिया होता है, इसमें भी पोलियूरिया होता है, but the things are going to be different. Here insipidus will be having functioning of ADH, and there it is due to what? Hyperosmolar state, or due to increase in the glucose, right? Okay, got it. So this is about the kidney. Now the important thing we are having is endocrine system. What is the important question they are asking from the endocrine system? Let's try to understand this thing. So what is the most important gland that we are having in endocrine system? First of all, you will try to tell me what is this particular organ. ये कौन सा organ है? What is this particular organ? This area. Last FMG exam का question है. This area is known as they have given you the picture and they have asked you what is this particular thing. This area is what? This is no idea. Yes, very good. Godfather Pooja. Yes, this is corpus callosum. This is your corpus callosum. These are going to be the different lobes of the brain. These are the lobes. Sulci and gyri will be there. This is going to be corpus callosum. Here you will be having thalamus. Below thalamus you will be having this hypothalamus. And below hypothalamus you will be having a small gland. This gland is known as what? Pituitary gland, right? So here you will be having this hypothalamus, and this gland will be there. This is known as pituitary gland. This is going to be your midbrain, your pons, your medulla and cerebellum, right? एक बार these are going to be your image based question. ऐसे questions तो हमने गलत नहीं करने. 2-3 बार इनको बनाओगे अपने आप ठीक हो जाएंगे, right? What is this gland? Try to tell me what is this gland? What is this gland? Anyone? Here you will be having pathway for the CSF, right? Fourth ventricle, third ventricle. So let's try to understand what is this. hypothalamus is going to do? Hypothalamus will release total of 8 hormones. How many hormones beta? Total of 8 hormones. यही याद कर लेंगे. 7 are written. This 8th one is going to be what? Dopamine. These are going to be the total 8 hormones which are coming through this hypothalamus that are important for us. These are going to be total of 8 hormones are going to be there. Very good, Pooja. That was your pineal gland, है ना? वो pineal gland है पीछे. Right? So what are the hormones that are coming from the hypothalamus? These are going to be 4 stimulatory hormones. कौन से stimulatory है? Thyrotropin releasing hormone, gonadotropin releasing hormone, growth hormone releasing hormone, and corticotropin releasing hormone. These 4 are going to be what? These 4 are going to be what? Stimulatory hormones. ये चारों क्या है? स्टिमुलेट करेंगे, रिलीज करवाएंगे किसी ना किसी चीज को. नाम बोलो इनके. व्हाट आर द नेम्स? थायरोट्रोपिन, गोनेडोट्रोपिन, ग्रोथ हार्मोन रिलीजिंग हार्मोन एंड कॉर्टिकोट्रोपिन रिलीजिंग हार्मोन. ठीक है. 2 of them are going to be what? Inhibitory. 2 inhibitory है. First one is dopamine, second one is somatostatin. These are going to be what? Inhibitory hormones. Dopamine is also known as what? Prolactin inhibitory hormone. ये दोनों कैसे हैं बेटा? इनिबिटरी. सोमेटोस्टैटिन इज अ यूनिवर्सल इनिबिटर, जहां भी आएगा इनिबिशन करेगा. सो टोटल हाउ मेनी हार्मोन्स आर कमिंग फ्रॉम योर हाइपोथैलेमस? टोटल 8 you need to remember. 4 of them are going to be what? Stimulatory. 2 of them are going to be what? Inhibitory. 2 of them are going to be what? Inhibitory, dopamine and somatostatin. बचे हुए कौन से हार्मोन? वो वाले हार्मोन. What are those वो हार्मोन्स? Remaining are going to be your vasopressin and oxytocin. These are going to be 2 other hormones that we are having. So we have got वो hormone, right? These are your वो वाले hormone. These are your vasopressin and oxytocin. Or you can also remember wow. This vasopressin is also known as ADH. This vasopressin is also known as ADH. The same ADH we have learned in the kidney chapter. This is the same ADH, right? So vasopressin and oxytocin are the 2 other hormones which are coming from the hypothalamus. तो hypothalamus की कहानी समझ में आई. How many hormones total? 8 hormones, 4 stimulatory, 2 inhibitory and 2 वो वाले hormones. So what are these hormones? Where they will go? Let's try to understand how they are going to work, right? अगर आपको ये समझ में आ गया तो आपको आगे का भी समझ आ जाएगा, right? So this is going to be hypothalamus. This hypothalamus will be draining these hormones into the anterior and posterior pituitary. तो posterior pituitary में कौन से हार्मोन आएंगे बेटा? Posterior pituitary will be having वो hormone coming, right? What are those वो hormone? They are formed in the hypothalamus. They are coming to the posterior pituitary. First one is going to be your vasopressin. Another one is going to be your oxytocin. This vasopressin and oxytocin are coming to the posterior pituitary. और ये posterior pituitary से बाहर आएंगे. These are going to be your V and O, right? Oxytocin has got 2 important locations. What are those 2 locations? One, it will be working on the breast, right? It is going to do what? What is the function of oxytocin? In the breast, it is going to cause contraction. That is going to cause what? Milk ejection, right? It is going to cause milk ejection. Second thing, it is going to be drug of choice in PPH also. In PPH, you are going to use it as a drug of choice. In the induction of labor, it is also going to be the drug that you are going to use, right? So induction में and PPH में, this is the same oxytocin which has got receptors on the breast and uterus. So in breast, it is responsible for milk ejection. In the uterus, it is responsible for what? It is responsible in the uterus. It is going to be utilized for 2 things. That is going to be what? Induction of labor and PPH, right? So these are the 2 important things you need to remember about this oxytocin. दूसरा हार्मोन क्या है? This is one is going to be vasopressin. Vasopressin मतलब vessels को press करेगा. Also known as antidiuretic hormone, right? So it will go to the kidney. It will go to the kidney. Where exactly in the kidney? Now you tell me, where exactly in the kidney? Upper part of the kidney or lower part of the collecting duct? It will go to the lower part of the collecting duct, and it is going to make what? Aquaporins. It is going to make what? Aquaporins over there. And if you are having increase in the ADH hormone from the brain, what will happen? You will be having disease, SIADH. If you will have decrease in the ADH, you will be having what? Diabetes insipidus. Story over, right? So where it is coming from? From the hypothalamus. If they ask you ADH is formed where, the answer will be in the hypothalamus, right? It will be stored in the posterior pituitary. It will be coming to the lower part of the collecting duct, making what? Aquaporins. These aquaporins are going to be responsible for the water intake only. If you are having more ADH, you will be having SIADH. If you are having less of ADH, you will be having what? diabetes insipidus. This is what is simple story of this particular one, right? Now comes the anterior pituitary hormones. So anterior pituitary hormones, how many hormones are stimulatory? 4 we have seen. What are those 4? Let me summarize very shortly. The first one is going to be what? Thyrotropin. Second one is gonadotropin. Third one is growth hormone. Fourth hormone is corticotropin. So let's begin with the first one. Hypothalamus will release growth hormone releasing hormone. And this growth hormone releasing hormone will come to the anterior pituitary and it will release what? Growth hormones or IGF-1, insulin like growth factor 1. And this is going to responsible for the growth of the bones, muscles and all the organs that is going to be there, right? In pediatrics, you have learned about this thing. If you are having increase in growth hormone before the closure of the epiphyseal plate, you can have what? You can have gigantism. You can have growth hormone more after the closure of the epiphyseal plate. You can have what? Extremities will be long. This is going to cause what? Acromegaly. If you are having decrease in the growth hormone, you can have what? Dwarfism, right? Decrease in the growth hormone can lead to dwarfism. This is going to be the basic understanding that you should be having, right? Another hormone which is coming is going to be what? Gonadotropin releasing hormone. Gonadotropin releasing hormone will go to the gonads. It will go to the anterior pituitary, and now anterior pituitary will release what? LH and FSH. These are your luteinizing and follicular stimulating hormones. They will go to ovaries and testes, and they are going to produce what? Estrogen, progesterone and testosterone. They are having different functions. So this is going to be what? The funda for GnRH. Third one is going to be what? Third one is corticotropin releasing hormone. It will again come to the anterior pituitary, and now anterior pituitary will release what? Adrenocorticotropin hormone, ACTH, which will go to the adrenal cortex, and it will make what? It will make the like aldosterone. And we already know the function of aldosterone. This aldosterone will go to the kidney. Where exactly in the kidney? Lower part or upper part of the collecting duct? Upper part of the collecting duct. And in upper part, it is going to make what? Your channels. What channels? E-neck channels, which is going to absorb what? Sodium and water in body. And it is going to decrease what? Potassium and H plus in the body. Simple understanding. If you are having increase in aldosterone, cone, decrease in aldosterone will lead to adhesions. Simple, right? So this is going to be what? Third hormone. Lastly, we have got the last hormone which is going to be there is going to be what? Thyrotropin releasing hormone. Thyrotropin releasing hormone will go to the anterior pituitary again, and it will work at two places. This is your exam question. First thing everybody knows, it is going to increase the TSH, thyroid stimulating hormone, and this thyroid stimulating hormone will go to the thyroid gland, and in thyroid gland it is going to make what? T3 and T4, which will come into the blood vessel, which will cause what? Increase in the metabolism, activity of beta receptors, increase in the activity of the person. So these are your thyroid hormones, right? But the important question is, what about this prolactin? So examiner has asked this question in INI set also, and in NEET PG also, that you need to remember this particular thing. This prolactin is also under the control of what? TRH. The release of prolactin is also under the control of thyrotropin releasing hormone, and this is going to be taking care for the prolactin. And what is the function of prolactin? Pro means it is going to do what? Production of milk, right? Production of milk is going to be due to prolactin. So these are going to be your basic hormones and basic glands that we are having. You understand total how many hormones are coming from the kidney, coming from the brain, from the hypothalamus? Total are going to be what? 8. Thyrotropin we have seen the function, two important functions. One is in the thyroid gland, another function we have seen is the prolactin. Oxytocin we have seen in the breast, in the uterus we have seen this thing. Gonadotropin will go to the gonads. Remember kidney, remember your ovaries and testes are the gonads. They are not your internal genital organs, right? So these are the ovaries and testes where you will be having this GnRH will be working, and it will make what? LHFSH, which is going to be further working on the testes and ovaries for the ovulation and all those things which are happening, right? The another thing that we are having is about the growth hormone, which is going to be responsible for the growth of the overall person. Vasopressin we are having. We have seen the vasopressin role. This is also known as ADH, right? So this is what we have seen here, right? Now we are having certain secondary messengers. What are these secondary messengers? What are these secondary messengers? Just try to understand how our body is working. Just let me just give you a basic idea that you should be having. क्यों पढ़ना है सेल, है ना? So basically whenever a hormone is coming or a message is coming, this is going to come through a gland, and this is known as what? This is known as primary messenger. This is known as primary messenger, and this primary messenger will go to the receptors. This is going to be a cell, so we can have extracellular receptor, we can have intracellular receptor, which can be present at two locations. It can be inside the cell, intranuclear, it can be inside the cytoplasm, intracytoplasmic receptor. So these are going to be three locations for the receptor. They can be extracellular, outside the cell, they can be intracytoplasmic, they can be intranuclear. तो जब भी कोई भी ये मैसेज आएगा, दिस इज गोइंग टू बी हार्मोन, सपोज दिस इज योर T3, T4, this is a hormone which is coming from the gland. It will go to the cell of the gland, right? And what will happen now जब ये मैसेज आएगा, this message will be given to the nucleus. What is nucleus? Nucleus of the cell will be having what? DNA. It is a storage for DNA, and this DNA is going to make what? Your mRNA. This is going to be biochemistry, right? mRNA is going to be there, and mRNA is going to function to do what? Protein. What is the function of mRNA? ये क्या कराएगा? Protein synthesis कराएगा. And this protein synthesis, what is the site for protein synthesis? This is going to be your rough endoplasmic reticulum. And after that, this all things will be going to the Golgi bodies. You will be having Golgi bodies. The function is going to be what? Packaging, post-translational modifications, everything will be happening, right? And after that, this vesicle will be formed, and this vesicle is going to be there, and this vesicle is going to come out of the cell. This is known as what? Exocytosis. And after that, this is a thing which is going to be ready for the use, right? So this is how it is working, right? The first messenger is going to be what? Coming from the gland. This is known as primary messenger. When this first messenger will come to this extracellular receptors, there are certain receptors, these are known as extracellular receptors or serpentine receptors or GPCR. तो ये primary messenger यहाँ पर आएगा, and it is going to send a message inside, and this is known as what? Secondary messenger. Whatever message is coming inside, this is known as what? इसको बोलते हैं secondary messenger. This is known as secondary messenger. And we are having three important secondary messengers that you need to remember. आपने पढ़ा होगा cyclic AMP, cyclic GMP, right? IP3DAG system. So these are what? Secondary messengers. So IP3DAG, cyclic AMP, cyclic GMP, tyrosine kinase receptor, these are your secondary messengers. अब ये जाके nucleus में जाके आगे का काम करेंगे. They can make what? Certain units. So these are the examples that you need to remember, right? So these are going to be working via G protein coupled receptors, है ना? पूरा नहीं पढ़ना. Basic याद रखो. IP3 जब भी आएगा, it will increase what? Calcium. And whenever there is increase in the calcium, it will cause what? Vasoconstriction. Vasoconstriction, muscle contraction, and exocytosis. Let me write it simply. आपको एक सिंगल चीज याद रखनी है. What is the role of calcium in our body? Calcium body के अंदर तीन ही चीजें कराएगा. It is going to do three things. In the cell, it is going to cause what? In the vessel, it will cause what? Vasoconstriction. In the muscle, it will cause what? Muscle contraction. And whenever it will enter inside a cell, it will cause what? Release of something. This is known as what? Exocytosis. तो ये जिस भी सेल के अंदर जाएगा, उसमें से कुछ ना कुछ बाहर निकाल देगा. This is going to be what? Role of calcium in our body, right? So it will increase the calcium, and it will cause what? Now you can see it will increase the ADH. ADH is going to cause what? Vasoconstriction. V1 receptor will cause vasoconstriction. V2 will make what? Aquaporins. Angiotensin. Angio मतलब vessel, tensin मतलब again it is contracting. Oxytocin, again it is contracting. Thyrotropin releasing hormone, again it is contracting, right? So all the functions are going to be same. So you can simply remember IP3DHE मतलब क्या बढ़ गया? Calcium बढ़ गया. Cyclic GMP will always release nitric oxide, and it is a universal relaxer, right? It will always increase, it will always cause what? Relaxation of the muscles. This is what you can remember, right? So this is pretty much you need to remember about this particular gland. Now comes the next gland. This is going to be your adrenal gland. This adrenal gland is a gland which is also known as suprarenal gland. Suprarenal gland. यहाँ से क्या क्वेश्चन पूछा suprarenal gland से? They have asked the question, is there going to be a tumor? दो तीन क्वेश्चन पूछे. पहला देखो, what are the parts of this adrenal gland? It is going to have two parts. Outermost is known as what? This outer part is known as cortex. ये बाहर वाला cortex है, अंदर वाला जो है this is going to be medulla. So there are going to be two parts. Outer is going to be cortex, inner is going to be medulla. In FMG exam, they have given you this schematic picture and you need to identify. They have marked this particular structure. What is this? What is this area? Is going to release what, right? So you need to remember the adrenal gland will be having two parts. What are the two parts? Cortex and medulla, right? This cortex will itself has three layers: glomerulosa, fasciculata, and reticularis. These are the three layers, right? So what are these three layers are going to do? This glomerulosa is going to release what? Aldosterone. This fasciculata is going to release what? Cortisol. And this reticularis is going to release what? DHEAs or your androstenediones, right? These are going to be the basic understanding. So adrenal cortex is going to have three layers, and this cortex is working under the influence of what? अभी देखा था hypothalamus में से क्या निकल रहा था? Hypothalamus is releasing, let me complete the story for you, corticotropin releasing hormone. It will go to the adrenal cortex part and it will go to the anterior pituitary, and now anterior pituitary will be releasing what? Adrenocorticotropin hormone, and this HCTH is going to work on the adrenal cortex part, and it is going to release what? Aldosterone, cortisol, and DHEAs. And this is the same aldosterone which will go to where? Upper part of collecting duct, and it is going to increase what? E-neck channel production. कहानी समझ में आ रही है? And this E-neck channels are going to absorb what? Sodium and water. Right, so the same story is going to be there. You just need to connect it from the head to toe and you will understand how it is working. अगर ये बढ़ गया तो कौन हो जाएगा, ये decrease हो गया तो addition हो जाएगा, right? We are done with this, right? The next thing we are having is going to be what? Fasciculata, and the lowermost layer is going to be what? This is going to be reticularis, right? So this is going to be what? Zona glomerulosa, zona fasciculata, zona reticularis. Here also this is going to be cortex, this is going to be medulla, this is going to be zona glomerulosa, this is going to be zona fasciculata and reticularis. The mnemonic is GFR, again GFR, right? And here you will be having the adrenal medulla. Here you will be having the adrenal medulla, right? They have also asked one more question. So zona glomerulosa, zona fasciculata, zona reticularis. Glomerulosa will release mineralocorticoid, also known as aldosterone, है ना? Fasciculata will release what? Glucocorticoid, also known as cortisol, and they are going to release DHEAs or androgens, which are going to be reticularis, right? What about this medulla? This medulla is going to release what? Catecholamines. What are these catecholamines? These are your epinephrine, norepinephrine, dopamine, and they are going to be collectively known as what? Catecholamines. They are the neurotransmitter for what? For the sympathetic nervous system, है ना? तो इनका function क्या होता है वो आपने we have discussed in the full class, right? So what is going to be there? उनकी कहानी अपन ने पढ़ी हुई है, right? So these are going to be what? Catecholamines. If you are having a tumor, or let me simply give you, they are going to activate your sympathetic nervous system beta. And what are the receptors for sympathetic nervous system? Alpha 1, alpha 2, beta 1, beta 2, beta 3 इनको activate कर देगा, right? It is going to activate all the receptors which will lead to increase in the alpha 1 is responsible for what? Brush up कर लो. It is responsible for vasoconstriction leading to increase in the BP. Alpha 2 is acting as a brake. Beta 1 is present in your heart and kidney. In heart, it will increase the heart rate, increase the conduction, increase the contraction. In the kidney, it is going to increase the renin, and this renin is going to activate what? Again, vasoconstriction leading to increase in BP. This beta 2 will be causing what? Bronchodilation and skeletal and smooth muscle tremors, and this is going to be what? Activate your hormone sensitive lipase, which will cause what? Adipolysis, right? If you are having a tumor of this adrenal medulla, this is known as what? Pheochromocytoma. The tumor of adrenal medulla is known as what? Pheochromocytoma. अगर कुछ भी नहीं समझ में आ रहा तो क्या समझ में आ रहा है? सबसे बीपी बढ़ रहा है क्या? हार्ट रेट बढ़ रही है क्या? BP hypertension will be there in the patient. So if the patient is having pheochromocytoma, the same patient will be having what? Increase in heart rate, increase in conduction, increase in contraction, vasoconstriction, increase in BP, adipolysis, पतला हो जाएगा patient. Thin patient will be coming to you, young patient will be coming to you with all these symptoms of hypertension. Doctor सोचेगा इसको anxiety attacks आते हैं, but this is not the anxiety. Basically, this patient is having what? Pheochromocytoma, right? So they have asked the treatment part also. They have asked for the understanding diagnosis also. let me just give you. For diagnosis, you can go for metanephrine levels, plasma metanephrine's, urine test also you can do. Right, we can go for MRI, we can get the light bulb appearance, right, we can get the light bulb appearance, right. For the treatment, we can use what? Two drugs you need to remember. One is phentolamine, another one is phenoxybenzamine. Phentolamine and phenoxybenzamine has been asked previously in your recent examination, है ना, last 1 year में पूछा है दोनों drugs, so यही याद रखना है. So tumor of adrenal medulla is known as what? Pheochromocytoma. We can give what? We can understand this thing by the metanephrine, light bulb appearance will be there, phentolamine and phenoxybenzamines. These are going to be the drugs which will decrease the BP of this particular patient, right? Now comes the parathyroid gland. This parathyroid gland is going to release what, beta? Parathyroid gland is going to release what? Parathormone. And this parathormone is going to cause what? This parathyroid hormone is going to cause what? Breakdown of the bones. And bones is made up of two things, calcium and phosphate. This bone is made up of two things, calcium and phosphate, right? So this is important. Parathyroid hormone is going to break the bones, but it is going to activate your osteoblast. This osteoblast is going to activate your rank ligand, and this rank ligand is going to activate your osteoclast, and now this osteoclast is going to break the bone into calcium and phosphate. This is the basic understanding that you should be having. Why we are having, my question, why we are having in postmenopausal females we are having osteoporosis? Why we are having? The reason is pretty simple. You can understand this is going to be what? E2, estrogen is going to be there. This estrogen is going to activate a thing. This activation is known as osteoproteogenin, right? And this osteoproteogenin is going to be acting as a brake. It will be acting as a brake on rank ligand. So till the time you are having what? Estrogen, you will be having activation of osteoproteogenin, and this activation will lead to break on the rank ligand, and this rank ligand is not going to break the bone. So this is the basic cycle. But what happens in a postmenopausal female? You will be having decrease in the estrogen, right? If there is decrease in the estrogen, this osteoproteogenin will not get activated, and if it is not going to get activated, what will happen? The brake will be failed, and now you will be having what? Rank ligand will act on the osteoclast, and now you will be having bone breakdown, leading to what? Postmenopausal females will be having what? They start to have what? Osteoporosis, right? And what is the drug of choice for osteoporosis? Also tell me. What is the drug of choice for osteoporosis? This is also a very, very high yield topic from pharma. You will be learning it in pharma. What is the indication, when to give, right? This is going to be your bisphosphonates, right? The next thing we are having is about the growth hormone. What is the role of this growth hormone? What are these hormones, and what are the roles of these things, right? This is your growth hormone, prolactin, thyroid stimulating hormone. We have learned about everything. ACTH, follicular stimulating hormone. They are going to stimulate the follicles. LH is going to stimulate the ovulation, right? These are going to be the thing. ADH, we have already seen, it will absorb the water resorption in the kidney. It is going to absorb the water from the kidney. Oxytocin 2 function, we have seen, stimulate the uterine contraction as well as milk ejection. Same thing is written here, right? Just go through this table because they are asking one question from the hormone, right? Insulin is responsible for lowering the blood glucose. Glucagon is going to increase the blood glucose. It is going to decrease the blood glucose. And cortisol is a stress hormone which is coming from the glomerulus fasciculata, which is coming from the zona fasciculata, right? So these are the hormones we are having. Now comes, where do we have vitamin D production? Vitamin D3 production is going to happen in which layer? This is a question from Derma. They have asked, where do we have vitamin D3 production? And this is happening in the answer was in the question. They have written the answer, that is Malpighian layer. What is the answer they have written? Malpighian layer. What is Malpighian layer? Lowermost stratum spinosum and stratum basal together known as what? Malpighian layer, right? We are having 5 layers, right? These are your let's grab some burger, right? So these are the 5 layers of the epidermis: stratum corneum, stratum lucidium, stratum granulosum, spinosum, and basal. These two together are known as what? Malphizian layer. These two are known as Malphizian layer. So what is the light source that is required, beta? That is going to be what? UVB rays are required, and first thing is going to be what? Conversion of 7D hydrocholesterol into cholecalciferol. This is going to be what? Vitamin D1. So first thing that is going to happen, this cholesterol is going to convert into cholecalciferol, which is known as vitamin D1. And the richest source, another question, the richest source of vitamin D3, kaun si fish hai? Mushroom, you already know. Which fish is going to be the richest source of vitamin D? Right? Now what will happen? This D1 or cholecalciferol will come into the liver, and you will be having hydroxylation process, right? Hydroxylation process is going to happen on which position? On the 25th position you will be having hydroxylation. So what will happen? Now it will become 25 hydroxy cholecalciferol. The same cholecalciferol, we call it what? 25 hydroxy cholecalciferol. Again the same compound will go into the kidney, and here also you will be having again hydroxylation, but at what position? Again on the first position, and now it will become what? 1,2,5 dihydroxy, 2-time hydroxylation, cholecalciferol. This is also known as calcitriol, also known as vitamin D3. Remember, this vitamin D3 is also acting as a hormone, right? Vitamin A and vitamin D, they are acting as a hormone also, right? So this is how we are going to make D1, D2, D3. What is the source? Source is going to be what? Halibut. Halibut is the fish that is going to be the source of this vitamin D, right? Now try to solve this question. A 30-year-old female patient is going to be there with the symptoms of excessive weight gain, cold intolerance, and menstrual disturbances. The diagnosis was Hashimoto thyroiditis. It is an autoimmune condition. What is the antibody that is going to be there? What is your answer in this case? Hashimoto. What is the antibodies are going to be there in Hashimoto thyroiditis? The antibodies are going to be what? Against the thyroid peroxidase enzyme, against the TPO enzyme. So what antibodies are going to be there? Anti-TPO antibodies are going to be there. This is going to be the answer in this case, right? Now certain one-liners, try to solve. Leydig cells are responsible for the release of, Leydig cells are responsible for the release of what? Which hormone will be coming out of Leydig cells? This is going to be testosterone. This is going to be testosterone, and this testosterone is going to make what? Internal genitalia of the male person, right? This is going to be the testosterone. Erythropoietin is secreted from, we have already done this, 2 times asked question, peritubular capillaries. Right? Oxytocin is secreted from. Now your answer, oxytocin is secreted from. This is another question they have asked 3 times. Even it is a simple question, they have asked 3 times. Oxytocin is secreted from, it is formed where? It is formed in the hypothalamus. Remember, wo hormones. This wo hormones are formed in the hypothalamus. They will be stored in the posterior pituitary. And from posterior pituitary, कौन से हार्मोन निकलते हैं? This is वो hormone, vasopressin and oxytocin, or wow, you can remember vasopressin, ADH, or oxytocin. Thyroid hormone will bind with, they will bind with the thyroid binding globulin. Or transthyretin, right? This is going to be what? Thyroid binding globulin. What is the action of PTH for the on the bone? It is going to break the bone. We have seen the pathway, how it is going to break the bone. It is going to break the bone into calcium and phosphate. Another question, nitric oxide is synthesized from which amino acid? What is the amino acid that is going to be making what? Nitric oxide. Nitric oxide is synthesized from, yes, Godfather, Dr. Khan, Pooja, Jovita. Tell me. Previous year question. Nitric oxide is synthesized from which amino acid? This is going to be your arginine. Arginine, right? Arginine is important. This is your previous year question. They've also asked you epinephrine, norepinephrine, and dopamine, tyrosine, sorry, T3, T4, melanin. They are coming from which amino acid? They are coming from which amino acid? They are the precursor of which amino acid? Which is present in black coffee or tea. This is going to be, yes, Ninad, very good. This is going to be precursor of tyrosine. Tyrosine is going to make what? Epinephrine, norepinephrine, dopamine. That's why we are having tea, coffee in the morning. This tea and coffee will be having this tyrosine, right? Now comes a very, very important chapter. Last time also I have covered this particular thing, and 2 questions from these 2 slides they have asked in the examination, and every year they are asking this type of question. So we are going to understand what is this cardiovascular system, how it is going to be there, and what is the utilization of these graphs. Very, very important. Stay alert, right? We are having 2 important graphs here. The first one is for the SA node, another one is for the normal myocyte. Myocyte matlab it is a cell of the ventricular muscle, right? So this is going to be ventricular myocyte action potential graph that we are having. So let me just try to make you understand one graph. अगर आपको एक graph समझ में आ जाएगा, you will also understand how the current is moving in our body. अगर मुझे contract करना है, if I want to contract my hand, how I am going to contract my hand, from where this power is coming, how the impulses are traveling in our body. You understand one cell, you will understand a lot of things. You will also understand how your heart is working. We will understand all those things, right? So let me just try to give you a basic insight behind this particular thing. So this is going to be what, suppose these are the cell. You need to understand certain cells. So these are multiple cells we are having, right? So these are multiple cells we are having, and we already know this cardiac myocytes will be having what? Gap junctions. So these are your gap junctions. These are your gap junctions. Now let's try to understand one cell, and you will understand all other cells very easily. This is a graphical representation of a single contraction. Let's say this is 1 second. This is a graphical representation. आपके heart की muscle के जो cells हैं, the cells that you are having in your heart muscles, we are learning about that cell, right? If you understand single contraction, you will understand the complete entity, right? So first thing, what is going to happen? The first ion which is going to come inside is going to be what? And certain words you need to remember. What is the meaning of depolarization? What is the meaning of repolarization? What is the meaning of systole? What is contraction? Right? Let's try to understand this particular thing. So देखो, resting membrane potential क्या होता है? First thing is going to be what? What is RMP? Resting membrane potential. Resting membrane potential means there is going to be certain ion outside, like sodium we already know is the extracellular cation, right? We already know potassium is going to be inside, chloride is going to be there, bicarbonates are going to be there. So what is the meaning of resting membrane potential? This is the potential difference. This is the current difference between outside and inside. This is known as resting membrane potential. Yani, the simple meaning is at rest, what is the difference between these two current? This is known as resting membrane potential. So at rest, we already know. One more thing, last thing you need to remember here, there is going to be a window through which this potassium can leak out, right? So let's try to understand what is this resting membrane potential. For certain cells like cardiac myocyte, it is going to be minus 90 millivolt. So minus 90 millivolt is the resting membrane potential. That means when this cell is in the resting state, there is nothing going out, nothing coming in. The cell is in the resting state. What is the current difference here? This is going to be what? Minus 90 millivolt. This is the basic understanding that you should be having. Okay, let me draw a graph for you so that you can understand it better. So suppose this is going to be a normal graph that we are having, and this is going to be a point where there is going to be minus 90 millivolt. let's say this is going to be a point where there is going to be minus 90 millivolt, and this is the resting membrane potential. Now what will happen? The ion tries to enter into this particular cell and sodium will come inside. Just try to understand, whenever a sodium charge will come inside, what will happen to the current? It will move towards the positive, yes or no? When sodium, lots and lots of sodium will come inside, it will become positive, yes or no? Normally it was minus 90, it will come towards, suppose this is plus 20, here you will be having 0, like that it will be increasing. So whenever sodium is going to come inside, what will happen? This potential will go towards the positivity, yes or no? This is going to be known as what? Action potential. This is known as action potential. First thing will be sodium will come inside. Second thing will be, whenever sodium will come inside and it will touch the point plus 20, you know what happens? There is going to be another channel which is going to get opening, and what will happen? This potassium will start to leak out. This potassium channel will open, and now what will happen? Potassium is a positive charge, it is going out of the cell. What will happen? This current will come towards the negative, yes or no? So this is going to give you a plate. This phase is going to be there, this current is going to, this graph is going to come below, and as soon as it will touch the point 0, what is going to happen? Another channel is going to open, and this channel is going to be for what? For calcium. And now who is going to come inside? The calcium is going to come inside the cell, because calcium channel are going to get open, and calcium is what kind of a charge? Positive charge, and potassium start to leak out. So what will happen? There is going to be a plateau phase is going to be there. So this is going to give you a plateau phase. And lastly, what is going to happen? This calcium channel will get closed, and you will have opening of these multiple potassium channels, and this potassium will leak out till what time? Till the time it will come back to its original नेगेटिव पोजीशन, ओरिजिनल माइनस 90 पोजीशन. सो ये कब तक बाहर निकालेगा इसको? So this is going to remove the potassium till what time? Till the time it will come back to its original negative position. Did you understand this thing? Give me a quick confirmation, right? So this is going to be known as what? Action potential graph. Now comes the important application part. देखो पहली चीज जो अंदर आएगी, this is going to be what? This is sodium. Then you will have release of potassium. Then you will have entry of calcium, and then you will have what? Again release of potassium. And this is what we are made up of. हम लोग इन्हीं चीजों से बने हुए हैं, right? You will understand this thing. You will understand how we are working, right? So first of all, one cell will get depolarized. Now what is the meaning of depolarization? Depolarization मतलब होता है कोई भी सेल का पॉजिटिव होना. So what is depolarization meaning? Any cell is becoming positive. This is known as what? Depolarized cell. This is known as systole. This is known as contraction. All these things are going to be similar. So what is depolarization? What is systole? What is contraction? Everything is going to be same, right? Once this cell will get depolarized, beta, what will happen? The impulse will transfer to another cell. This will get depolarized. Now this cell will get depolarized. Now this cell will get depolarized. Now this cell will get depolarized. And this is how the wave of current is going to move in your body. You understand this thing? कैसे ये current move कर रहा है? So this is how the wave of current is going to move in your body. This is how this current is going to be moving, right? Now what will happen to the backward cell? It will come back to its original position, that is minus 90 millivolt. Very simple, right? It will again come back to minus 90. It will again come back to minus 90, and the wave of current is going to move like that. You understand how this depolarization is going to take place and what are the different steps? So they are going to ask you certain question. They will ask you, what is this phase 4 is indicating? This is going to be what? Resting membrane potential. What is this phase 0 is indicating? This is going to be due to influx of sodium. कौन अंदर आ रहा है? This is due to sodium influx. What is this phase 1 is indicating? Who is going to go out? Now potassium will start leak out. This is going to be due to potassium efflux. Phase 2 is due to, now who is coming? Calcium influx and potassium out efflux, right? So calcium अंदर आ रहा है, उसकी वजह से phase 2. And phase 3 is due to what? Who is going to go out? Potassium efflux. इस क्वेश्चन को हम गलत करेंगे क्या? This is not a question you are going to make wrong in the examination. This is a simple graphical representation of a single cell. समझ में आया ये? Did you understand this? So this is a simple graphical representation, and this is how the current will be moving in this particular direction, and this is what is going to be the phases that we are going to have. Now comes a SA nodal cell. SA nodal cells are the cells that do not have the resting membrane potential. Rather, they will be having a special potential. This is known as what? Restless membrane potential. पेसमेकर को पेसमेकर क्यों बोलते हैं? बिकॉज दे आर हैविंग व्हाट, why do we call pacemaker as pacemaker? Because they are having restless membrane potential. That means they are not at a fixed potential like this. They are having a potential which is oscillating between a range. So what is the oscillating range we are having here? Minus 60 to minus 40 millivolts. So they are going to have a resting membrane potential which is oscillating between minus 60 to minus 40 millivolt. Funda remains simple. Funda is going to be simple. जब भी किसी सेल के अंदर पॉजिटिव चार्ज आएगा, यू कॉल इट एज अ डीपोलराइज्ड सेल, यू कॉल इट एज अ सिस्टोल, यू कॉल इट एज अ कॉन्ट्रैक्शन. व्हेनेवर अ सेल विल कम बैक टू इट्स ओरिजिनल पोजीशन, यू कॉल इट रीपोलराइजेशन. बहुत ही आसान हो जाएगा. दिस इज गोइंग टू बी नोन एज डायस्टोल, दिस इज नोन एज रिलैक्सेशन. वेरी सिंपल. Yes or no? Right? So this is how we can understand this thing, and you can apply this thing into your knowledge also. Just try to understand this thing, right? So what we are having, this is a cell which is having a restless membrane potential which is oscillating between minus 60 to minus 40 millivolts. Now, if I want to make this cell depolarize, what I need to do, beta? I need to put positive charge inside, yes or no? So there are going to be three ways, very important for FMG NEET PG. Direct question they are asking from here, very important topic, right? There are going to be three important phases for this particular one. This phase 4 is known as what? Pre-potential. It is due to three things. First thing, funny sodium channel. Second thing is calcium channel. Third thing is decreased potassium efflux, right? So funny sodium channel, first thing is going to be what? If I put sodium inside, what will happen? This cell will get positive, yes or no? Positive. Can I call it depolarized? Yes. Second thing, transient type of calcium channel. Calcium is also what kind of a charge? Positive charge. So if I give positive charge, again this cell will get depolarized. Third thing, I told you every cell will be having electrical window, and through this window who is going to leak out? This is the potassium which is leaking out. And if the potassium will leak out, what will happen to the cell? It will become negative, right? So if I close this leaking out, if I block this particular thing, is it going to accumulate the potassium inside? Yes. And these three things are responsible for what? Membrane potential of SA node. These three things are responsible. So examiner क्या question पूछेगा? First question, phase 4 here in SA node is known as what? First thing, pre-potential. Phase 4 here it is known as resting membrane potential. Phase 4 is due to what? First thing, phase 4 is due to what? Funny sodium channel. Second thing, transient type of calcium channel. Third thing, decrease in potassium efflux. These are the three things, right? Once you will reach this threshold value, once you will put enough positive charge, like the cell was in minus 60, now we are putting sodium, calcium, and you are blocking this potassium exit also, it will reach towards minus 40 millivolts. Once it will reach minus 40 millivolts, what will happen? Another channel will open, and what is that channel? This is going to be your calcium channel, and these are going to be L type calcium channel. That means long lasting type of calcium channel, which is going to pour the calcium inside, and because of this calcium, what will happen? The potential will reach towards a point of 10, and this is how this contraction is going to happen. And after that, what will happen? Again, this is going to get closed, and now you will start to have what? Leakage of potassium. Again, potassium will go out, and till the time potassium will come back to its original position, it will be going out, right? So it will bring the cell back to its basics, back to its repolarized state or normal state. So this is going to be what? Known as a pacemaker cell. This is a single contraction, 1 second contraction. So if this cell is contracting once in a 1 second, this is going to be having, what is the heart rate? This is a SA nodal cell, so heart rate will be 60. Heart rate will be 60. Now just try to apply the concept, a very important concept. Suppose if this cell is contracting once in a 1 second, this is going to have heart rate of 60. Very simple, right? If I want to increase the heart rate, or what sympathetic nervous system will do, this sympathetic nervous system will increase the slope of pre-potential. So it will increase the slope. If slope will be increased, what will happen? 1 contraction, 2 contraction. So how many contraction in 1 second? Now you are getting 2 contraction in 1 second. What will be the heart rate, beta? 2 contraction in 1 second. That means the heart rate will become what? 120. You understand how this body is working, how sympathetic, parasympathetic, and what are calcium blockers, sodium blockers are doing? Basically, they are putting the calcium and sodium inside. If you block this sodium and calcium entry inside, sorry, if you block this calcium and sodium entry inside, do you think this cell will get contracted? If it will not contract, what will happen to the heart rate? It will increase or decrease? It will decrease, right? So parasympathetic nervous system or calcium blocker, sodium blocker will decrease the slope of nervous this particular graph, and now you will be getting half contraction in 1 second. So what will be the heart rate? Half contraction in 1 second, heart rate will be 30. This is just a hypothetical thing to make you understand how it is working, right? So this is going to increase the slope, we can decrease the slope, and we can understand this thing. But what examiner is going to be asking you from here is going to be, what is this phase 4 is telling us about? This is telling us about the resting potential. Here the phase 4 is telling us about the first question, pre-potential. Second question, depolarization is due to what? Here it is due to sodium influx. Here it is due to L type of calcium channel are going to come inside, and this is going to cause what? Contraction. They will not ask you about the phase 3. Here also it is due to potassium efflux. Here also it is due to potassium efflux. So potent questions are going to be first one. Pre-potential is due to what? All except the answer will be what? Answer will be one odd one out. Here it is going to be depolarization due to what? Calcium channel. Simple understanding, right? So this is what is basic you need to remember. What about this resting membrane potential? Resting membrane potential for SA node, it is going to be what? RMP, which is not going to be resting. It is going to be oscillating between a value of -60 to -40 millivolt. For a neuron, it will be -70 millivolt. For ventricular myocytes, Purkinje fiber, skeletal muscle, it will be -90 millivolts. So you just need to remember about the neurons and pacemakers. What about this equilibrium potential? Equilibrium potential for potassium is -90. Equilibrium potential का मतलब क्या होता है? This is going to be a potential at which there is going to be no exchange. So when it will reach the -90, it will not remove extra potassium. This is known as what? Equilibrium potential. You can calculate this thing with the help of Nernst equation. You need not to remember about in detail. Just remember these some common equilibrium potential that we need to remember. For calcium, you can remember 130. For chloride, you can remember -70. -70 is for the chloride. Examiner has asked one more question, right? They have asked you one more question. Nerve potential is equal to. If they ask you same question, they have asked twice. Nerve potential is equal to, your answer will be what? It is equal to chloride, that is -70 millivolt. If they ask you nerve potential is close to, if they ask you close to, then your answer will be along with the potassium. This is going to be what? -90 millivolt, right? So you can remember it is equal to chloride, it is close to potassium. Simple understanding, very important topic. They have asked these two questions, right? Just remember these two statements. They can ask you these two statements, you can answer this, right? So we have got, you understand how a pacemaker is working, you understand what is this particular myocyte is working, right? You understand this thing. Now comes a very important question. Just try to mark this question. Last time also they have asked this question. Do you understand this thing? This is a pressure volume graph. What is this point C is corresponding? What is this point C is corresponding to? So this is a graphical representation of heart. This is known as cardiac cycle. This is known as cardiac cycle. Point C, you are telling me opening of aortic valve. Dr. Nerd, Dr. Prabhakaran, Motil, Pooja, Jovita, everyone is marking D. Point C is corresponding to what? Answer is D, S1 due to opening of aortic valve. So this is a wrong concept we are having. We need to improve this thing, right? Give me your complete focus. I'll make you understand this thing crystal clear within like 5 to 7 minutes. We are going to cover this particular concept, and you will also understand about the murmurs and all those things with the help of this particular concept. Okay, so let me make you understand. Let me draw a simple heart for you first, and we will follow the heart. This is your heart. We are having 4 chambers in the heart. This is your right atrium, this is your right ventricle, this is your left atrium, this is your left ventricle. Between right atrium and right ventricle, we give the bigger number, this is tricuspid valve. Between left atrium and left ventricle, we give the smaller number, this is mitral or bicuspid valve. This is going to be the basic thing. The blood from the body is going to come into the right atrium. This is your deoxygenated blood. It will be coming via the vena cavas, right? It will drain into the right ventricle, and from the right ventricle, this blood will be going into the lungs for the oxygenation. And here we are having a valve. This valve is known as pulmonary valve. This is going to be pulmonary valve, right? From the lungs, it will get the oxygenation, and after oxygenation, this oxygenated blood will come into the left atrium. This is going to be the oxygenated blood which is coming into the left atrium, and from left atrium it will go to the left ventricle, and through the left ventricle it will go towards the aorta to the body, to the complete body for circulation. This is a schematic diagram of your heart. This is a schematic diagram of your heart. Let me make you understand how this graphical representation is going to be working along with this particular thing. You know what is IVC, what is what is going to be your pressure volume graph, what are the different changes which are going to be there. We will discuss each and everything. Just understand this graph from the basics, from the zero. I'm trying to make you understand, right? 5 minutes and you will be done with this particular thing, right? So for now, just assume this is going to be what pressure volume graph. On the x-axis we are having the volume, on the y-axis we are having the pressure, and I am assuming a point here. Let me just assume a point here. Suppose this is going to be your point number B. This is going to be your point number B, and at point B I am assuming I am having what, 120 ml of blood is going to be there. One more thing you need to remember, we are having 4 valves in our heart. These are the 4 valves, right? What are these 4 valves? We are having pulmonary valve, aortic valve, tricuspid valve, bicuspid valve. These are the 4 valves you are having, and the function is to open and close. You will only get the sound whenever there is going to be closure of the valve. There is going to be a sound is going to be there. Simple understanding, when you will get the sound, whenever there is closure of the valve, right? Now I am dividing my heart into 2 halves. One is going to be this part, another one is going to be this part. I will teach you about this half and you will automatically understand this half. Whenever I will say closure of mitral valve, you will appreciate tricuspid be closed hoga. Whenever I will say aortic valve is getting closed, you will appreciate this one is also getting closed, right? So this is going to be a basic cycle. For now, just assume I am having 120 ml of blood in my left ventricle. Kitna blood hai? 120 ml. Now, can I open this valve and can I send all this blood directly into the aorta? No, I cannot do that, right? Why? Because the walls of this ventricles, can you appreciate, the walls of ventricles are going to be small or bigger? They are going to be bigger. Why they are bigger? So that they can send the blood to the complete body. तो इनको क्या करना पड़ेगा पहले? क्या directly ढक्कन खोल देंगे? No, we are not going to open this directly. First, we need to generate the pressure, right? So at point B, assume I am having 120 ml of blood in my left ventricle. ये 120 ml blood is going to be there. You understand one cycle, you will understand complete cardiology from this particular aspect, right? So this is going to be 120 ml blood is going to be there. Now I cannot open this valve directly. Aortic valve nahi khul sakta directly. I cannot open this. First I need to generate the pressure. I need to generate the pressure, and this is a pressure generation. This is known as isovolumic contraction. Isovolumic means on the same volume I am going to contract my heart 120 ml. I am going to increase the pressure in the walls of ventricle and it will increase the pressure. Till what point I am going to increase the pressure? Till the point it will reach a certain value कि यहाँ से अगर मैं ढक्कन खोलूंगा तो पूरी बॉडी में ब्लड चला जाएगा. So this is going to be a certain volume we are having at point C. So you can appreciate at point C what is going to happen. At point C what should be happening? Let me write ABCD also. So at point C what is happening? Which valve will be opening, beta? Can I open the aortic valve? I can open the aortic valve, and what will happen? At point C I have increased the pressure. I am having 120 ml blood here. At point B I am increasing the pressure. Abhi blood nahi aa raha. I am just increasing the pressure in my ventricle valve, and now at point C I am going to open this valve, and what will happen? This 120 ml will go into the aorta, it will go into the body. So you will be having 2 phases. You will be having rapid ejection, you will be having what? Slow ejection. और ये सारा ब्लड कहाँ चला गया बेटा? ऑल दिस ब्लड विल बी गोइंग इनटू द body. After this blood will be going into the body, do I need to close this valve? Do I need to close the aortic valve? Yes or no? Yes, we are going to close the aortic valve. So this is going to be the point where you will be having the closure of the aortic valve. So at point D, you will close the aortic valve. And I have already told you, whenever you are going to close a valve, you will get a sound. And what is the sound? सिर्फ बंद करोगे तभी आवाज आएगा. कौन सा साउंड होगा बेटा? ये दिस इज गोइंग टू बी S1 और S2. दिस इज गोइंग टू बी योर S2 ड्यू टू द क्लोजर ऑफ द aortic valve. अभी ये ढक्कन बंद हो गया. दिस इज गोइंग टू बी 120 ml was there. Out of that some amount will be going into the body and now this valve is getting closed. But यहाँ पर कुछ amount बच जाता है. Some amount will be left here. How much is left here बेटा? Here you will be having 50 ml of blood will be left here. कंप्लीट एम्प्टिंग नहीं होता. देखो यहाँ पर 20, 40, 50 ml is going to be left here. Out of that 120, 50 ml यहाँ पर बच जाएगा and this 50 ml is going to be there. Now can I open this valve directly? This valve is closed. Just think it, imagine it. If you will understand this thing, you will understand all the murmurs very easily. Now imagine this particular thing. You are having 50 ml of blood over here and this valve is closed. If I open this valve, it is going to have lots of pressure. What will happen? This blood will backflow into the left atrium. Yes or no? Yes, it can backflow into the left atrium because we are having lots of pressure here. Because look at the pressure graph. We are having lots of pressure. First I need to decrease the pressure, and this phase when you will be having decreasing in the pressure, this is known as decreasing pressure on the same volume. This is known as isovolumic relaxation. This is known as isovolumic relaxation. Till what point I will be decreasing the pressure? Till the point it will come to the zero. जैसे ही ये zero पे आएगा, when the pressure is going to be zero, what can I open? Now I can open the mitral valve. Yes or no? क्या mitral valve खोल दूं? Yes, because the pressure here is zero. Amount of blood is going to be 50 ml. I can open this valve. So what will happen? So that extra blood can come into my ventricles, right? And here you will be having what? Filling will start to happen. Till what point this filling will be happening? Till the time it will get 120 approximately, right? When 120 ml is going to be here, now it will tell close this valve. And closure of mitral valve will be there, and closure of mitral valve will produce which sound? At point B, what will happen? At point A, just let me write the point number A. At point A, what will happen beta? At point A, when the pressure will become zero, opening of mitral valve will be there. Opening से कोई sound आएगा क्या? It will not produce any sound. But at point B, you will be having what? Closure of mitral valve. And if you are going to close the mitral valve, closure will produce some sound. What is that sound you are going to hear? This is going to be your S1 sound. S1 sound. You understand this thing? Let me repeat the cycle. You will understand this thing clearly. You are having how much blood here? 120 ml. Can I open this valve directly? No. First I need to do what? Increase in the pressure. This is known as what? Isovolumic contraction. Till what point? Till the point C. Now what will open? Aortic valve will open. How much blood will go into the body? 70 ml. How much is left here? 50 ml. This is going to be what? 50 ml is going to be there. 70 is going to go out. Now, can I open the mitral valve? No. First, I need to decrease the pressure. What is the pressure decrease? This is going to be decrease in the pressure, isovolumic relaxation. And at point A, you can open the mitral valve and you will start to have what? Filling will be there. Till what point this filling will be there? Till the time it will get 120 ml. And now once again 120 ml will be there. We will have closure of the mitral valve and this is going to produce you S1 sound. And then you will be having what? Again, you cannot open directly. First, you need to generate the pressure. You will generate the pressure. It is going to throw the blood away. You understand? This is a very simple cycle that we are having. Now, let me make you understand what are the different terminologies that medicine people are talking about, or you know about them. Do let me know. Do you know what is end systolic, what is end diastolic, what is a murmur, what is a ejection, what are the different things we are having? Or let me just give you a short simple story. So you already know S2 is due to what? Closure of aortic valve. S1 is due to what? Closure of mitral valve. Now I'm dividing this cycle into two halves. मैंने एक चीज बताई थी ऊपर. Whenever there is going to be contraction, whenever there is going to be systole, whenever there is depolarization, they are the same thing, right? So let's try to understand. I'm dividing my cycle into two halves. The upper half is going to be what? Systole. The lower half is going to be what? Diastole. देखो बोल सकता हूँ क्या? Let me verify this thing. Isovolumic contraction. Contraction means systole or diastole? Systole, right? Rapid ejection. Ejection means systole, diastole. Ejection is systole. Slow ejection, it is also systole. So this is going to become what? Systole, right? And whatever volume you are having at the end of systole, this volume is known as what? End systolic volume. So what is the end systolic volume? At the end of the systole. Systole is starting here, it is ending here. The volume is going to be known as end systolic volume. If you think about this thing, this is going to be relaxation, relaxation. At the end of this thing, relaxation, this is known as diastole. So whatever volume we are having here, this is, can I call it end diastolic volume? Yes, this is end diastolic volume. So end systolic volume and diastolic volume. And you can also appreciate one more thing. What is that? Stroke volume is going to be what? Stroke volume is end diastolic volume minus end systolic volume. What is end diastolic? 120 ml. What is end systolic? 50 ml. 50 ml is end systolic. So what is stroke volume here? 70 ml is the stroke volume. And you already know, I told you, cardiac output is heart rate times stroke volume. So if the heart rate is 75 and stroke volume is 70, can I say approximately 4.9 liter of blood is coming out per minute? You understand how beautiful this thing is, right? So this is how it is going to be there, right? I told you cardiac output heart में से 1 मिनट में 5 लीटर ब्लड बाहर आता है. कैसे आता है समझ में आया? सिंपल है, कोई दिक्कत नहीं है, right? But sometimes they can also confuse you. In certain questions they are going to write you what? Instead of end diastolic volume, they can write you sometimes preload, sometimes afterload. So what is preload? What is afterload? What is preload? Pre मतलब पहले, load मतलब contraction. So before the contraction, how much blood is there? This is known as preload. Before the contraction, load मतलब contraction. So before the contraction, how much blood is there? This is known as preload. After the contraction, how much blood is there? This is known as afterload. Load का मतलब समझ लो बस contraction, right? So what is afterload? This is going to be 50 ml. What is preload? This is going to be 120 ml. You understand this thing? And you are having what? Murmurs, right? This is your S1 sound, this is your S2 sound. You think about it. S1, S2, S1, S2. You hear this sound? We are having S1, S2. This is your S1, this is your S2. Any sound you are getting here in this particular phase, this is what kind of a murmur? Systolic murmur or diastolic murmur? So anything you are getting between S1 and S2, this is going to become what? Systolic murmur. This is your lub sound, this is your dub sound. Anything you are getting from this particular one till here, this one, this is known as diastolic murmur. If it is coming in this phase, this is going to become early systolic murmur, mid systolic murmur, late systolic murmur. You understand? They are not difficult. You just need to understand this thing, right? If complete cycle will be having murmur, this is going to become what? Continuous murmurs like we are having, right? Early diastolic murmur, mid diastolic murmur, late diastolic murmur. You understand what is happening? This is just a single contraction. If you understand, you will understand these things nicely, right? Just a brief overview I want to give you so that all this concept will get brushed up, right? And you can utilize this information further. You understand what is this point? Now you can tell me in this particular diagram. Leave the question, just look here. Tell me what is this point B? Who is going to open at point B? Who is going to open at point B? Who is going to open at point B? Point A will be? Very good. Very good, Nurse, Jovita, Pooja. I'm glad you guys are understanding, right? So this is going to be what? At point B, you will be having what? Opening of the aortic valve. Here you will be having rapid ejection, slow ejection. Point C, you will be having closing of the aortic valve. Where do you get the S1 sound? This is going to be your A point. Where do you get the S2 sound? This is going to be your C point. Simple, right? Is it difficult? Now you can solve this type of question very easily. In the following graph, the point C is corresponding to what? Now you tell me the answer. Point C is corresponding to what bit at this point? Everyone mark your answer. At point C, what is going to be there? I hope it is clear now. Point C is going to be what? There will be closure of aortic valve, and aortic valve closure will lead to what sound? S2 sounds, right? So what is going to be the option? S1 is cut, right? S2 is due to opening of the mitral valve. So opening will not give you any sound. Automatically the answer will be what? S2. Very good, right? Wonderful, wonderful. These two questions you can appreciate. These two questions can come in your examination again this time also. You can appreciate on 28th of June you can find these questions in your examination. Definitely there is a very high chance they can be there. Another important question is going to be what? JVP, jugular venous pressure. Very simple now. Just look here. JVP is the complete story of what beta? Right atrium. Just look at the right atrium, you will understand JVP very nicely. There is going to be nothing in JVP. It is the condition of the right atrium, and this is what we are making it graphical representation. This is known as what? JVP, jugular venous pressure. So what happens in jugular venous pressure? Just try to understand this thing. You have already got the concept. You can apply this information, right? Look here. A wave is going to be there. A wave is telling us about the atrial contraction. So this is a venous pressure. So atrial contraction मतलब क्या होगा? जब atria contract होगा, when the atrias will contract, what will happen? Here, do you think the pressure will increase? Yes. And if there will be increase in the pressure, what will happen? It is going to give you a big wave. This is known as A wave. Now what will happen? The blood will come into the ventricles, yes or no? After atrial contraction, the blood will come into the ventricles, yes or no? So what will happen? There will be decrease in the pressure, yes or no? Yes. But now what will happen when this blood will be 120 ml, 120 ml will be in the ventricles, this ventricles will start contracting, yes or no? This ventricles will start contracting, and due to contraction, what will happen? This bulging of tricuspid valve into the right atrium. Just think like that. This is a lower chamber. This is another lower chamber, and here there is blood. If the pressure will be increased, what will happen? This lower chamber will try to bulge into the right atrium, right? So this right atrium bulging of tricuspid valve into right atrium during which phase? During isovolumic contraction. You understand the same phase. When isovolumic contraction is happening, it is developing the pressure. What will happen? Because of the blood, this pressure will lead to what? Increase in this bulging, and this is going to give you a small C wave. And this is your exam question. C wave is due to what? So C wave is due to what? Because of the pressure increase, what will happen? This tricuspid valve will try to bulge into right atrium, leading to sudden increase in the small pressure. This is known as C wave. What is X? X में क्या होगा? Now who will open? Now aortic valve and pulmonary valve will open, and the blood will go away, and because of that, what will happen to the pressure? The pressure will decrease. It is simple. If you understand normal physiology, you can understand this thing nicely, right? So what will happen? Relax will be there, and you will be having decrease in the pressure. X is going to be relax, right? X for relax, right? Next phase is going to be what? Venous filling is going to happen. Now the vena cava blood will start to come, and here these valves are closing, isovolumic relaxation might be happening, and here the blood will start to get accumulate again, and because of that, what will happen? You will be having what? Venous filling will lead to again increase in the pressure. And now when this venous filling is going to be completed and this valve will open, what will happen? The blood will again come back into the ventricles, and this is going to cause what? Emptying. Y is for about, Y descent is for the emptying, right? Right, Y descent is for the emptying. So simple words you can remember. A for, you can remember the ABCD. A for atrial systole. A wave is due to what? Atrial contraction, right? C, isovolumic contraction will lead to what? Tricuspid bulging. Tricuspid bulging. Let me write you the exact information they have given you. C wave is due to what? Bulging. This is the exact term they have written. Bulging of tricuspid valve. Bulging of tricuspid valve into right atrium during isovolumic contraction. You understand what I'm trying to say? This is going to be happening, right? So bulging of tricuspid valve into the right atrium during which phase? Isovolumic contraction, right? X is for the relax. X is for the relax. V is for venous filling. You can remember like that. Venous filling is happening. And Y is for what? Emptying. Y for Y, you can remember. So X for relax, V for venous filling, Y for emptying, A for systole, and C you have to remember. They have asked 3 questions from this particular one. 3 questions they have asked, right? Try to tell me the answer. Try to tell me the answer. You know, JVP, raised JVP, sometimes you will find in a triad like cardiac tamponade. What is that cardiac tamponade? Just think like that. You will be having a cavity outside the heart, right? You tell me the triad for cardiac tamponade. What was that? You have a cavity outside the heart, right? And this cavity will be there, right? And this cavity is going to be your pericardial cavity. If you are going to have lots of fluid here, अगर यहाँ पर पानी भर गया, इसी को बोलते हैं cardiac tamponade. What will happen if there is going to be water around this particular cavity? You will be having water around this cavity. Are you able to hear good sounds? So you will be having no hearing of good sounds. You will be having muffled heart sounds will be there. Second thing, your ventricles are not able to contract properly. This is going to cause what? Hypotension in the patient. And this pressure will translate into the right atrium also. Due to pressure in lower part, this will increase the pressure in the right atrium also, leading to what? Elevated JVP or raised JVP. And this triad is known as what? This complete triad is known as Beck's triad. Important one for the very good important one for the cardiac tamponade. Simple understanding. What is that? Cardiac tamponade? Sir, pani bhar gaya yahan par, right? Pericardial area will be having accumulation of fluid or blood, anything that is going to cause what? Cardiac tamponade. You understand this thing? Answer in this case. Very good. You guys are answering. So depolarization means what? Simple understanding. Depolarization means systole, means contraction, right? So what is going to be your answer? Answer is going to be what? A wave, right? A wave. Now certain reflexes, last important reflexes that you are they are asking from the cardiology part. This is going to be what? Bain bridge reflex. First one is your Bain bridge reflex. It is triggered by increase in venous return. You just try to keep it simple, right? Whenever lots of fluid is going to come into the venous return will be increased, or simply think about it, whenever there is lots of blood will be coming into the right atrium, what right atrium will do? It will be having stretch of the atrias and it will activate your SA node to remove the excess of blood. So basically Bain bridge reflex is a protective reflex which is going to do what? Whenever lots of blood is coming into the right atrium, it will activate your SA node, will lead to what? Increase in the heart rate, so that pooling will not happen, right? वो सारा extra blood निकल जाए body में से. We don't want that blood in our heart, right? So we just want to remove that thing, and for the particular purpose we are going to have what? Bain bridge reflex. The another one that you need to remember is about your Basalt-Gerês reflex. Basalt-Gerês reflex. It is triggered by excessive ventricular stretch. Now you will be having what? Ventricular stretch. It can be due to certain drugs. It can be due to what? Chemical stimulation, right? It will lead to what? Bradycardia, hypotension, and peripheral vasodilation. Peripheral vasodilation will be there. Bradycardia will be there. Hypotension will be there. This is going to be what? Basalt-Gerês. Third important one is going to be what? Cushing has been asked previously. Anytime you are having increase in intracranial pressure, सिर में अगर प्रेशर बढ़ गया, you already know brain is a closed cavity, you are having a skull. अगर उसके अंदर कुछ भी होगा तो it will compress small vessels, right? You are having a skull which is a closed cavity is going to be their brain, right? If there are going to be certain vessels, they are going to get compressed. You will be having ischemia, hypoxia will lead towards cell injury, right? So we don't want that thing, and to prevent that particular thing, we don't want our ICP to be raised, है ना? Intracranial tension नहीं बढ़ाना, उसको कम रखना है, right? So whenever you are having a maybe some space occupying lesion, maybe some hydrocephalus is going to be there and lead to what? Increase in the intracranial pressure, then it will lead to what? Hypertension, bradycardia, and some irregular respirations is going to be there. Why this thing is happening? To maintain the cerebral perfusion. हम नहीं चाहते कि हमारी brain की जो vessels है वो contract हो जाए due to that pressure, and they will start entering into ischemia, and it will lead to ultimately stroke, right? So automatically this Cushing reflex is going to come into action, and this Cushing is going to tell us about the pushing. So you can think like that, whenever there is going to be pushing in the brain, it will activate your Cushing reflex, right? These three reflexes you have to remember, right? One more test we are having, that is known as Zermark-Herring test. Zermark-Herring test, where you will be doing what? Carotid sinus massage, and that will lead to what? That will lead to decrease in the BP, है ना? उससे BP कम हो जाएगा, right? These are the heart sounds. So examiner has moved a step further, and they are asking which ECG leads will correlate to which sound. So we are going to use a mnemonic for that. We are having mnemonic for the this particular one, when you will get the S1 sound, that is going to be on the peak of R wave. You are going to get S1. Here you will get the S2. Here you will get the S4. So when you will get the S2 sound, this is going to be at the end of T wave. You can see at the end of T wave, this is your P, this is your Q, R, S, T. Where do you get the S1 sound? This is on the peak of R wave. You can remember RTP. Where do you get the S2 sound? This is going to be at the end of T wave. Where do you get the S4 sound? This is going to be at the end of P wave. So this is going to be what? At the end of P wave, you are going to get the S4 sound. So this is how you can rule out and you can identify this particular one, right? Yes, S3 is going to be in between, before P wave. But these are the questions from the CVS. Very, very important topic. Pressure volume loop. You cannot skip. Even you have not read anything, just do this particular thing, right? Second one is going to be action potential graph. Definitely they are asking in every exam. They are asking. You cannot skip this, right? The next thing we are having, impulses are generated from which cells? You already know. Most of you know this. This is going to be what? SN node. Gatekeeper of heart. They have asked this type of silly questions also previously. This is going to be your AV node, right? In JVP, C wave indicate what? Now you tell me. C wave indicate what? Bulging of tricuspid valve into right atrium during isovolumic contraction, right? In JVP, absent A wave is going to indicate what? Absent A wave means what is not happening? Atrias are not contracting. A wave is telling us about the systole. Atrias are not contracting or not contracting properly. This is what you need to remember, right? When atrias are, instead of contracting, they are fibrillating. So this is going to tell us about what? Atrial fibrillation. This is going to tell us about the atrial fibrillation. RMP of nervous system is equal to, now you tell me, equal to, when they ask you, this is going to be going in the favor of what? Chloride. This is going to be what? Minus 70 millivolt. If they are asking close to, this is going to be around potassium, which is going to be minus 90 millivolt, right? So this is going to be what? Basic questions they have asked from here. Now comes the next topic. Did you understand this thing? Give me a quick confirmation. Did you understand this thing? Are you understanding? Now we will discuss about the reproductive system, right? Reproductive system basically will be covered in like your OB/GYN majorly, right? But we will learn about certain hormones and their functions, which are going to be important from the physiology aspect, right? There was only one question important from here is about the inhibin, right? So we have got this hypothalamus. We already know this hypothalamus is going to release what? GnRH, and this GnRH is going to activate your anterior pituitary. This GnRH is going to activate your anterior pituitary, and now anterior pituitary will be releasing what? FSH and LH, right? This LH will go to the testes, and in testes you will be finding what? Leydig cells and Sertoli cells. There are only two cells in the testes, Leydig cells, Sertoli cells. Leydig cells will make LH. Under the influence of LH, it will make what? Testosterone, whereas the Sertoli cells will make what? Inhibin. They are under the influence of FSH, right? And this inhibin is working as an inhibitory hormone. So they have asked about this inhibin in the male and female, from where they are going to come, right? Remember two important things. In males, there are only two important cells in the testes. In females, also two important cells in the ovaries. That is going to be your granulosa cells and theca cells in females, whereas in males you are having Leydig cells and Sertoli cells. This Leydig cell is important. It is going to make testosterone, and this testosterone is further converted into, with the help of an enzyme 5-alpha reductase, it is going to convert into dihydrotestosterone. One more important thing, Testosterone is responsible for the internal genitalia formation. Dihydrotestosterone is responsible for the external genitalia formation, right? External genitalia include what? Prostate. So in prostate, you are also giving what? DHT blockers or 5-alpha reductase inhibitors like finasteride or group of drugs, right? Prostate, scrotum and penis. This is going to be what? DHT. And secondary sexual characteristics are also under the influence of what? DHT, right? This testosterone is responsible for internal genital organ. What are internal genital organs? These are your seed. Seed is seminal vesicle, epididymis, your ejaculatory duct, and your vas deferens, right? So these are going to be what? I'm glad I could help you, right? These are going to be what? These are going to be what? Your internal genital organs of a male person, right? And this is going to be the external genital organ of a male person, है ना? Testes genital organ नहीं है, they are going to be gonads, है ना? Testes कब से present है? When there is going to be sperm, ovum, they are going to meet. Till 6th week, you know, we are going to have the formation of testes, right? Once we are having a sperm, once we are having ovum, they are going to meet, they are going to make what? Zygote. It will go inside, it will get implanted within 6 to 9 days, it will get bigger, right? First week, second week, third week, fourth week, fifth week, sixth week. Till 6 weeks, you cannot identify the sex of a person. By 6th week, if you are having SRY region present, this is going to convert genital ridge into what? Testes. You will be having genital ridge which will convert into testes, and now this testes are going to be there. It will be having two cells. What are those two cells? Sertoli cells and Leydig cells, right? Now comes the hormone. Which hormone? LH will come, and this LH will come into the Leydig cells, and it will make what? Testosterone. And now this testosterone, just listen to the story. Now this testosterone will make what? Internal genital organ. Internal genital organ is due to what? Testosterone. And now what will happen? This testosterone will convert into dihydrotestosterone, which will make the external genital organ. You understand the complete cycle, how it is happening. Sertoli cells is responsible under the influence of FSH. They are responsible for nerve cells. They are responsible for phagocytosis, certain other functions, right? But basic understanding is what? When you have a sperm, you have an ovum, they are going to meet. Till 6 weeks, you cannot decide the sex of a person. After 6 weeks, if you are having SRY region, genital ridge will convert into testes, and this testes will be having what? Leydig cells, Sertoli cells. Leydig cells will work under the influence of LH. It will make what? Testosterone, and this testosterone is responsible for internal genital organs, right? And now this testosterone will convert into DHT, which will make the external genital organs, right? This is how we are raised, right? And this Sertoli cells has got some different other functions. So you understand this thing? Female genital organ, like you are done with the OB-GYN majorly, right? Some part are left that you can see in your notes, right? What are the hormonal actions that are going to be there, which are important here, right? In uterus, we are going to have what? Effect of estrogen and progesterone. We already know from where these things are coming. They are coming from the hypothalamus. Hypothalamus will release what? Gonadotropin releasing hormone. This is going to go to anterior pituitary, and this anterior pituitary is going to release what? LH and FSH. In both male and female, both things are coming out, right? Now this LH is responsible for what? Certain functions. FSH is responsible for certain functions, right? In females, FSH is going to make what? Estrogen. LH is going to make what? Progesterone. This is the simple understanding, right? Now, what is the role of estrogen in our uterus? It is going to do what? Endometrial proliferation in the first phase of the cycle, that you already know, right? Progesterone is going to make it secretory, and it is going to give the support. Suppose this is first phase of the cycle, progesterone will come and it will give the supports. It will make it secretory also, right? In breast, it is important. Ductal growth is due to what? Estrogen. So if someone is having CA carcinoma of the breast and ductal carcinoma of the breast, what is the thing we are going to look for? Your receptors. In surgery, you might have studied about this ER, PR, HER2 receptors. So what is the meaning of ER receptor positivity, PR receptor positivity? Let me make you understand. This ER is going to be estrogen receptor. Estrogen is responsible for what? Ductal growth. Whereas this progesterone is responsible for what? Lobular growth. And in the breast, you will be finding only these two important things. We are having these ducts, and we are having these lobules. Along with that, you are going to have what? Subcutaneous fats, your areola is going to be there. So you can have ductal carcinoma, you can have lobular carcinoma, and depending on the thing, if these receptors comes out to be positive, we are going to stop this particular drug, because we already know estrogen will increase the ductal growth. So if patient is having ductal carcinoma, I will block the estrogen. If patient is having what? Lobular carcinoma, I will block what? Progesterone. This is how you need to apply this information, right? And what are ER, PR positivity? You can understand that thing also, right? What about the cervix, increase in cervical mucus? So in first phase, you want to have the sperm entry into your vagina. So this is going to make the cervical mucus thin, whereas this progesterone will stop the entry of this particular sperm. So it is going to make the thickening of the cervical mucosa, right? In vagina, it is going to cause the epithelial proliferation, lubrication basically, and that is the reason why postmenopausal females are having decrease in the lubrication, because they are going to have a decrease in the estrogen, right? Increased glycogen content, they will prepare for the pregnancy. Hypothalamic axis, we have already seen GnRH, FSH, LH, right? It is going to be giving you negative feedback, which is going to be via LH surge. What about body temperature? Remember, during the ovulation, the females will have a basal body temperature rise. This is going to be due to what? Progesterone. So whenever there is going to be day 14, she will have the LH surge. LH is important for progesterone, and this progesterone is responsible for body temperature increase, right? So female will get to know this thing, right? And she will start to have a small pain, which is also your question, exam question. What is that mid-cycle pain is known as? Try to answer me, right? What about the bone? It is going to maintain the bone density by inhibiting the certain functions of osteoproteogenin activation will be there. We have already seen this particular thing. It will inhibit the rank ligand, which is going to increase the bone maintenance, right? Here it will also cause the bone maintenance, right? Remember, this progesterone is a CNS depressant also. CNS depressant also. This is a CNS depressant, and that is the reason why whenever there is going to be having what decrease in the progesterone, the female will be having decrease in the progesterone. What will happen? She will start to have menstruation, but along with the menstruation, what will happen? The depression of the CNS will also go, and they will start to get irritated, right? And the same thing will happen during the pregnancy also. You can appreciate this thing, like during pregnancy, she will be under the influence of progesterone for 9 months, right? And as soon as the baby is going to come out, what will happen? This progesterone level will decrease. This will lead to what? Postpartum psychosis, postpartum blues, sudden decrease in the levels of progesterone. She can get aggravated. You can have postpartum psychosis, blues, right? All these things, depression. You understand about these things, why and how these things are happening, right? So you can remember, progesterone is a CNS depressant. Okay, what are the effect of estrogen on the breast? You can tell me. In the bone, it is going to be forming. It is going to make the bones. What in the breast? It is going to be responsible for which growth? Ductal growth has been asked previously. These one-liners are what? They are long questions, but the mainstream, that main thing they want to ask, I've just taken up these things out. So this is going to be what? Responsible for the ductal growth, right? FSH surge is going to be increasing what? Have you heard about FSH surge? FSH surge is going to be what? It is going to have increase in the plasmin. Just before the LH surge, you will have the FSH surge, and it is going to increase the plasmin, and plasmin is a fibrinolytic thing. It is going to break the fibrin. It is going to break the fibrin, and it is going to cause what? Lysis of follicle rupture. Follicle rupture on day 14, which is going to happen, is due to what? Not LH surge. This is due to what? FSH surge is also going to be there. When you will see the next time you will see the cycle, you will find certain amount of FSH is also increasing, which is going to increase the plasmin, and this plasmin is responsible for the FSH surge, right? Follicle rupture is going to be there, right? Next thing is Klinefelter syndrome is going to be a male or a female? Klinefelter is going to be what? 47XXY. This is going to be a male person. Remember, anytime you will find the Y chromosome, it is always going to be a male person. So what about this 45XO? This is going to be what? Streak ovaries. This is going to be a female. Whenever you will not find the X chromosome, Y chromosome मतलब आदमी, Y chromosome नहीं है मतलब ladies. Be it anything, बाहर से क्या दिख रहा है, doesn't matter, right? Ultimate thing, whenever you see this thing, you can answer. What is the pathway of the sperm? So it will be formed in the testes. Where exactly in the testes? In the seminiferous tubule. Seminiferous tubule, and from the seminiferous tubule they will go to the epididymis. Epididymis for maturation. What is the function of epididymis? It will be responsible for storage and maturation. And after storage and maturation, whenever needed, this thing will come via vesicle. This is going to be what? Vas deferens. Vas deferens is going to bring all the sperm, and two glands are going to drain. One is seminal vesicle, which is going to give the seminal fluid. Another gland is going to be your prostate gland, which is going to give the prostatic fluid, and everything that is going to come out is going to be what? This is known as semen, right? So prostatic fluid, seminal fluid, these three things are going to become what? Semen. What is sperm? Sperm is going to be approximately 10%, which is going to be till this particular area, right? So vas deferens is going to bring the sperm, and these two fluids which are coming from these two glands are going to have certain things like choline is going to be there. You are having what? You are having fructose is going to be there. Acid phosphatase are going to be there, right? Multiple things are going to be there. So these are going to be the substances which are coming from these two important glands, right? So this is going to be the sperm pathway. It will take how many days? This is going to be taking 74 days in the spermatogenesis. All right. Now the next system we are having is about the gastrointestinal system, right? The first thing we are having is about this question they have asked. They have given you this picture and they have asked you what is this particular organ is, right? What is this particular organ? You need to identify. So look at this particular thing. They have written here 10 seconds. If they have written here 10 seconds, so what is going to be the organ? They have asked this particular thing. If it is 10 second single contraction, so in a minute, how many contraction you can get? This is going to be 6 contraction in a minute. So the organ is going to be what? Sigmoid. Next time if they write you 5 seconds here, what is going to be your answer? If they have written 5 seconds, the organ will become what? Duodenum, right? This is known as what? Basal electrical rhythm. This is known as basal electrical rhythm. This is known as basal electrical rhythm, right? We are having another type of motility that is known as MMC, that you need to remember. What is MMC? MMC is motor migratory complex. You know, when you are hungry, right now you might be hungry, so you are having some voices coming down in your stomach. What is that voice? This is going to be your migratory motor complex. It is going to be a strong wave of contraction generating from the mid part of stomach, and it will go towards the terminal ileum. From the mid part of the stomach till terminal ileum, this is known as what? Migratory motor complex. This is going to be happening every 90 minutes. And whenever you are hungry, does not mean you need to eat food, right? This means the cleaning is happening, right? This sound is coming, right? This is a strong wave of contraction generating from the mid part of the stomach till the ileum. है ना? कभी-कभी when you are hungry, you might feel this particular sound. You can hear it in your ears also. This is a strong sound, right? So that means what is happening? It is the cleaning process which is happening. It is also known as the broomstick of GIT. Broomstick of GIT, right? Now, what are the mechanical motilities we are having? We are having segmentation, we are having peristalsis. So what is this peristalsis? Peristalsis, the posterior segment is going to get contracted, anterior segment is going to get relaxed, and the food will move in this direction because the posterior segment is contracting, anterior segment is relaxing. So what will happen? This food will move like that. This food will move like that. This is known as peristalsis. So examiner has asked question, this posterior segment is contracting due to what? So contraction is due to two important things. One is going to be your acetylcholine, another one is substance P. This is going to cause the contraction. Anterior segment is relaxing because of nitric oxide and vasointestinal peptides. These are going to cause what? Relaxation and contraction. Very, very important. So contraction is due to these two, relaxation is due to these two. And if you are having failure to relax, like in the esophagus, if you are having what? In esophagus you will be having what? Decrease in nitric oxide or VIP. You will be having sustained contraction, right? And that appearance that you are going to get like that, this is going to be failure of relaxation of the lower esophageal sphincter. This is known as what? Achalasia cardia, Birdbeak appearance will be there, barium swallow that you have already studied, right? This is going to be what? The same thing which is responsible for the same problem, right? So this is going to be what? This type of motility is known as what? Peristalsis. This is your peristalsis. What happens in segmentation? Here the same segment will contract, beta. Here the same segment will contract, same segment will relax. This is going to cause what? Mixing of the food. Big particles will broken down into smaller particles because the same segment is contracting, relaxing. So this is going to cause what? Mixing and further mixing. This is known as what? Segmentation, right? So this type of motility is known as segmentation, right? So we are having peristalsis, we are having segmentation. These are the two types of motilities that we are having in this particular segment, right? What are the hormones we are appreciating here? Look here, we are having gastrin. Gastrin is responsible for what? Gastrin is coming from the G cells. It is responsible for increase in the acid. We can have G cell gastrinoma, which is also known as Zollinger-Ellison syndrome. So this gastrin is responsible for what? Increasing the acid. This is the only important thing you need to remember. What about secretin? Secretin was the first hormone to be discovered, and secretin, they are thinking like something secretive function is going to be there. So this secretin is going to be increasing pancreatic bicarbonate, or in simple words you can remember, this is going to be what? Nature's antacid. So whenever the food is going to come into your stomach, simple understanding, the food you are eating, it will come into stomach. First, what will happen? It will mix with the acid, right? Second thing, HCl will be coming. It will mix with the acid. HCl will be coming. G cells will be releasing what? HCl. It will mix with the acid. When this acidic food will try to enter into duodenum, first thing is going to be what? Neutralization. And this neutralization is done with the help of secretin. It will neutralize the food. कैसे neutralize करेगा? It will activate certain glands. These are going to be your pancreatic bicarbonate secretions are going to be there. It will increase the bile secretions and decrease the gastric acid secretion. It will activate your glands. These glands are rich in bicarbonates. These glands are known as Brunner's gland. तो पहले क्या होगा? First thing is going to be neutralization. Right? Post neutralization, what will happen? It will activate your cholecystokinin, and now this cholecystokinin, नाम से ही पता चल रहा है, cholecysto means it is going to contract something, right? So what it is going to contract? It will contract your pancreas. It will contract your gallbladder, so that now the pancreatic juices will come into the action and they will start to do what? Digestion, right? So this is how it is happening. Whenever a food is going to be there in the stomach, it will come into the duodenum. It will try to enter into the duodenum. First thing is going to be S cells are going to be there. These cells are going to do neutralization. After neutralization, what will happen? Now the pH will become basic and this sphincter of OD will open, and now pancreatic juice, bile juice, everything will come and they will start to do the digestion, right? What is this GIP? These are your incretins. Basically they are going to increase the release of insulin. जैसे ही खाना आएगा तो incretin बढ़ेंगे. Incretin basically they are going to increase the release of insulin for the digestion, so that lots of blood sugar is not going to be there, right? What about motilin? Motilin is for the movement coming from the M cells, same migratory motor complex that we have seen. Somatostatin is a universal inhibitor coming from the delta cells. It will inhibit everything. Somatostatin. What about histamine? This histamine is going to increase the secretion via H2 receptor. Very, very important. This is going to increase the acid secretion. So for acid secretion, three things are important. One is acetylcholine. This is parasympathetic nervous system. Second one is histamine, and third one is gastrin. These are the three things which will increase the acid. INI-SET exam question. What question they have asked you? All of the following are going to increase the acid, except in the exception, the option was somatostatin. Very simple, straightforward question. So somatostatin is going to decrease the acid. Three things which will increase the acid are going to be what? Increase acid is due to what? Three things. First one is H2 receptor, which is going to increase the histamine. Second one is your gastrin, and third one is your acetylcholine. Parasympathetic nervous system will help in digestion, right? Rest and digest. So for digestion we need what? Acid, right? One hormone, one more thing that is going to be increasing here, that is going to be serotonin. You can remember. So whenever you are hungry, you will feel what? Whenever you are hungry, you will feel irritated. आप irritated feel करते हो, you will not feel good. Why? Because the levels of serotonin are going to be decreased. Whenever you will eat food, you know what happens? The levels of 5-HT is going to increase in the blood. all the amino acid will go inside. The only amino acid which will come out is going to be 5-HT. And this 5-HT will travel in the body, it will go to your brain also, and we can appreciate this thing. This 5-HT is what? Serotonin. And this is going to enhance your mood, it is going to make you feel better, right? That is the reason why depression people, those people who are having what? Depression, they keep on eating things. When we will eat the food, you know what happens? This 5-HT will come, it will come into blood, it will go to our brain, will feel happy. Good food is going to good mood. And this 5-HT is also going to make what? Melatonin. Good food, good mood, good sleep, basically, right? So this is why they will enter into a vicious cycle. You know, when we are studying, when we are depressed, what will happen? We'll try to eat. Some people, they are depressed people, they will eat chips, they will eat something. What will happen? They will have short bounce of 5-HT, and this 5-HT is going to go to their brain and they will make them feel better, है ना? हम लोग भी तैयार होके जाते हैं, you will go for a date, you go outside for a dinner. What will happen? You will eat only 5 things. What are the 5 things I've taught you? Carbohydrates, fats, proteins, vitamins and minerals in different forms, right? There are only 5 test receptors you are having. These are going to be your sweet, salt, sour, bitter and umami. Very simple, right? So 5 tastes we are having, 5 things we are eating, but we are making it more difficult, right? Critical. Very important. Another topic that we are having is going to be what? Ghrelin is also going to get increased, beta. Ghrelin is going to be, it will increase the growth hormone also. This ghrelin, whenever your ghrelin level, they have asked one question about ghrelin. So the levels of ghrelin are going to be what? Maximum just before eating. Just remember this statement, maximum just before eating. Hypoglycemia is a very good thing, right? It will increase your brain power, it will increase your growth hormone, it will increase the levels of ghrelin more in your body. More ghrelin will lead to what? More productivity in your body, more better neuron health. Everything is going to be good if you are having hypoxia. Not hypoxia, if you are having hypoglycemia, right? Hypoglycemia. Hypoxia, you will die, right? The next thing we are having is iron absorption. Iron absorption is very important. So we are having what? Iron absorption. This is going to be what? Iron can be absorbed in 2 forms, beta. One is going to be what? This iron absorption is going to be, iron can be present in ferrous and ferric. Sir, how to remember? Ferric mein beta 3 aata hai. Ferric will be having what? C you can remember 3. So ferric and ferrous forms are going to be there. The food iron that you are eating is going to be what? Fe3 plus you are eating. Ferric form we are eating. But this ferric form is cannot be getting absorbed directly. So that is the reason we need to change it, right? So first thing is going to be whatever food iron you are eating is going to be Fe3 plus. And this Fe3 plus needs to get converted into Fe2 plus. The question number 1 is going to be what? Which is the enzyme which will convert ferric into ferrous? Is ferric ko kaun convert karega? The answer will be what? This is going to be what? Duodenal cytochrome B, right? When it will convert into ferrous, now it can enter into the body. This is your second question. See how many questions they have asked, right? This ferrous can enter into your body with the help of what? Divalent metal transport. Let me make you better, right? This is your mucosa. You are eating a food. This is going to be cell. Here is going to be blood vessel, right? So this is going to be mucosa. These are villi, microvilli. This is going to be the cells, and here is going to be the blood vessel. This is going to be submucosa, which is going to have the blood vessel. Now you are eating a food which is rich in iron. Now first thing you need to convert is going to be convert this ferric form into the ferrous. Fe3 अंदर नहीं जा सकता. You need to convert it into ferrous form, and this conversion is happening with the duodenal cytochrome B. Second answer is also sorted. What is the site for absorption of iron? The answer is going to be what? Duodenum, right? So this duodenal cytochrome B will convert ferric into ferrous. Now it will become Fe2 plus. Follow the cycle. Just give me your 2 minutes and you will understand this thing. Now this ferrous is going to enter, Fe2 plus is going to enter inside the cell. It can get stored, and the storage form is known as what? Ferritin, right? Another thing, if it is not getting stored and required in the body, it will come out of a thing, ferroportin. Portin means it is going to transport. So it is going to transport this ferrous Fe2 plus outside. Now this ferrous is where? In the blood vessel. So this Fe2 plus is in the blood vessel right now. But in blood vessel, it cannot travel into Fe2 form. So it needs to get converted into Fe3 plus, and it requires what? Hephaestin for that particular purpose. And the role of hephaestin is to convert Fe2 into Fe3 plus. Once it will convert into Fe3 plus, it cannot travel alone. It will ask for some transporters, and transporter for iron, transferrin. This is going to be plasma transferrin, which is going to transport this iron to various parts of the body. What are the various parts of the body? Look here. First thing, it will be traveling to the liver, but more importantly, it will go to the bone marrow. Why in the bone marrow? Iron is responsible for the production of what? Hemoglobin, RBCs. ये सब कहाँ से बनेंगे? Iron से बनेंगे, right? If the person is not eating enough iron, he is not eating enough iron, he can have what? Iron deficiency anemia, right? Maybe now whenever you are going to have what? Enough amount of iron is going to be there, it will send a signal to the liver, extra iron will go to the liver, and now this liver is going to put a brake. What is the brake? This is important. What is the brake? The brake is going to be your hepcidin, right? And this hepcidin is going to put a brake on ferroportin. That we don't want extra iron. No need to send extra iron into the blood, right? We don't want extra iron into the blood. Please don't send it, right? So what will happen? This hepcidin is going to put a brake here, and if there is going to be a brake, do you think this extra iron is going to come into the blood? No, right? So this is the basic cycle that we are having about the iron metabolism. Now we can have problem. What problems we can have, you will learn in the pathology, but I'll just give you basic hints so that you can understand. If you are having this brake fail, if you are having a HFE mutation, HFE gene mutation, which is going to code for this disease is known as what? Hemochromatosis, iron overload condition. And this iron is going to get deposited where? No, you should ask where it is not going to get deposited. It will deposit everywhere. It will come into the liver. It will cause what? Liver cirrhosis. Extra iron will cause what? Liver cirrhosis. It will cause hyperpigmentation on the skin. Hyperpigmentation on the skin. It will cause a special kind of diabetes. It will destroy the pancreatic glands, which is known as bronze or diabetes. Blood is a connective tissue. Anything is coming into the blood, lose connective tissue. It will transport everything everywhere, right? So this is going to be the problem. You can have what? Hemochromatosis, right? Iron chelators also, they have asked you. These are going to be your desferrioxamine, deferriperone. These are the important question. Iron, definitely they are going to ask you one question, right? They have asked about duodenal cytochrome B. In fact, they have written this iron can get inside, Fe2 plus can get inside with the help of divalent metal transport. ये सबको पता था, but 1 or 2, right? The answer will be DMT1. This is also they have asked. Storage form of iron, ferritin. Conversion of Fe2 to Fe3, F-acetin, right? This is a simple thing. You just need to go through it and you will be able to understand. एक बार यहाँ से बना लेना. This is about the food iron, right? Another thing, iron absorption is going to get increased by which food? Citrus, right? It will decrease by coffee, tea, phytates, oxalates, and they have even written the sprouts in the question. So you need to remember sprouts are also going to decrease the iron absorption, right? So these are going to be for the decrease in the iron absorption. This thing can increase the iron absorption, right? Iron deficiency anemias, you will be having MCV more or low. Yes, tanates, oxalates, all these things are going to be there, right? Iron ka simple hai, it is going to be causing problems, it is going to cause nausea and vomiting, so you just need to take it with a gap of something, right? You need not to mix it with the food, right? What are the digestion? I told you we are only eating 5 things. What are those 5 things? We are eating carbohydrates, proteins, fats, vitamins and minerals. These are the things we are eating, right? These are the only things we are eating. 5 things: carbohydrate, fats, vitamins, proteins, minerals, right? How these things are going to get absorbed in our body? What are the transporters we are having? So carbohydrates will convert into glucose, fructose and galactose. This glucose and galactose can be getting absorbed by with the help of gluts. For fructose, we are having which glut? This is going to be glut5. Maximum absorption in the small intestine, mainly in the duodenum, jejunum. Proteins are going to convert into amino acids and peptides. These are also getting absorbed in the small intestine. Again, duodenum, jejunum. Here also it is going to be duodenum, jejunum. Water absorption majorly happening in the small intestine, little bit in the colon. What about the vitamins? Fat soluble vitamins generally happening in the small intestine, A, D, E, K. water soluble vitamins in the jejunum and terminal part of ileum, that is going to be special for the vitamin B12. Iron absorption we have seen in the duodenum. Folate absorption, sometimes duodenum, sometimes jejunum, right? Both of them can be correct. Whatever is there, you can mark that. Minerals in the small intestine, most of the 90% of the things are absorbing in the small intestine. Bile salt, you need to remember, is going to be under enterohepatic circulation, right? Yes, MCV is going to be less than 80, that is going to be iron deficiency anemia, right? Some special important points that you need to remember, let me give you. In your mouth, in your oral cavity, what is not getting digested? Protein. Protein digestion is not going to happen in your mouth. You are having salivary amylase for the digestion of what? Carbohydrate. For the lipid digestion, you are having lingual lipase, but there is nothing for the protein, right? In your stomach, if you talk about stomach, there is going to be digestion of what? Proteins. Protein digestion is going to take place. There is going to be digestion of lipids, but carbohydrate digestion is not happening. Very important point to remember. कार्बोहाइड्रेट का डाइजेशन कहाँ नहीं होता बेटा? स्टमक में नहीं होता, राइट? माउथ में किसका डाइजेशन नहीं होता? प्रोटीन का डाइजेशन नहीं होता. इन स्टमक वी आर हैविंग व्हाट? पेप्सिन. पेप्सिन इज फॉर द कन्वर्जन ऑफ पेप्टाइड्स, राइट? प्रोटीन डाइजेशन के लिए है पेप्सिन, राइट? सो पेप्सिन और स्टमक इज गोइंग टू हैव डाइजेशन ऑफ प्रोटीन्स एंड लिपिड्स. Lipase is going to be there, but not the carbs digestion. These two important points you need to remember, right? Now try to tell me these answers. What are the answers we are having? Iron absorption is increased by, in the option they have written the ascorbate. What is ascorbate? Ascorbic acid or ascorbate, right? This is going to be basically vitamin C, limb C, that is going to increase the iron absorption. Posterior segment in peristalsis is contracted by, try to answer. I told you one is going to be anterior segment, one is going to be posterior segment. Posterior segment is going to get contracted, whereas anterior segment is going to get relaxed in the peristalsis. This posterior segment contraction is due to what? Acetylcholine and substance P. Very good. Harsha, Ranjini, Jovitha, Pooja, Shabash, right? Saikirshna. The next thing, which thing will decrease the acid secretion in the parietal cells? This is another question. Which thing will decrease the acid secretion? Three things you already know which will increase the acid secretion. Acetylcholine, second one is histamine, third one is gastrin. You can have G cell gastrinoma, Zollinger-Ellison syndrome. These three things will increase the acid. Decrease is going to be for due to somatostatin, right? So answer in this case is going to become what? Somatostatin. Somatostatin, right? You know there is a bacteria which can cause cancer, that is H. pylori. You know what H. pylori will do? It will damage this somatostatin, right? This is your INI-SAT question. H. pylori will damage the delta cells, and now delta cells will not make the somatostatin, and this somatostatin is a brake on gastrin, brake on G cell, and gastrin will lead to what? Acid production. Simple understanding. What is the function of gastrin? To make acid, HCl, right? What is the function of H. pylori? To damage the delta cells. What is the function of somatostatin? To put a brake on this. Now what is happening? Person is having H. pylori infection, delta cells not working, somatostatin not working, gastrin will increase, leading to increase in the acid, leading to ulcer formation. You understand this thing? But they are asking about the contraction. If they are asking about relaxation, then your answer will be nitric oxide and VIP. If they are asking about the contraction, contraction is due to what? Contraction is due to substance P and acetylcholine, right? Glucose absorption in intestine is via which receptor? Intestine glucose absorption, that is going to be your SGLT1, SGLT1, sodium glucose linked transporters. Lastly, we are having vitamin B12 is absorbed from which part of the intestine? The answer will be what? This is going to be your terminal ileum. terminal ileum with the help of what? With the help of intrinsic factor beta. This is happening with the help of what? Intrinsic factor in the terminal ileum. Very, very important entity, right? Now try to solve this type of question. This another chapter we are having, respiratory. Solve this question. In the given spirometry diagram, identify the point G. You will remember me when you will go in the examination, you will find this type of questions only, right? These are the same repeated question multiple times they are asking. What is this point G is indicating? Tell me. What is this point indicating? Point number G is indicating what? So there is a mnemonic that you can remember for this particular one. What is the mnemonic we are having? This is going to be what? Reti TVI. What is the mnemonic we are having? Reti TVI. So whenever you will find this type of question, you can remember the mnemonic. What is the mnemonic? Reti TVA. Before that, let me make you understand. We are having 4 volumes and we are having 4 capacities. What are the 4 volumes we are having and what are the 4 capacities we are having? This is what you need to remember, right? What are the 4 volumes we are having? Let me make you understand. We are having 4 volumes and 4 capacities. What are these 4 volumes? These are going to be your, this is your normal diagram that we are having. First one is your tidal volume. Tidal volume means what? Whatever amount of air that is going into your lungs and coming out of your lungs, this is known as tidal volume. This is known as 500 ml is the tidal volume. What is another volume? Maximum inspiration. Maximum inspiration is maximum inspiratory reserve volume. This is known as inspiratory reserve volume. This is your maximum inspiration, only inspiration, single entity. Maximum expiration is going to be what? Expiratory reserve volume. And you know, some volume is always going to be there once you will inflate a balloon. Let's say I'm talking about a balloon. एक बार आप गुब्बारा फुला दोगे तो उसमें हवा हमेशा रहेगी. The same we are having the lungs, right? And these tests you are doing in the FMT also कि बच्चे ने सांस लिया एक बार तो पता चलेगा हमेशा, because there will be always be residual volume is going to be there, right? So these are the 4 volume you need to remember. First is tidal volume. This is going to be 500 ml. Second is maximum inspiration, inspiratory reserve volume. Third is maximum expiration, and lastly is going to be what? Reserve volume. These are the 4 volumes that you need to understand. ठीक है, तो 4 volume हो गए and 4 capacities, right? 5 capacities you can remember. Capacities में we are going to add on what? Tidal volume along with inspiratory volume, tidal volume along with expiratory volume, tidal volume along with this one also, right? So this is going to make what? This is going to make what? Capacities, right? So let me try to give you a mnemonic so that you cannot get confused and you will be able to solve these questions, right? So we are having 4 volumes. What are the 4 volumes that you know? These are going to be your, these are going to be your Reti. Mnemonic is absorbed but will help you out. And some capacities we are having. What are the capacities we are having? These are going to be your T, V and I. So this is going to be the mnemonic Reti TVI. What are the 4 volumes you know? First one is residual volume. Second one is maximum expiration, expiratory reserve volume. Third one is tidal volume. Fourth one is inspiratory reserve volume. These are the 4 volumes you know, right? What are the capacities? You need to remember what are the capacities. So remember, whenever you are going to combine these two, residual volume plus maximum expiration, it is going to become what? Functional residual capacity. When you will combine expiratory reserve volume, that means maximum expiration plus tidal volume, it will become what? Expiratory capacity. When you will combine tidal volume with maximum inspiration, Listen carefully. This is going to become what? Inspiratory capacity. When you will combine expiratory reserve volume, tidal volume and inspiratory reserve volume, simple समझो तो normal volume, maximum inspiration, maximum expiration, all these three are going to become what? Vital capacity. And when you will combine all of them, this is going to become what? Total lung capacity. You understand this thing? You will make it once for yourself. You are not going to get confused. Only important thing is going to be what? This FRC. Others are going to be pretty simple. Now look at this diagram and try to answer me. This is your normal tidal volume. So A is going to be what? Tidal volume. Try to tell me what is this point number B. This is your maximum inspiration. This is your maximum inspiration. Point number C is telling us about maximum expiration. So this is going to become what? Expiratory reserve volume. Point number E is going to tell us about, एक बार ये भर लोगे तो क्वेश्चन गलत नहीं होगा. This is going to become what? Residual volume. Now you can tell me this particular volume, tidal volume plus maximum inspiration. Tidal volume plus maximum inspiration is going to become what? Inspiratory capacity. This is inspiratory capacity. Tidal volume, maximum inspiration plus maximum expiration. This is going to become what? Three things. We are going to have what? Vital capacity. Combining all of them is going to become what? Total lung capacity. And when you are having what? Residual volume including along with the expiratory reserve volume, this is going to be point G. This is going to become what? Functional residual capacity. You understand this thing, right? It's not difficult. You make it once. Volume and capacities. The mnemonic is RETI TVI. RETI TVI. Right? Residual volume, expiratory reserve volume, tidal volume, inspiratory reserve volume, total lung capacity, vital capacity, inspiratory capacity. Here it is going to make FRC. This is going to become EC. This is going to become what? IC. This is going to become VC. This is going to become TC. So this is how you can make it in a minute, and this is going to help you out, right? Keep it. Right? These are the volumes, lung volumes and capacity. These are the static one, dynamic graphs you are going to learn in the medicine, right? We don't have enough time for that to cover, right? So you are going to learn about the dynamic lung volumes also, है ना? Dynamic lung volume भी पढ़ना है. That is going to have what? Restrictive and obstructive lung diseases, very important, right? Apart from that, we are having this story of hemoglobin and dissociation curve. This is also very important, repeatedly asked topic that we need to understand, right? Need not to remember any mnemonic, rather you should be having the understanding how to apply the concept to this particular question and how to utilize this information, right? So basically, what is this hemoglobin oxygen dissociation curve? We are having a saturation, we are having a partial pressure of oxygen on the x and y axis, right? So let me make you understand in a simple words होता क्या है. Oxygen का function, hemoglobin का function क्या है? Hemoglobin has got a function to transport what? Oxygen. This is a function of hemoglobin. So this is the dissociation curve. Why we are having? Because of the binding of the oxygen. First molecule will require what? More time, then it will next three molecule can bind or can remove very easily. The first molecule require more energy. That is why we are getting a sigmoid shaped curve, right? The important thing about this hemoglobin oxygen dissociation curve, it is a love story of hemoglobin and oxygen. When they are going to get breakup क्यों होगा, कब होगा? Let's try to understand this particular thing. So whenever right shift is going to happen, right shift means reduced in affinity. You just need to remember right shift means reduced in affinity. Affinity means what? Love, right? So whenever there is going to be decrease in the love, what will happen? This graph will move towards the right side. And if there is decrease in the love, what will happen? This hemoglobin is going to remove this oxygen from himself and it is going to transport to the tissues. What is the function of hemoglobin? ये कहाँ लेके जाएगा oxygen? कहीं नहीं. It is going to transport it to the tissues, right? So whenever this hemoglobin is going to get transport to the tissues, this is going to be what? This is going to happen in which condition? Now need not to mug up anything. First thing, कब ये oxygen hemoglobin dissociation curve होगा? Basically कब ये hemoglobin oxygen को छोड़ेगा? Whenever there is going to be need of oxygen in the body. So if there is going to be a need of oxygen in the body, if there is going to be need of oxygen in the body, what will happen? You will be having what? You will be having what? You will be having hypoxia. So whenever there is hypoxia, what will happen? This hemoglobin will leave this oxygen will come here. Hypoxia means, can I say there will be increase in the levels of CO2? Can I say like that? Yes, there will be increase in the levels of CO2. And let me tell you one more relation that we are having over here is the relation of CO2 and H plus. They are brothers for life. They are brothers for life. So anytime you are having increase in CO2, you will always have what? Increase in H plus beta. Anytime you are having decrease in CO2, you will have decrease in H plus. They are brothers for life. They are always together, right? So this relation you have to remember, right? This is something you can appreciate. We are having what? CO2 and H plus. So increase in H plus, what you are going to call it? Increase in H plus means it is going to happen in which condition? In the condition of what? Acidosis. Increase in H plus means acidosis. What happens to the pH beta? What happens to the pH here? There will be decrease in the pH. There will be decrease in the pH. And decrease in the pH is also known as what? Acidosis. What happens to the temperature? अगर कोई इन दोनों में आग लगाएगा, if temperature is going to get increased, what will happen? This hemoglobin oxygen dissociation will start to happen, and you will be having what? Increase in temperature. You can also remember some mnemonics, but I would prefer if you are not remembering the mnemonics, rather you will understand this thing is going to be good, right? So increase in temperature is going to be causing what? Right shift of the curve, and this right shift of the curve is known as what? Bohr effect. This effect is known as what? Bohr effect. Bohr effect, right? Whereas this left shift of the curve is known as what? This is known as Haldane effect. Haldane effect. Now you can reverse the same thing here, right? Left shift means increase in the affinity. Increase in the affinity, that means hemoglobin and oxygen are tightly bound now. They are not relieving the oxygen. Why? Because already, sir, there is increase in the oxygen in the body. Increase in the oxygen means there will be decrease in the CO2. Decrease in the CO2 means there will be decrease in the H plus. Decrease in the H plus means what is the condition? This is a condition of alkalosis. And what happens to the pH here? The pH will be more. What happens to the temperature? The temperature will be low, right? Opposite to that is going to be what? This is going to become the left shift of the curve, right? And this is known as which effect? This is known as Haldane effect, whereas this is known as Bohr effect. Simple understanding. You just need to remember one thing and you can apply it all over together, right? So this is going to be what? Hemoglobin oxygen dissociation curve, right? Another important question they are asking, last exam they have also asked this question. Identify the pattern of breathing given below. So what is this type of pattern is known as? What is this type of pattern is known as? Is it a Kussmaul breathing? Is it a chain stroke breathing? Is it a Biot's breathing or a normal respiration that we are having? So whenever you will find what? Chain stroke. Whenever you will have chain stroke breathing, what will happen in chain stroke breathing? You will find crescendo, decrescendo, increasing and decreasing type of movement is going to be there, followed by apnea, followed by increasing and decreasing movement, right? So this is going to be characteristic crescendo, decrescendo type of movements. Very, very important, right? With apnea. This is going to be what? Chain stroke breathing pattern. What happens in Biot's breathing? In Biot's, you will be having what? Irregular breathing will be there, not increasing, decreasing. Irregular breathing will be there with the apnea. With a period of apnea, this is going to be what? This is going to become what? Biot's breathing. Biot's breathing, right? Kussmaul, I'll show you, right? So these are the different breathing patterns you are having. This is going to be eupnea, normal breathing that we are having. Tachypnea means faster breathing is going to be there. You can have apnea. This is your Biot's. Look here, abnormal breathing, right? Irregular breathing is going to be there. Not waxing waning period is not there. Increasing crescendo, decrescendo is not there. It is abnormal breathing followed by apnea, abnormal breathing followed by apnea, abnormal breathing. This is known as what? Biot's breathing. This is known as Biot's breathing. You can see this type of breathing patterns in the neuronal damage. You can have neuronal damage. This type of breathing pattern, right? You can have this agonal type of breathing, not so very common. Hyperapnea can be there. And this Kussmaul is important. This Kussmaul type of breathing you can find in the diabetic ketoacidosis, right? The person will try to remove the excess of CO2, and he will try to remove that by doing the breathing, by the respiratory mechanism. So he'll be doing like that. So this type of breathing pattern, when you will find, this is going to be what? DKA patient, right? This chain stroke, you can appreciate there is going to be sudden increasing, decreasing apnea, increasing, decreasing apnea type of breathing. So this is going to be what? Chain stroke breathing. Sometimes you will find it in the cases of what? CHF, right? This type of apneustic breathing is going to be something you will be finding in the stroke. Patient will not be able to breathe properly. This is going to be something, a feature of stroke, right? So basically you should be remembering about chain strokes, Biots and Kussmauls are the most important one that you should be remembering, right? These three are going to be the important ones. I know how to, I've told you how to differentiate between these three, right? If a diabetic ketoacidosis patient is going to be there, he will show you a special breathing pattern that is known as what? That is known as Kussmaul breathing pattern, right? What about the hypoxia? Hypoxia, the most common cause for cell injury, and the most common cause for hypoxia is going to be what? This is going to be your ischemia. This is going to be your ischemia. Or in simple words, if I want to give you basic understanding, every cell require energy, and without oxygen you are not going to do the aerobic respiration, and the cell mitochondria will start to die and a complete cell will die, right? So ischemia means decrease in the blood supply will lead to what? Decrease in the oxygen supply will lead to what? Hypoxia, and hypoxia will lead towards cell injury. Once a cell will die, it will kill multiple cells, it will cause what? Tissue injury, multiple organ injury, organ system injury, and ultimately the person can also die. So we are having this hypoxia basic culprit. You need to understand what are the different kind of hypoxias we can have. We can have the first one. This is going to be hypoxic hypoxia. That means in the environment itself you are having what? Low oxygen. Hypoxic hypoxia means the oxygen is going to be due to low atmospheric oxygen. Bahar oxygen hai nahi. You are on a very high altitude, right? You are on a high altitude. This is going to give you what kind of hypoxia? Hypoxic hypoxia. Pneumonia हो गया. Pneumonia means what? There is going to be accumulation of fluid in the lungs. अगर यहाँ पानी भर गया, do you think there will be any gas exchange is going to take place properly? No, right? So this is going to cause what? Hypoxic type of hypoxia, right? One more question they are asking you about a person who is going to the mountain, and what is going to be your answer? The first thing you are going to do is going to be what? Rapid descent. Remember, rapid descent is very, very important, right? A person is going to have what? Going to the mountain and he start to develop what? Mountain sickness. The first thing is going to be rapid descent. You can give oxygen to the patient, oxygen therapies. You can give nifedipine to the patient if he is going to have what? Nifedipine is a calcium channel blocker, not working everywhere, right? But in certain individuals it will be working very nicely. If it is not working, the pulmonary edema is developing, you can go for bosentan kind of drugs, which are endothelin antagonists, right? So this is the rapid descent that has been asked previously also. 2 times they have asked this question, right? What about this anemic hypoxia? Anemia is going to happen. Anemic hypoxia matlab patient ko anemia. If the patient is having anemia, he will be having low levels of hemoglobin. Hemoglobin is not going to be there. What is going to be there? If hemoglobin is not going to be there, what will happen? No transport of oxygen. No transport of oxygen will be leading to what? Leading to some kind of hypoxia, and that is a simple understanding also you can apply. If you find an anemic patient, you will find this patient faster or slower. Anemia wala patient तेज होगा कि slow होगा? This patient will be slow. He will be hyperventilating all the time. These are the symptoms you can apply, right? So a patient is going to be there. They will come to you. They will complain to you, sir. Weakness आ रही है, हिम्मत नहीं है, थोड़ा काम करती हूँ, थक जाती हूँ. What are the symptoms? These are the symptoms of anemia. Pale body is going to be there, right? Why? Because oxygen transport is not good. Because hemoglobin oxygen carrying capacity is not good, right? Hemoglobin is low. So if you will increase the hemoglobin, oxygen transport will be better. If oxygen transport will be better, she will make more energy, more aerobic glycolysis will happen, more energy production will be there, and she will be active, right? So this is how you will understand. Hemoglobin is decreased or hemoglobin function is decreased. Other things are going to be normal. This is going to be seen in the anemia. Carbon monoxide poisoning can also lead to this type of situation. What is this circulatory hypoxia, or also known as stagnant type of hypoxia? Circulation में problem आ गया. Suppose this is a vessel and this vessel is going to have what? something is here. This is atherosclerosis. Artery के अंदर plaque बन गया, atherosclerosis. So what is this? Atherosclerotic plaque is going to be there, and because of that, what will happen? This blood is not able to reach another thing, which will lead to what? Hypoxia in the patient, right? So decreased blood flow despite normal oxygen levels can lead to what? Circulatory or stagnant type of hypoxia. What about histotoxic hypoxia? This histo means tissue toxicity. The toxicity is happening at the levels of what? At the level of tissue, right? And why this thing is happening? Because of cyanide poisoning. You tell me in how much time the person will die in cyanide poisoning. In how much time a person will die in cyanide poisoning? Is it going to be within seconds? And what is the drug of choice? The drug of choice we are giving is vitamin B12 cyanocobalamin, right? So this is what we are using. Earlier we are using different things, amyl nitrate and all, but now we are going to give it give what? Vitamin B12. Cyanide poisoning is also taking a lot of time. Sometimes, you know, this is not you will not be able to tell the taste of this thing. You just eat it and the person will die within seconds. It's all myth, right? Next thing is about the surfactant, surface tension antagonist, right? Very, very important concept. They are asking you, they are produced from which cells? First thing, surfactant is produced from which cells of the lungs? They are the pneumocytes. What exactly? Which type of pneumocytes? Type 2. Type 2 pneumocytes are going to be there. Type 1 is responsible for the respiration, right? Their major component is going to be what? Phosphor. They are basically phospholipid in nature. And this phospholipid, which lipid is going to be there? This is going to be what? Lecithin. Lecithin and sphingomyelin. Right? So major component is lecithin, minor component is sphingomyelin. This lecithin is also known as, sometimes they can write you dipalmitoyl phosphatidylcholine. Dipalmitoyl phosphatidylcholine. Dipalmitoyl phosphatidylcholine, DPPC. This is going to be the phospholipid that we are having. Major protein, if they ask you, major protein is going to be what? The major protein here is surfactant protein type B, SPB, right? Not E, it is going to be SP type B, right? What is the time period when it will start the production of surfactant? This is going to be our 20th week. And maximum production you can get around 34th week. Right? Why we are giving, if someone is having decrease in the surfactant, we are giving what? Glucocorticoids to the patient. Because this glucocorticoids has got a side effect. What is the side effect? They can cause what? Hyperlipidemia. They will increase the sugar also, they will increase the lipids also, and that is the reason we are giving beta or dexamethasone, right? So beta or dexamethasone that we are using, they are going to cause what? Hyperlipidemia, and this lipid is going to make what? Surfactant in the body, right? If a baby is born like with the same disease like NRDS or respiratory distress syndrome, we can give intratracheal surfactant also. Now we are having this thing available, we can give intratracheal surfactant also, we can save this baby, right? So these are the steroids that we are using to save our patients with the surfactant deficiencies. It will lead to what? Collapse of the alveoli. Surface tension antagonist is going to prevent the collapse of the alveoli. Agar alveoli collapse ho gaya, suppose if this alveoli is open, it is going to be causing what? Respiration, no issues. But if this alveoli is going to get closed, what will happen? You're not going to have good respiration. This is important, right? So this is going to be the surfactant. Surfactant is released from which cells? Surfactant is released from the type 2 pneumocytes. Surfactant is released from the type 2 pneumocytes, right? Cyanide poisoning causes which type of hypoxia? Cyanide poisoning is going to cause this is going to cause what? Histotoxic hypoxia. In DK, what kind of breathing pattern you are going to find? This is going to be Kussmaul breathing pattern, right? HbF and CO causes what shift of the hemoglobin dissociation curve? This is going to be your, just remember this, left shift, right? It has got high affinity with HbF, you know, is going to have high affinity. That means going to cause what? Left shift. FRC indicates what? This is going to indicate what? Residual volume. And ERV, this is going to be what? Functional residual capacity, right? Now try to solve this particular one in the musculoskeletal system. A 37-year-old male patient is sent for cholecystectomy under general anesthesia. During the anesthesia, this patient start to hyperventilate and ET CO2 levels are very high. Expired CO2 levels are very high. Which of the following mutation is responsible for this condition of the patient? What do you think? Which mutation will lead to this particular disease? Or let me just make you understand how this thing is going to be happening. Right? So this is going to be the skeletal muscles that we are having. They are going to be voluntary muscles that we are having. They are striated. They are under the somatic control. That means we can control them with the will, right? I can control them under my will, right? They are composed of long multinucleated fibers, and they are going to have what? Sarcomeres. Sarcomeres are going to be there. Sarcomeres are going to divide. This is going to be the basic structural and functional unit of a muscle cell, right? So what is the sarcomere? This is going to be the area between the two Z lines. These are the two Z lines that we are having. So this is one Z line, this is another Z line. So area between these two Z lines is known as what? Sarcomere. This is known as sarcomere. This middle part is known as what? Myosin. This part is known as what? Actin. This thin filament is known as actin. This is your actin. And this mota wala, beach wala, this is known as myosin. This is known as myosin, right? So this is going to be your myosin filament. This is going to be your actin filament. And this is going to be what? This is going to be the titin. This middle one is going to be what? Titin, which is responsible for the elasticity of the thing, right? ये इसको वापस लेके आएगा, right? So now they are asking you certain questions. What is this I band? What is this A band? What is that band, right? So the part, this part is having what? Myosin is there, yes or no? Yes, actin is also there. तो जिनमें दोनों चीजें हैं, this is going to become isotropic or anisotropic. Same रहेगा कि अलग अलग हो जाएगा? Anisotropic. So this is going to become what? A band. A means anisotropic. Aniso मतलब same नहीं है, right? Iso मतलब same है. This band which is only having what? Actin, no myosin, only actin filament. This is going to be known as isotropic band. So we are having I band, we are having A band. So A band, actin plus myosin. I band, only actin, right? What is this myosin? The line is going to be there which is dividing this myosin in between. This is known as M line. What is the H zone? The zone which is going to divide this cycle into two halves. इसके दो हिस्से जो करेगा, this zone is known as H zone. This H zone will get contracted. ये छोटा होगा तो H zone भी छोटा हो जाएगा. This is going to be what? H zone, right? So what are the question examiner is going to ask you from here? These are the basic understanding. क्या क्वेश्चन पूछेगा? What happens to A band during contraction? What happens to I band during contraction? Right? First you need to understand कि होता क्या है, तो अब अपने आप समझ में आएगा क्या होगा. Right? Actin is going to be patla wala, thin filament. Myosin is going to be thick filament. A band is going to be myosin band. Myosin, right? A band will be having myosin. I band is going to have actin only. H zone, myosin only. H zone is the zone which is only having what? This is the H zone which is only having the myosin, right? What happens? This H zone is going to disappear during full contraction. ये दोनों अगर पास आ गए, these two things are going to come closer. What will happen? This zone will get narrower and it will get completely disappear when these two things are going to come closer, right? तो ये गायब हो जाएगा, right? Z lines is going to anchor the actin, right? This is a function of Z line. So basically how this contraction is going to happen, let me make you understand. So whenever there is going to be, I'm thinking about a contraction. If I'm thinking about the contraction, what will happen? This nerve will travel here. This nerve will travel here. Suppose I want to contract this biceps muscle. What will happen? The information will come from my head to my biceps. And now what will happen? At this particular area, I told you the function of calcium. The calcium will come inside. This calcium will activate something. And because of that, what will happen? Voltage gated calcium channels are going to get open. This is a neuron I'm talking about. Here you will be having neuromuscular junction. राइट। तो देखो यहाँ क्या होगा, फर्स्ट कैल्शियम विल कम इनसाइड, वो एक्टिवेट करेगा वोल्टेज गेटेड कैल्शियम चैनल को, एंड नाउ दिस कैल्शियम विल कम इनसाइड, and calcium I told you three function: in vessel, vasoconstriction; in muscle, muscle contraction; and inside a cell it will cause what, exocytosis. With the help of snare protein, what will happen, these vesicles are going to be there, they are going to come out. These are your synaptic vesicles. कहाँ बनी, ये न्यूक्लियस ने मैसेज भेजा mRNA को, प्रोटीन बनाया, साइनेप्स बनाया, गोल्गी ने बनाई, एंड these vesicles are going to be stored, और ये सारी चीजें बाहर आ जाएगी. One more question they have asked you, where these neurotransmitters are formed. This is going to be formed in the, this is also important, ribonuclear proteins are going to be there. They are responsible for the RNP or ribonuclear proteins which are present in the cell body. They are responsible for the production of neurotransmitter. This is exam question they have asked. ये बनता कहाँ पर है, एसिटाइलकोलिन कहाँ बनता है, तो यहाँ बनता है. और आता कहाँ से एसिटाइलकोलिन, you know about the acetyl coenzyme A, right? Your Krebs cycle, this is the same acetyl coenzyme A which is going to make what, acetylcholine, right? So this is going to be what, this is a neuron. Now what will happen, this acetylcholine is going to come out, and this acetylcholine will go to the synapse, right? Here you will be having what, here you will be having what, neurotransmitters are going to be coming here, and here you will be having what, action potential generation will happen, right? Here you will be having sodium entry will happen, and action potential will generate. That means cell will undergo depolarization, and after depolarization what will happen, this depolarized, let me make you understand here. So first of all, neurotransmitter will come. This neurotransmitter is going to be acetylcholine. It will generate what, it will generate the action potential in the muscle layer. This is going to be generating where, in the muscle layer. This is going to be what, nerve, right? So from nerve, acetylcholine is going to come out, it will activate your action potential, and now what will happen, due to this action potential, what will happen in the muscle, the muscle will start to have what, activation of dihydropyridine receptors, and this dihydropyridine receptor will bind with the ryanodine receptor, right? So this DHPR is going to bind with the ryanodine receptor, and they are going to do a mechanical change. This is not a chemical change. Important one is, this is a mechanical conformation. ये जगह change करेगा अपनी. This is a mechanical change which is going to, conformational change which is going to take place. ये ढक्कन खुलेगा, right? And now what will happen? Now sarcoplasmic reticulum will release what? Calcium. Now sarcoplasmic reticulum will release excess of calcium, and this is the calcium in the muscle is going to cause what? Muscle contraction, right? So this is the calcium which is going to cause what? Muscle contraction. This is how we are contracting our muscle. Pectin, myosin will come closer, tropomyosin binding will remove, they will come closer, and you will be having what? Muscle contraction. And after contraction, this calcium will be taken up by the sarcoplasmic reticulum. ये बाकी calcium ये फिर से ले लेगा, and you will have what? Relaxation of the muscle. So this is happening because of this DHPR and RYR, right? So what is this disease? This disease that we are having, this disease is known as malignant hyperthermia. In this particular patient, the disease that we are having is malignant hyperthermia. Basically what is happening in malignant hyperthermia, you will be having mutation of this RYR gene. RYR gene mutation will lead to what? Will lead to malignant hyperthermia. So whenever a person is shifted for cholecystectomy, he must be given some anesthesia. And if a person is having RYR, ryanodine receptor gene mutation, and he is exposed to succinylcholine or any inhalational agent, CO, ISO, DES, HALO, कोई भी inhalational agent से अगर ये patient expose होगा, he will start to have what? Activation of this sarcoplasmic reticulum, leading to what? Increase in the calcium release. And if this calcium release is going to be there, you appreciate, if there is going to be lots of calcium coming into the body, it will cause lots of chaos in the body, and this is why this person is going to have what? Lots of metabolism, leading to EtCO2 very high, and this condition is known as malignant hyperthermia. Malignant means non-cancerous, not cancerous, but it is dangerous, right? Malignant hyperthermia. Why hyperthermia? Because this calcium in the vessel, it will cause vasoconstriction leading to increase in the BP. In the muscle, it will cause muscle contraction leading to increase in the contraction, and in the cell it is going to cause what? Exocytosis, which will also cause problems, right? So this is why this patient is having what? Malignant hyperthermia. What is the treatment? They have also asked about the treatment. Treatment is going to be what? IV sodium dantrolene. So you are going to use what? Sodium dantrolene as a drug of choice for this particular condition, right? This is an anesthesia emergency that can happen in our OTs, right? So this is going to be what? Neuromuscular junction, right? You can also have some you can apply this information, you can have some diseases from the medicine, like we are having mutation of this voltage gated channel. This syndrome is known as what? Lambert-Eaton syndrome. Lambert-Eaton syndrome. If this think about it, if this voltage gated channel is not working, do you think this calcium is coming inside? It will not come inside. If calcium is not coming inside, do you think this acetylcholine will go and cause contraction? No. So patient will be having what? Some kind of muscle problems are going to be there. He is not able to do the contractions. This is known as what? Lambert-Eaton syndrome. This is known as Lambert-Eaton. Myasthenia is different, right? If you are having this, these are going to be your nicotinic acetylcholine receptors. These are your acetylcholine receptors. If there is antibody against acetylcholine receptor, if there is antibody formation against the acetylcholine receptor, then it is known as myasthenia gravis. It is the same spectrum, the symptoms remains the same, right? But this disease is going to have different pathology. What is going to be the problem? The problem lies here. This is known as Lambert-Eaton syndrome. If the problem lies in the antibody against this nicotinic acetylcholine receptor, this is known as what? Myasthenia gravis. This is going to become what? Myasthenia gravis. If you are having issue with this particular one, if you are having issue with this ryanodine receptor, this is going to become what? This is going to become malignant hyperthermia. Malignant hyperthermia. And if you are, if this person is taking what? Botulinum toxin, what will happen? This vesicles are not able to rupture, because to rupture these vesicles we require which protein? Snare protein, and this snare cleavage is not going to happen. This is going to inhibit the snare cleavage. So what will happen? Everything is okay. So this is okay, this is okay, but this acetylcholine vesicle is not able to rupture, and you are not going to release this acetylcholine, so there will be no further movement, right? This is known as what? Snare protein inhibition. You understand this thing, right? So this is going to be the single diagram telling you multiple things, right? This sign is known as what? This sign is known as Gover sign. I told you in the first question, this is going to be what? Muscle dystrophy patient, and this person is not able to stand up directly. This person is going to require the complete body support to stand up, right? This is known as what? Duchenne muscular dystrophy, where there is complete loss of dystrophin protein, right? Yes, it is going to be flaccid type of paralysis, right? Now, certain one-liners. RYR mutation will lead to which disease? RYR mutation will lead to which disease? This is going to be your malignant hyperthermia. This is going to be your malignant hyperthermia, right? During contraction, what happens to the H zone? Now tell me, contraction में H zone will contract or it will not contract? It will contract. It will contract or it will decrease in the size. What happens due to mutation in voltage gated calcium channels at NMG? This is going to cause a disease. This is known as Lambert-Eaton myasthenia syndrome. Lambert-Eaton syndrome, right? Multiple sclerosis is due to mutation in. Multiple sclerosis is due to mutation in what? There is a protein which is going to do what? Myelination. So this protein is going to be what? Myelin basic protein, and if you are going to have mutation in this myelin basic protein, this is known as what? Multiple sclerosis. Because this, you can simply remember, in the peripheral nervous system you are going to have what? Myelination due to, in CNS, you can remember, in CNS the myelination is going to happen because of oligodendrocytes. Oligodendrocytes are responsible, and one oligodendroglial cells is going to myelinate 30 neurons, right? Whereas in peripheral nervous system, this is done with the help of Schwann cells. Schwann cells, and this one Schwann cell is going to do myelination of this one neuron. S for Schwann cells, S for single neuron. One Schwann cell will do it for the single neuron. But sometimes, you know what happens, this is also a recent case, you can remember, we are having one bacteria and one virus. One bacteria, that is Campylobacter jejuni, one virus, that is going to be your Zika virus. These are the organisms which can cause what? Which can cause damage to these Schwann cells. How? This virus or this bacteria will enter into your body. Like you remember the Pune case that was happened a few days ago, right? So in Pune, what happened? The outbreak happened. The person was eating what uncooked or raw chicken. What happened? This person will start to have what? Diarrhea. First, this person will start to have diarrhea due to Campylobacter jejuni, and what will happen? This person has taken antibiotics, and what happens? Or antibodies are formed in the bodies, and because of that, what will happen? This jejuni is getting killed. But what about the antibodies? These antibodies are going to be formed against this Campylobacter jejuni, will start attacking what? Schwann cells. They will start attacking Schwann cells, and when they will start attacking Schwann cells, what will happen? They are not able to do the myelination in the peripheral nervous system, leading to a disease. What is that disease, beta? अगर myelination नहीं होगा तो movement नहीं होगा. If movement is not going to be there, very good, shabash, Harish. This is going to be what? Guillain-Barré syndrome. This is going to be Guillain-Barré syndrome, where you will be having problem with the myelination in the peripheral nervous system. What is the treatment? You are going to give IVIG, intravenous immunoglobulins. You are going to give to this particular patient, and this patient will be fine. Two entities for this Guillain-Barré syndrome, two organisms you can remember, jejuni and Zika, right? Jejuni and Zika. Jejuni can also lead to what? Not just diarrhea, it can also cause what? Dysentery, right? It is a bacteria that we are having, right? माइक्रो एरोफाइल बैक्टीरिया. जेजुनी नाम में ही लिखा है ना, जेजुनम में रहेगा, राइट? जेजुनम में कम ऑक्सीजन होता है. पाइलोरस में रहेगा, इट इज आल्सो अ माइक्रो एरोफाइल. So there will be also little amount of oxygen. Wherever there is less oxygen, these bacteria will grow, right? Aerobic bacteria will be present generally in the lungs, in the upper part of the body, because they need good oxygenation. And anaerobic will go deeper into the tissues because they don't need what? Oxygen, right? So this is important. Yes, it is going to cause what? Ascending paralysis. I'll teach you further. Okay, last topic we are having is about the central nervous system. What is the central nervous system is going to be about? Let's try to understand this thing. So we are having C and S. You need to understand about the nerves. What are the nerves classification we are having? They are asking questions based on this. So what are the basic classification we are following? This is known as Erlanger and Gasser classification. Earlier we used to have what? Earlier we used to have Lloyd and Hunt classification. Lloyd and Hunt classification we used to have. Now we are following what? Erlanger and Gasser classification, right? So what is this fibers we are having? We have got different fibers. Let's try to remember these fibers. We have got A alpha, A beta, A gamma, A delta, B and C. These are just like the wires, right? These are just like the wires. Let me show you. These are just like the wires that we are having, right? So this is a wire that we are having which is myelinated. Myelinated matlab kya ho gaya? Some wires you see, some wires are going to be slow charging, some wires are going to be fast charging, hai na? आजकल फास्ट चार्जर्स आ रहे हैं. सो दोस वायर्स विच आर फास्ट चार्जिंग मीन्स दे आर माइलिनेटेड. जस्ट थिंक लाइक दैट, राइट? सो बेसिक फंडा ऑफ माइलिनेशन इज गोइंग टू बी व्हाट? द मोर द माइलिनेशन विल बी देयर इन द न्यूरॉन, द मोर द माइलिनेशन विल बी देयर इन द न्यूरॉन, द फास्टर द न्यूरॉन विल बी. है ना? एक चीज मैं आपसे पूछता हूँ, some questions you are able to answer very nicely. What is the drug of choice for erectile dysfunction? All of you will answer me that it is going to be what? But if I ask you what is the drug of choice for amyotrophic lateral sclerosis, you might get confused because this is not a myelinated neuron. But the sildenafil neuron is going to be a myelinated neuron because you have read this thing multiple times, spoken this thing multiple times, told it to lots of people, or maybe your name itself, right? If someone will call you, you will suddenly go back and look. Why? Because it is a myelinated neuron. We will also ask our patient every time, first time we are going to take the name of the patient. Hey mister, what is your name? Like that. Because it is a heavily myelinated neuron, and the more the myelination will be there, the faster the neuron will be there, right? और ये myelination कैसे आता है? Repetition, revisions. More the revisions, more the myelination will be there, है ना? एक चीज को बार बार रिवाइज करोगे, myelination हो जाएगा, वो फटाक से रिकॉल होगा. कभी कभी रिकॉल में प्रॉब्लम आती है, नॉट एबल टू रिकॉल, दैट मीन्स डिक्रीज इन द माइलिनेशन, डिक्रीज इन द न्यूरोट्रांसमीटर, डिक्रीज इन द levels of neurotransmitters is going to be there, right? So it's not so difficult, it's very simple. You just need to go through the same thing multiple times, automatically it will be in your mind, right? कोई गाना सुनते हो अपने आप याद हो जाता है, राइट? बैठ के थोड़ी ना याद करते हो, यू जस्ट गो थ्रू इट मल्टीपल टाइम्स, इट विल बी इन योर हेड, है ना? पढ़ाई भी ऐसे ही है, बार बार पढ़ना है। आई टोल्ड यू इन द स्ट्रेटेजी सेशन ऑल्सो, आई टोल्ड यू जस्ट हैव टू फ्लिप थ्रू द पेजेस, नो नीड टू मग अप। ऐसा नहीं है कि ए अल्फा है, ए बीटा, बोलते जाओ, जस्ट गो थ्रू द मूवमेंट मल्टीपल टाइम्स, इट विल बी इन योर हेड, याद रहेगा, याद भी हो जाएगा, right? So these are the fibers we are having. The fibers we are having: A alpha, A beta, A gamma, A delta, B and C, right? What is the mnemonic that you need to remember? Prime Minister pressurized to sign the contract fast. The same way you have to remember, Prime Minister pressurized to sign the contract fast, right? So these are going to be the fibers. What is the fiber with the maximum diameter? सबसे बड़ा कौन सा है? A alpha. It is going to have maximum conduction velocity. सर सबसे fast कौन सा होगा? A alpha होगा, because it is the biggest one. The biggest one is going to have the maximum conduction velocity. उससे छोटा A beta, then A gamma, then A delta. Slowest is going to become what? C fiber. So they can ask you certain questions, specific question. They will ask you what is the most fastest fiber or fiber with the maximum conduction velocity. Your answer will be A alpha. The fiber with the least conduction velocity or slowest conduction velocity is C fibers. The fiber which is going to be responsible for proprioception or motor function, the answer will be A alpha. Pressure and touch is going to be A beta. Like we are doing massage, what is that? This is going to be what? A beta activation, right? For fast pain, this is going to be A delta. For slow pain, this is going to be C fiber. What is this fast and slow pain? How your body will understand this thing? Let me make you understand. आपका दिमाग कैसे काम करता है? How you will perceive the pain, right? So let me give you basic understanding. Suppose I am taking injection, tetanus का injection लगवाया. When you are going for a tetanus injection, first time you are going to have what? Pain. When you are injecting someone, you are going to have a pain. This pain is going to be what? Fast pain. कैसे पता चला ब्रेन को फास्ट पेन है? बिकॉज दिस पेन इज कैरिड आउट बाय ए डेल्टा फाइबर्स. ऐसे फाइबर्स है बॉडी के अंदर. सो ए डेल्टा इज टेकिंग अवे द पेन, दैट मीन्स इट इज गोइंग टू बी फास्ट पेन. फिर अगले दिन मॉर्निंग में टिटनेस के इंजेक्शन के बाद में यू विल बी हैविंग स्लो पेन इज गोइंग टू बी देयर. दिस इज ड्यू टू सी फाइबर्स. सो दिस इज गोइंग टू बी व्हाट? स्लो पेन, राइट? So we have got these fibers. A beta is for the pressure and touch, right? Which is the fastest, which is the slowest, we have already seen. Another question they are asking is for the susceptibility towards the pressure and hypoxia. So you can remember these important key points. Susceptibility towards the pressure is going to be A are more susceptible, followed by B, followed by C. For the pressure, for the hypoxia beta, B are more susceptible as compared to A than C. Right? So least susceptible is going to be what? C fibers. They are going to be autonomic fiber. अपने आप चलते हैं, right? So this is going to be the basic understanding. Now I will make you understand what are the receptors we are having. बस इतना ही याद रखना है इसमें, right? They will ask you simple question. Fast pain is carried out by. Answer will be fast pain is carried out by. Fast pain is carried out by. This is going to be what? A delta. Slow pain is carried out by C fibers. Okay. Pressure and touch is carried out by A beta fibers. You see why we are doing massage. Every time you are having pain, what you will do? You will try to press it. You will do massage. Pain is going through which fibers? Slow pain via C fibers, fast pain via A delta fibers. When you are doing the massage, you are activating which fibers? Pressure and touch. You are activating which fibers? You are activating which impulses, right? You are activating your pressure and touch is going to increase the overactivity of A beta fibers, which will diminish these two, which will decrease the sensations traveling from these two fibers, automatically leading to pain relief. You understand? This is not a treatment. This is just you are bypassing something. You are not letting your brain know that I am having pain. You are just doing some massage. This is how it is happening, right? Now let me make you understand this particular thing. What are the different touch receptors that we are having, right? The first one we are having is going to be our Meissner's corpuscle. They are responsible for gentle tap. They are abundant in lips and fingertips. Second one is going to be Merkel cell. They are responsible for braille reading. Very important point I am marking. This is responsible for braille reading. Those people who cannot see, they can also read with the help of this braille method, right? Pacinian corpuscles, they are the largest deep capsulated fibers. And Ruffini's nerve ending are responsible for the skin stretch and vibrations. They are present in the joint capsules. So now let's try to understand how these fibers are going to assess what is the current and how we will understand what is happening in our body. So we can have ascending tracts. These are your ascending tracts. We can have descending tracts. So whatever information is going into head, suppose this is the cross section of my spinal cord I am presenting in front of you. So information in your brain can go through via three pathways. This is your dorsal column, this is your anterior column, this is your lateral column, right? So we can have information going up. Up means from the spine to the brain. This is known as spinothalamic tract, right? So you can have anterior spinothalamic tract, you can have lateral spinothalamic tract, you can have dorsal spinothalamic tract. The information from the brain can come to the body. This is known as corticospinal. From the cortex to the spine, corticospinal. You can have lateral corticospinal tract, you can have anterior corticospinal tract. The first thing you need to understand, these type of wires are there in your spinal cord and they are responsible for this transport mechanisms, right? So what is the spinothalamic tract? From the spine to the thalamus information is going. This is known as spinothalamic tract. What are these dorsal column pathways? These are going to be on the posterior side, है ना? तो सिंपली कैसे याद रखोगे? You can simply remember, लात पड़ेगी तो क्या होगा? Pain and temperature. When you will get kicked, lateral pathway is responsible for the transport of pain and temperature. Whereas this anti wala pathway, anterior pathway, is responsible for what? Light touch, crude touch, and pressure and sexual sensation. Right? So this is going to be what? This is going to be anterior anti wala pathway, right? Then you are having fasciculus gracilis race. कहाँ से लगाते हो बेटा? Race via legs, right? So it will take the information from the legs, and cuneatus, from where you are going to eat something, this is going to be from the hands. So this is going to take the information from the hands. So ये सारे pathway कैसे बेटा? Ascending. Ascending is also known as from the spine to the thalamus. Thalamus मतलब ये information कैसे जा रही है? अगर मैं यहाँ पिन चुबा रहा हूँ, let me give you one example so that you can appreciate this thing better. Suppose I am having a pin, I am going to pinch it here. How this brain is going to understand कि यहाँ पर पिन चुबाया है और दर्द हो रहा है? Or maybe you are taking the RBS, random blood sugar sample, right? So when this thing is going to be touched, what will happen? Look here. What will happen? This is going to take the information via which fiber? Fast pain है कि slow pain है? Is it going to be fast pain or slow pain? This is going to be fast pain. So which fiber will be bringing this information to spinal cord? This is going to be A delta fiber. A delta fiber will bring the information to the spinal cord. So I'm talking about the pain and temperature. So this is going to coming via A delta fiber. When it will come to the spinal cord, now the spinothalamic tract will come into action, right? From the spine, the information will go to the brain. So this is going to be which type of pathway it is going to be using. For pain and temperature, lateral spinothalamic tract will be working. So here the information will come into lateral spinothalamic tract. It is responsible for pain and temperature. And which type of fibers will be activated? A delta. So this information which is going to the thalamus, now this thalamus will understand something is coming via A delta fibers and it is coming via lateral pathway. So it must be what? It must be pain, right? It must be pain, right? So it will send this particular things into the post central gyrus, where you will be having what? Sensory strip is going to be there, and in sensory strip you will be having what? Somatosensory area, and this motor homunculus will be there, right? This homunculus will be there, which has got a representation of the complete body. यहाँ पर ये sensory strip होगी and motor strip होगी brain के अंदर. You will be having central gyrus, या थोड़ा आगे और थोड़ा पीछे you will be having these strips, और इनके अंदर पूरी body का representation. Here you will get the representation. These are your fingers. So this information, this pain information will come to where? In the middle finger, and you will understand what? This is the pain which is happening over here, and this pain is due to what? This pain is happening in this particular area. So this is how you will understand how this pain is happening, right? So this pain is going to be reaching this area, and now what will happen? This motor tract is going to send some information, and these fibers are going to come from the motor tract. These fibers are going to be the fibers. They are going to come to the spinal cord, and they will drive the information to the body. और अब body क्या करेगी? हाथ को पीछे खींच लेगी. This is how this information is going to be there. So whatever neuron coming from the head till this particular area, they are known as upper motor neuron. From the spinal cord to the body, they are known as lower motor neurons, right? So these are the neuronal pathways that we are having, and you understand how do we assess what we are thinking, right? Now the next question we are having is about the 26-year male patient presented to ER department with the symptoms of stroke. He was on antihypertensive drugs. He was not able to speak out the words, but understanding is intact. Damage is in the Brodmann area number 44. So where does this Brodmann 44 is going to be there, right? What is going to be there? Aphasia, very important topic. So what is the aphasias we are having? We can have Broca's aphasia, we can have Wernicke's aphasia, we can have arcuate fasciculus problem, we can have angular gyrus problem. Let's try to understand what are the changes which are going to be there and how this thing is going to happen, right? So what are the changes you can have in the aphasias? First thing you need to remember, we are having this particular centers. This is going to be your frontal lobe, this is going to be your temporal lobe, right? Whenever you are speaking, whenever someone is speaking, you are hearing, and all this information is coming to the temporal lobe first. This is going to be the Wernicke's area, that is for the understanding. This Wernicke's area is for what? Understanding the speech. तो पहली बात समझ में कहाँ से आएगी? You are able to understand me because you know my language, and you are able to understand because this information is coming to your Wernicke's first. Now from the Wernicke's, some area, some fibers are going to connect this particular area to the Broca's. Simple, remember, Broca बोलने के लिए, Broca is for the speaking purpose, and these fibers are going to be what? Arcuate fibers, which are going to be connecting both these two areas, right? तो यहाँ से connect होगा, and now you are able to answer. Suppose if I'm asking you something, you are able to understand because your Wernicke's is intact. You are able to speak if your Broca's is intact, right? And you are able to repeat the sentence if this arcuate is intact. This is what you need to remember, right? So Wernicke's area is present in the superior temporal gyrus, right? Area number 22. This is going to be area number 22, and it is sensory speech area that is responsible for what? Understanding and comprehensive, right? You can have lesion here leading to what? Fluent aphasia. The person will be having what? Problem with the understanding. This person cannot understand. Whereas this Broca's area is located in the inferior frontal gyrus, and it is going to be present in area number 44, and it is responsible for what? Motor speech area, responsible for the word formation, speaking, right? Whereas this arcuate is connecting the both. If this arcuate is missing, what will happen? The person can understand, person can speak, but he cannot repeat the sentence. So here you will be having difficulty in repeating the words, right? Because conduction is problem, right? An angular gyrus, it will connect your visual area. Sometimes you just read the lip sync and you can identify what the person is trying to convey, right? Why? Because your angular gyrus is going to be there, and the aphasia is going to be what? Anomic aphasia is going to be there, right? If all are not working, this is going to be your global aphasias can be there, right? So in this particular case, they have already written what? They have already written the area number 44 is problematic. So if area number 44 is problematic, what is going to be there? It is going to be non-fluent aphasia. Simple understanding, right? Yes, right? These are the reflexes that we are having, right? Stretch reflex, inverse stretch reflex that we are having. These are going to be important, right? What you need to understand, whenever you see the keywords, you try to answer the question very nicely, right? If they are asking about a muscle stretch reflex means it is a monosynaptic reflex, like we are doing deep tendon reflexes. We are checking whether this particular spinal cord is working properly or not, whether this cycle is okay or not, or there is a lesion in between, right? So we can have myotactic reflex. Muscle stretch you can identify. Suppose I try to lift this weight, I can lift it easily, right? So contraction is going to be there. But if this weight is going to be 100 kilogram or 500 kilogram, am I able to lift it? No, it is going to get relaxed, right? So this is going to be what? Inverse stretch reflex. Stretch reflex is a protective reflex, whereas this one is inverse stretch reflex is a protective reflex, and this is going to be what? Stretch reflex, which will cause the contraction हो जाएगा, right? So what are the fibers that you need to remember? अगर क्वेश्चन में दिया हुआ है मसल स्पिंडल, you need to mark what? Stretch reflex. If in the question they have written muscle contraction, stretch reflex. If relaxation is written, then it is inverse stretch. If Golgi tendon organ is written, because these tendons are going to be there, these tendons are going to be there, they will assess the pressure और बोल देंगे कि नहीं मेरे बस का नहीं है, छोड़ दो. You will leave this particular weight. So this is going to be what? This is going to be Golgi tendon organ inverse stretch, right? Here it is going to be polysynaptic, bisynaptic also. And ultimate function is going to be what? Muscle relaxation, right? Prevent muscle damage from overloading. Whereas here it will maintain the muscle tone and posture, right? This is going to be monosynaptic. This is going to be poly or bisynaptic. Here alpha motor neuron is activated, it is inhibited. In simple words, if you will find some keywords in the question, what are the keywords? Whenever you see tension, what you are going to mark? Inverse stretch reflex. Whenever you see Golgi tendon organ, tension or tendon, this is going to be inverse stretch. Wherever you will find stretch or spindle, muscle spindle, this is going to be stretch reflex. Muscle is contracted, stretch reflex. Muscle is relaxed, inverse stretch reflex, right? A protective reflex, inverse stretch. Monosynaptic, stretch. Polysynaptic, inverse stretch. So this is what you need to remember. This is pretty good enough to solve questions for you, right? The last thing we are having is about the thalamus. What are the thalamus we are having? So we are having thalamus, we are having hypothalamus. Thalamus and hypothalamus are going to be what 3D kind of structures. So we are going to have what different problems with the identification. So we need to look at these important things, है ना? इसको थोड़ा imagine करके करना है. This is how it is going to be there, or maybe you can remember directly. So we can have what ventroposterolateral nucleus, VPL nucleus. This is responsible for what? Somatosensory information. I told you everything will go to your thalamus first. Spine से thalamus में जाएगा, फिर thalamus से सब जगह जाएगा. This is going to be what? Somatosensory information will be there. We can have ventral anterior, ventrolateral nuclei. This is for what? Motor function. This is a previous year question that has been asked in your FMG examination. ये पूछा गया है. Motor function के लिए कौन सा nucleus है? Anterior group of nuclei is responsible for what? It is concerned with the memory and emotions. These are going to be the memory and emotions. Medial geniculate body, M for M, it is responsible for the music. So music means it is responsible for the auditory information, whereas lateral geniculate body is responsible for light. L for light, it is responsible for what? Vision. It is responsible for what? Visual pathways, right? These are your common hypothalamic nuclei. Very important topic that we are having. These hypothalamic nuclei, you can remember, at least you need to remember anterior and posterior hypothalamus. They are concerned with the thermoregulation. You can imagine a car, and the car will be having what? Engine in the front. So you can remember anterior hypothalamus is responsible for hot thermoregulation. It is responsible for hot thermoregulation. You can imagine a car, the same car will be having diggy on the back side. So posterior hypothalamus is responsible for the cold thermoregulation. So if they ask you, these are the important ones. If they ask you about shivering, shivering is what? Hot thermoregulation or cold thermoregulation? What is going to be your answer? Shivering is controlled by anterior hypothalamus or posterior hypothalamus? You can also remember some mnemonics like soap. This supraoptic nucleus for ADH, paraventricular is for oxytocin. These are some mnemonics that you can remember. Let me just try to make you understand what are these important ones that you need to remember. We are having multiple nucleus, and this is also a 3D structure. This is same thing we have seen, right? This is your hypothalamus. Above that will be thalamus, and below that will be anterior and posterior pituitary. Hormonal part we have seen in the endocrine system. Total how many hormones are coming, beta? Tell me how many hormones are coming. This is the same thing we are discussing. Yes, cold is posterior hypothalamus, right? Okay, so we are having arcuate nucleus. This is responsible for what? Prolactin, growth hormone release. These are going to be arcuate. Pre-mammillary for social behaviors. Mammillary body is important. The important one, let me mark. This is for the learning and memory. Learning and memory, this is going to be mammillary body. It can get disrupted in which disease, right? कब ये खराब हो जाती है? Mammillary bodies can have problems, and person will start to make some false stories, also known as confabulations. This is going to be what? When do you find this confabulations? In which patients of having disease in mammillary body, right? Paraventricular nucleus is responsible for what? Your cardiac rhythm, your stress response. These are going to be your paraventricular nucleus. Posterior hypothalamus, BP regulation, as well as your regulation of the cold temperature, right? Dorsomedial is responsible for your circadian behavioral, right? Your food intake. Ventromedial hypothalamus is responsible for what? Glucose metabolism. Your specific sex related behaviors are going to be there. Lateral hypothalamus is responsible for, again, food intake, your reward system. Here you will be having what? Dopamine pathways, dopaminergic pathways are going to be there. Nucleus accumbens is going to be there, important one, right? Anterior hypothalamic nucleus is responsible for what? Thermoregulation. What kind of thermoregulation? We have already seen, right? Supraoptic nucleus, we have seen for the parturition. We are having important one, right? Suprachiasmatic is for the circadian rhythm, at least you can remember, right? Tuberal for nucleus is for the food intake, and preoptic is for the sleep. Important functions are going to be there, right? So these are some nuclear part that you need to remember. Hypothalamic nuclei, they have asked 2-3 questions till now. hypothalamic nuclei, right? They are important. Now you can solve this question. Stretch reflex is due to what? Stretch reflex is due to what, beta? Stretch reflex is due to what? Muscle spindle or tendons? So this is going to be due to muscle spindle. Muscle spindle, it is going to be monosynaptic, right? You just need to go through the table once. You will be able to remember all those things, right? Ventral anterior and ventrolateral nuclei of the thalamus has what functions? This is going to have what kind of functions? This is going to have motor functions are going to be there. This is a previous year question, has been asked previously. Decrease in speech output is seen in which type of aphasia? कहाँ नहीं बोलेगा person? This is going to be your Broca's aphasia, non-fluent aphasia, Broca's aphasia, right? Emotions are going to be generated where? This is going to be generated in the limbic system, right? And they are controlled by frontal lobe. They are controlled by the frontal lobe, right? So we can assess this thing, right? They are generated in the limbic system, controlled by the frontal lobe. Subthalamic nuclei will lead to what? If you are having damage to the subthalamic nuclei, this is going to cause what? Hemibellismus. This can cause what? Hemibellismus, which is a sudden contraction of a large joint. This is known as what? Hemibellismus. Hemibellismus. And this shivering is going to be controlled by, the shivering is controlled by, shivering is cold thermoregulation. It is controlled by posterior hypothalamus. This is controlled by the posterior hypothalamus, right? So these are the important points that I want to convey, right? Thank you so much for all the patience, guys. I know it took me a lot of time, right? We did not expect that, right? But yes, we are done with the most of the important topics that has been asked previously in your examination, and I hope you will be able to solve this particular questions which are going to come in your exam, right? Lastly, we have the quote, nobody can go back and start a new beginning, but anyone can start today and make a new ending. Those of you who are having doubts that we are not able to do it, is it really possible to do it? Yes, you have to put your hard work, but yes, definitely it is going to pay off, right? So this 30 days can decide the rest of your life, है ना? आपके 6 महीने 30 दिन में decide हो जाएंगे. So it depends what kind of hard work you want to give. Lots of money you can save, lots of time you can save. Time is the real money, right? So lots of things you can save. Just put your efforts. एक बार 100% दे दो. Self doubt आना is okay. You are going to find certain things कि होगा नहीं होगा क्या होगा. Those things are going to be there. But एक बार के लिए 30 दिन devote yourself. Whatever we have read, just go through these things, right? You can find all the PDFs. I will share in my Telegram group also. You can connect with me. Any doubts, कुछ भी है, कोई issue नहीं है. You can come back to us. You can ask us, and we will be definitely more than happy to help you guys, right? But the ultimate thing, we are going to pass this particular exam with the good marks, है ना? Flying colors के साथ में पास होना है और बहुत अच्छे से पास होना है, right? So I'm glad you guys are still here, right? Thank you. I might take derma in the end.